Well, good morning, everybody. Welcome to cool, sunny Houston. Apologize for having, especially the out-of-town folks, coming into Houston when it's 106 degrees today, I think, is the temperature. Now, we typically would not hold our conference in August. We used to hold it in March or April, but that was BC before COVID, and we're trying to work our way back. We held it for the last couple of years in January, and my board said, well, let's do it in the spring. And for those of you that have put on conferences before, to finish one and then get into another one the next day, I said, well, let's kind of work towards that. So I don't know when it will be next year. It won't be in August, I can tell you that. So again, appreciate that. We've got, unfortunately, with the medical center, folks take their time getting into downtown here. We have about 140 registrants here, and it's a nice mix of employers and providers. So without any further ado, I wanted our board chair, Ted Barrell, to officially welcome you. Ted is Director of Benefits and Compensation for the Friedkin Group. So he's a really great board chair. I'll tell you that. I've been blessed with that, with Ted and his predecessors. So Ted,
Well, as Chris said, we're expecting to fill the house, but now we have an intimate audience. So I would like to thank all of you for being here today. Lots of familiar faces. Looking for the clicker. Chris, what do we do with the clicker? Oh, good. Okay. Well, you can do it for me. That's good. Yeah, so lots of familiar faces and some new faces too. So we really, really appreciate you being here. Chris will go over the agenda, but before he does, I'd like to say just a few words about HBCH, about our program today, and most importantly, maybe how you could get a little bit more involved in what we do at HBCH. So, as you know, HBCH is an employer-centric organization. And to paraphrase and to plagiarize, we are focused very much on the triple aim in employer benefits. That's improving on cost, quality, and, as we know, the essential element, consumer experience. And we do this on behalf of our employer members, but really it's the larger community, and now even Chris, I think we could even say the state of Texas. And very importantly, it's kind of really important to point out, we're doing it for the employers, but it's our employees, it's their family members that participate in our plans, because ultimately that's the focus. So one of the ways that we accomplish this mission is to encourage and introduce innovation and creativity. And today's just an amazing example of that. I think I'll be proved correct once you hear the speakers today. And another thing that we do, which is absolutely critical, is we have some very targeted initiatives that are aimed at changing the market. Big deal stuff. Some people call some of these did someone say moonshot? I don't know. But big ambitious projects. And Chris will talk about those. You'll hear more about those from the speakers. A couple are legislative advocacy, where we had some great success this year in the Texas legislature. Our SMART network, hospital price transparency. These are big things, and they require change, as I said. Change is uncomfortable, especially when you're talking to your friends in the marketplace. It could be uncomfortable. It's not always easy, and you can't do it alone. No employer, the HBCH, cannot create fundamental change in the marketplace alone. But we know we have to, right? Again, kind of cliche, unsupportable ever-increasing healthcare costs. That's the impetus. That's what we have to deal with. So we have to work together. We have to work collectively. We have to work as a community. So I'd like to do a little exercise, again, with our intimate audience. And if you're an employer in this room, raise your hand. If you are a consultant or a broker, raise your hand. If you're a service provider, you have a point solution, healthcare provider, raise your hand. Ooh, lots of you guys. We like you guys. We rely on you. So look at each other, because you're the community. And everybody, oh, if I missed anybody, raise your hand too. I'm sorry. You're the community. You're the group that's needed and can create that change. So thanks for being here. So a little bit about the program today. Our program today, you are going to see a lot of speakers and presentations and panels. And most of them are going to be talking to you about an opportunity or a problem that they work together. Employers, advisors, service providers work together to solve that problem and create an opportunity for their health plan. And what I would like to ask you to do, a favor to me, Sam, there will be extra credit for this. I'd like you to make a note. If you're a note taker like me, that's not going to be a problem, but mental note if you're not. Make a note of what looks like a problem that you have that there might be a solution for. What do you think might work for your environment? And getting to that customer experience, do you think you could engage your members in that kind of solution? Oh, I didn't do my slides. That's my community slide. So make a note of those things. So at the end, I will be working with a very impressive gentleman, Francois, who will be working with me. There he is, Francois. To do a conference wrap-up. And so I'm going to ask you to share your list. Share your list of notes of things that might work for you, because I think we can all benefit from each other's perspective. So now I'm going to remember my next slide. This is the most important one. This is our impressive group of board members, and I should be able to do this extemporaneously, but I don't want to have to turn around. So these are our board members, and many of them are here today. So I'd like to ask you to raise your hand. So I don't think Sarah Costa is here. Sarah Costa, Harris County. Dan Burke from Turner Industries, made the drive in from Louisiana. Thank you, Dan. Denise Crandon, HISD. Katrina Daniel also drove in. Hey, Katrina, welcome. TRS. Amanda Jones, Harris Health System. Heidi McPherson, UT Health. Stephanie Myers, Goose Creek ISD. Karen Rakers, I saw you, Karen, way in the back. Hey, Karen. Next Level Urgent Care, not just urgent care. And Jen Roberts, hello, Heart. Jen, good to see you here. Carrie Rust, Elwood Group, and Cecilia Sheeran. Hey, Cecilia, Novo Nordisk. So, I'd also like to call out, we all know Chris. Chris is our executive director. Sam may still be in the room. Sam is our operations manager. Can we get a round of applause for Chris and Sam? Thanks for that, because they put in the blood, sweat, and tears that made today's event possible. So thanks for that. So we may look like a pretty big group, but we are always looking for more involvement from our members. We need your input. We need your creativity. We need your energy to achieve the missions, the efforts, big and small. So if that sounds interesting, or you just want to learn a little bit more, pull any one of us aside. Pull any board member, Chris, me, Sam. We would love to talk to you about that. We will have plenty of time for anyone who wants to engage in that conversation. So Chris, I'm going to turn it back over to you. Thank you, sir.
So just a few minutes and we'll get rolling here. Did Representative Frank make it yet? So as Ted said, just to put this into perspective, it's together. I mean, that's the key here of what we're trying to accomplish. And I just wanted to, for a moment, tell you again the four major things that we work on. Hospital transparency. How many know about the RAND hospital price transparency studies? Most do. We think there's room for improvement. Employers typically are paying about 250-some%. The median price in the Houston market for hospital services is 316% of Medicare. Is that reasonable or not? I think we're just looking for, and what you're going to hear today are folks who are looking for other solutions here. You see, as told by employers to employers, all of these, save one, are going to be examples of folks who are doing direct contracting in the context of their PPOs. We've heard so often we can't do direct contracting. Why? Who said you can't do direct contracting? Every single one of these employers is doing some form of direct contracting in one way or another. Again, hospitals are critical to our infrastructure, but we also think there's a value proposition that needs to be addressed here. Legislative advocacy, I'll mention that in a second. You'll hear about our smart purchasing network at the end of the day. Educational programming, and last and certainly not least, we serve as the employer voice for the community. As an example, we're working with the Center for Houston's Future to put on a forum actually here on October 23rd that's focused on equity. So these, I just wanted to point out, these are our main areas of emphasis here. There's a couple things here. Just if you don't know the Wi-Fi, it's Rice Visitor. There's no password required. So I'm sure most of you have already figured that out. You can, where do they, how do they scan that? If it's, do they scan it here or, pardon?
With your camera on your phone.
Oh, okay. There's space for calls or meetings, room 106, which is out this way if somebody needs that. You can see about the visitor exhibits. Any more to say about that, Sam? Folks have, you just stop by.
On your badge, you have a QR code. If you pull up your LinkedIn, you can just scan it with your LinkedIn scanner, and that will connect you from a networking perspective. So everybody's badge, for the most part, if I could find your profile, created this connected to your personal LinkedIn. So just pull up LinkedIn, scan or rescan, and that will connect you to everybody here or networking, that sort of thing. Outside of that.
Okay. All right. Fair enough. And the reason I say about the scanning, we can't hold these conferences without support from our members, sponsors. So these are our strategic partners. I won't go through the whole list. You can see them. The point that I would make is on your phone, if you go to the, if you scan it, you'll get our website, and if you click on any of these, there's more information, PDFs, little videos, contact information for any of our supporters. So these are our strategic partners, our conference underwriters, many of whom are exhibiting here. Encourage you to stop at their booths. Our panel sponsors for discussions here, and our exhibitors. So that's why I wanted to make sure you were able to get to the website from your phone and can get some more information on our sponsors. I'm not going to go over the agenda other than that you can see it here. You have it in hard copy, you have it on your phone. We'll be close to sticking to it here. We've got a little bit of slush time here as we need it. But the point I wanted to make again is you're going to be hearing primarily from employers. And when I interviewed and we had our sessions here, they know that I'm going to be there, not with a hook, but it's going to be interactive. But we want you to hear from the employers and why they're doing what they're doing. So it's a busy day. And then we're going to end, by the way, we'll be going to the Hilton rooftop. It's in the shade. They have some cooling devices, but it's a really nice setup. We've got a piano player as well, a little entertainment. So we hope rather than fight the Houston traffic or wherever you got to get to, you'll spend some time visiting with us. Okay? There is a slide that was taken out of here. I don't know what happened to it. But one of the way I say it from the employer end, even if you don't attend our events, if you're not part of our SMART network, we think we add a lot of value because of what we do behind the scenes. One of those is we set up a C4 called Texas Employers for Affordable Health Care. If you go to our table across the way, you can learn more about that. But that's focused on legislative advocacy. We had a real win this last legislative session, in no small part due to the gentleman that's going to be coming up here in a minute, Representative James Frank. But he's going to be talking to you as an employer today.
Well, good morning, everyone. Thank you, Chris. Yeah, we'll this is in good hands, right?
That's right.
We got this. So I want to thank you for inviting me to moderate this panel. I love the title that you gave it. It's a perfect timing for employers to take action. We've got some important legislation that has happened and is in the process that I think is helping us, and employers can kind of take that as a catalyst to move forward, maybe advance other legislative regulatory efforts, and then through contracting and partnerships where we can advance the work that we're doing. So I'm Katrina Daniel. I'm the Chief Healthcare Officer at the Teacher Retirement System. It was kind of funny. I was thinking, what bucket do I fit into? So we're one of the largest purchasers of healthcare in Texas. We're probably second only to the Medicaid program. We have nearly 750,000 lives. And I will say that with as many lives as we have, and Representative Frank and I've had this conversation, as many lives as we have at TRS and that we're contracting on behalf of and providing benefits for, we have a hard time really moving the needle in the industry. It's hard to get enough traction in one market to really move the vendors, the carriers, the PBMs. And so I think trying to find innovative solutions that we're aligned on, moving together, working with innovative and thoughtful policymakers like Representative Frank and those at the federal level is really important. So let's introduce our panel, and then we'll jump into the discussion. So I'll start with, on my right here, we have Representative Frank. He's from Wichita Falls and represents that area in the Texas House, and thankfully represents us too, because he himself is a small business owner, and we've had some fun conversations about issues in purchasing healthcare for your employees, trying to provide them good benefits so that they're not concerned about their health of themselves and their families, and you're sort of thwarted when you're trying to do that. And so we're going to talk about some innovative legislation that Representative Frank filed and shepherded all the way through. I think you had 100% support in the House, like no...
We had 100% support on the floor, with a lot of behind the scenes on both sides trying to get it stopped.
I mean, that's how it goes, right?
You couldn't vote against it publicly, but...
Well, we'll talk about that.
Yeah.
That's some of the fun part, and it just shows your savvy as a policymaker too.
Oh, yeah.
All right, and then we have Dan Burke, who we thought wasn't going to be able to join us. We're really thankful he's here. So super helpful. He's with Turner Industries and has his own innovative approaches to purchasing healthcare for their employees and providing them innovative benefits. Then we have Stephanie Myers from Goose Creek ISD. We've worked off and on over the years with active care and healthcare purchasing. And so Goose Creek, it's interesting the mix we have here. So we have private sector, public sector, TRS is public sector, Goose Creek obviously. And so the collaboration that we've had on finding ways to move the needle in the industry and really improve benefits. We want to hear what you're doing, what's on your radar. And then finally, we have Elaine Britt from right here. Thank you for hosting us at Rice University. And you have had an interesting circle as well. You've been at Rice and then out in the consulting arena trying to help other purchasers, other employers find innovative solutions. And then you've brought that experience back to Rice. So I want to thank all of you for being here today. And I hope that what we can do is have an interactive panel. Chris has given us an hour. So we can certainly fill that with conversations about how to catalyze change. So I kind of want to kick off right away with House Bill 711.
Okay.
That has been very helpful in Texas. I think, we're looking forward to more change as a result of the work that you've done. So maybe give us a flavor of what inspired you to file that bill, and if you want to give us some of the behind the scenes, then everyone loves to hear that stuff too.
House Bill 711 just removes about 4 different anti-competitive behaviors that the big insurance companies and big hospitals use to keep your prices up. And really, the bill now outlaws them. Gag clauses, steering and tiering, most favored nation, and one other that didn't come to me right now. But it's practices that almost all of us would consider unethical. Now they're illegal. It will actually only benefit if employers take advantage of it, because the market only works when people are taking advantage of a market. So I think it is good that it passed. This savvy legislator was able to pass that, but I got beat on about 4 other bills because there is a whole lot more money trying to keep healthcare costs up than there are people engaged in getting healthcare costs down. That's a lot of nodding right there. A whole lot more money spent trying to make sure healthcare is twice as expensive in this country as it is in the rest of the first world, or the same or worse results. That's embarrassing because as employers, we're the ones that are buying it. It's an employee benefit and we're paying twice as much. So instead of actually paying our employees money, we overpay for our health care. And we got a bill passed. I am excited about it. Don't mean to deadpan it, but it doesn't matter unless it gets taken advantage of. And there's a whole lot of other bills that are not passing because of the money spent against them. But I'm not without hope, because we did get a very good bill passed, had a nice coalition, including Houston Business Group. Chris did a great job, got other people involved. So I think there's at least starting to be some awareness of the overpricing of medical costs. How's that?
That's terrific. Well, you're right. When we talk about public policy, changing regulatory requirements or bringing in new regulatory requirements, change is incremental. Yeah. And so it's not a surprise that a number of the efforts that you undertook are going to take a little more work. And I think, groups like us can come together and help support some of those changes. What do you see on the horizon? And then I'd like to kind of get some feedback from the panelists about what's important to you and impediments that you're seeing.
Well, and I'll try to be real brief because I really do want to get to them, but I think from a big picture standpoint, Chris knows I always do this, the healthcare is expensive because it has no real market forces. To have a market, you have to have transparent pricing. There's no transparency. You don't even know what your broker's making. You don't know what they're passing back and forth. Hospitals, nobody wants to tell you what they're making. We make laws starting, 8 years ago. You have to be transparent. Most of the hospitals still aren't doing it because the penalties aren't big enough. Even if you have complete transparency, in many cases you don't have competition. If you have transparency without competition, you just know how bad that you're getting taken to the cleaners. If there's only one place to go, that's what I say in a mixed crowd. But you just know how bad you're getting taken advantage of, and your employees are overpaying. And then the last but not least, you have to have employees that actually care. You have to have customers that actually care how much something costs. Not to tell on you, but I'll use my TRS example. Like TRS, one of the biggest employers, or ERS is also one of the biggest employers. I had a procedure, we paid $82,000 for a procedure that in the state usually costs around $30,000. I asked why, and the answer was, well, because you have to have that hospital in network, and they know it. And by the way, there was no incentive for me to go anywhere else. I could have had the same procedure. Really, it was a fairly minor one-day procedure. It should have been $30,000. I had no incentive. One of the biggest employers in the state still gets taken advantage of, and their employees waste money because of that. That's not an insult to you, by the way. Those are the rules. Almost all of these are rules. Almost all of those are rules that we as policymakers make in trying to protect people, but the system does not work to protect people in that regard from a cost standpoint.
Absolutely true. We've talked about this. The area of the state where you're from is one of the more high-cost areas of the state. And we struggle, like the comment I made at the beginning, as large as we are, have a hard time using our leverage to bring down pricing. Let me shift to Dan for a second. I'm just going to go down the row here. I know you drove in from Louisiana, but you have employees all over. And can you talk about some of the impediments that you see to lowering your healthcare cost, and what do you see on the horizon?
Absolutely. Well, first of all, congratulations to the state of Texas and Representative Frank for passing House Bill 711. I wish Louisiana would head down this path, but Louisiana is notoriously political. We'll see where that heads. And one thing that I want to talk about is the impact of healthcare costs on the everyday employee. So Turner Industries, we operate in the oil and gas space. Our employees maintain and build refineries for the most part. And they will jump from Turner Industries to Zachary to Fluor, one of our competitors, for another $1 an hour. They'll just go. And if we're spending $10,000 a year on their health care, that really impacts what we can do from a compensation point perspective, especially as we're trying to be profitable as a company as well, right? So if we can bring those costs down, we can pay our employees more, we'll keep them around, get more business, and that's it's a very naturally functioning market. Some of the impediments we're seeing, man, I could go on forever on this. And first of all, Katrina, I will try not to be discouraged by your news that TRS can't impact the market, but it's alarming to hear
I'll
that.
say not as much as we'd like.
Not as much, okay. Well, and that's the benefit of collective influence, right? And it's great to have Katrina on the board of HBCH and join the rest of us because they are a huge heavy hitter in the state of Texas, and it's great to have them with us. But healthcare is very local. We understand that. We have to focus locally. Here in Houston is very different than in Dallas or in San Antonio or Wichita Falls. So you have to be aware of that and address things locally. Some of the impediments that I'm seeing, a lot of it is political. Folks in the C-suite that have relationships in health systems or insurance companies, that's a conflict of interest, but it happens. We struggle with that. Health literacy is an impediment for us. If we have some incentives in place to encourage folks to go to lower cost facilities, removing cost barriers, half of them don't know they exist. So it's a matter of communicating things. There are just so many layers to the problem. Rather than being discouraged, though, I think we can view it as opportunity. And seeing all the folks in this room kind of committed to making some positive change to benefit employers and businesses and individuals, it's exciting. So I'll have the glass half full approach.
Well, Dan, we're going to talk about the impediments first, but then we'll come back and pivot to what we can do together to help impact some of those issues. Well, let me shift to Stephanie. So you and I know a lot of the same pains and a lot of the same areas where we think that there is opportunity for improvement. So Goose Creek, you guys are a fairly large employer in your area, and we've talked a little bit about, I know, some of the challenges that you guys have had. You participated in active care, and then now you've decided to self-fund, and embrace what Dan was just talking about. Try to address the local impact of healthcare for your employees. Can you use that local momentum to make a difference there? And so talk about kind of what you see on the horizon and some of the impediments that you found, and thinking that we're going to come back and talk about what we can do to make some changes as well.
Right. So good morning, everybody. I can tell you that a lot of it is cultural change and shift. And so with our organization, one of the things we looked at was being innovative and being a foundation and a game changer, and really going out to the market and developing a different approach, but also providing accessibility and affordability for our employees. But it really goes back to a lot of the things that Dan was just mentioning on education and making sure that your employees are aware of what's available and what they can do in the market, how their plans work, and then the facilities that are available, because we know that facilities drive costs as well as pharmacy and those kind of things. And so making sure that they have the best resources and tools available to assist them.
Great. Well, Elaine, you are also in education. You're in higher education. And among the panelists, you have a little bit of a different view, because you have been in the employer's shoes where you sit now, but you've also stepped into the consulting world where you're helping other employers. With that broader landscape, what are your observations?
So it's interesting. I actually want to bring a different perspective. Having in-laws and parents that are aging, I think I mentioned my mother is a retired teacher. My mother-in-law is a retired Turner employee. So, I have a lot of connections here through parents. But, these are people that are using the system, as they should. And one thing that I've found that's really interesting to me is, and I think it's driven by the legal system, right? The potential for lawsuit. So you have someone that has an issue, and what happens is, instead of saying, well, I'm sorry you got dizzy, let's monitor it and see what happens. Instead, they order every test on the book. Let's rule out every single thing. And I've seen it's like a money grab, right? You come with a diagnosis, and all of a sudden, no, let's run this test and that test and go right next door to my MRI machine, and that's where I feel like education comes in, because as patients, we need to ask, is that really necessary? Do I have to have 50 tests and the same test over and over again? Does this make sense? So asking doctors questions, understanding incentives, why are they wanting me to get all these tests? I think that is also part of the equation, and how to get people to challenge. For so long, we've trusted our healthcare community, as we should, but now some of the motivations have changed. It's a financial incentive more than I just want to care for you incentive. So how do we get people to behave differently in that respect? I think that's a challenge.
Can I jump in real quick? I want to piggyback on something Elaine said, because it's really important. It's an impediment to change that the providers have incentives in place that will incentivize them to run MRIs and incentivize them to do things that are expensive. I had personal experience with this. Some of you may have heard this story before, but please indulge me. This was during COVID, so I'm working at home at my kitchen table. My wife's got her iPhone out. She's making an appointment with her doctor, and they want to send her for an MRI. And she's like, all right, well, just let's go ahead and get me scheduled. And I start waving my arms. I'm on the other side of the room. And she puts it on mute. I said, tell them we have to find a place to get that MRI done. It may be with them. It may be somewhere else, because our benefit plan has an incentive in place. If you go to one of the 3 or 4 low-cost imaging centers, you'll get a check in the mail. So it could be $25, it could be $500, depends on the service. So she pumped the brakes on that and ultimately got the service somewhere else. I had that experience at a doctor's office. I had jacked my fingers up, dislocated a finger, fell off a scooter. That was a long story. But I walk out from my orthopedist visit, and the nurse wants to schedule me for an MRI right away. And I said, well, I've got this insurance plan. It requires that I shop and do that. And it was as if I told them I was never coming back, and they won't get $1 from me ever again. And it was, oh, okay. And it doesn't give you a warm, fuzzy feeling as a patient when you run into that. And it's just how we've gotten here after 75 years of the employer-based system. The incentives that are in place lead us to this place.
You mentioned the word required because I think it's awesome that a plan actually encourages that. But the plan actually allows you to shop. It doesn't really require, like it allows. And that's, when I look at the issues here, it really has come down to if you don't know what it costs, if you don't have competition, but if your patient is not engaged, and obviously having some incentives gets you engaged, but it really is you mentioned a cultural change. It's a cultural change. Like we're scared to ask a doctor how much something costs. Like there's nothing else in the world that we do, and there's almost no correlation. If you look at any study, there's almost no correlation between cost and quality in healthcare. Almost zero. There's like almost none.
And honestly, most of the time, if you ask your doctor, how much is this going to cost?
Oh,
they don't
no.
even know.
Oh.
And if you ask a prescription medication, they want to prescribe something. How much is that brand versus another under my plan? I don't know. I mean, they really don't know. And so you have to wonder what their incentives are, or maybe it's they just don't have time. So the onus is on the patient, and we're the least educated people.
And I think that's the difference between clinical delivery of healthcare and the business of healthcare. And it almost makes me feel good that my doctor doesn't know what these things cost.
Well, it is, as long as that is the case and they're not earning any revenue from where they're referring you, which is another issue. We can put a pin in that. Well, so this is a great conversation. Many of the things that I want to talk about and shift back around and talk about solutions, but I want to turn to the audience and see if, as we've tried to unpack the challenges that we face, are there things that we've missed that are top of mind that as we shift into talking about what solutions we might look for that we want to throw into the mix. So I want to make sure we're engaging our audience. Yes, ma'am.
But I think the biggest issue is if they don't know where to go, that's how they increase the cost to the plan, because guess where they're going to go if they don't know where to go? They're going to go to the emergency room. Mm-hmm. The emergency room will take care of all the testing, all the extra stuff that they may or may not need. And as far as shopping or having incentives for MRIs, how do we, as employers, how do we communicate that? I mean, we have tools on a website. You can go and do cost estimates. Sometimes they work, sometimes they don't. But the average employee, especially in a public entity like we are, they don't know, okay, they're looking at the cost and they're looking at these different things that they can do, but how do they really use those tools? I think is a big portion of all of that.
Agree.
Totally agree. And one of the things that all of us struggle with in the benefits space is communication. That's everyone's number one problem. And healthcare is complicated. And if a person, I've been in this business for going on 30 years, if it's uncomfortable for me to deal with my doctor's office or my wife's doctor's office, how is a welder at the Shell refinery in Deer Park going to react? It's incumbent upon us as employers to do what we can to communicate things simply and break it down to financial terms that are easy to understand.
I think that's it. It's the financial incentives, right? So perfect example, my own child in college waited and waited. She was sick, waited until the weekend, 2 a.m. on a Saturday night. She's like, oh my gosh, my fever's 102. What do I do? And her roommate says, let's go to the emergency room. That's what you should do. Ugh. And she gets the bill. And she calls me and she's not happy. And I said, well, yeah, you shouldn't have gone to the emergency room, kid. And so, I gave her the education, here's Teledoc. Look, right here, you could have called someone, had a video chat Saturday afternoon, not waited until your fever spiked, and it would have cost you $40. So, and now she loves it. She's pulling up Teladoc all the time. I'm like, you don't need to go every week, kid. Like, stop it. But, you know, she's a little anxious. Anyway, but, you know, some of it is financial, and they're hard lessons, especially when they're low-income people, right? But you get hit once, and you think twice.
And I would say, from an organizational standpoint, it's really the education and creating those spaces for education, either getting with your marketing team and putting together notifications and flyers and sending things out of know when to go and where to go. But then also looking at just different components. At some of the organizations I've been at, I used to have a class called Benefits 101. So this is how your benefits plans work. This is where you can go, what you can do, what you need to know about your benefits plans, how much it's going to cost you, which plan you should maybe be on. So, you know, from high deductible to standard PPO plans or HMO plans, what makes more sense for your family and your organization and with the organization. And so really just doing those marketing and communication and education pieces also can help with the organization and your needs.
I think we've got 200 employees, and we switched to, I call it self-funded. It's really not self-funded because we have stopgap coverage. I would say it's fully insured with a $50,000 deductible. But we have changed the benefit structure such that it encourages them to shop. And we told them, because we had a $5,000 max out of pocket, and that's a big deal because we have mostly machinists, welders, and we have engineers and sales guys and that kind of stuff. But they are very smart if you put the right incentives in place, and we have a consultant that they can call at any time, and they know they can get $0 deductibles if they will shop their services. And guess what? They shop their services. It's not that complicated. But we actually did some things early on trying to get them information, but they had no incentive. Guess what? It didn't work that well because they're smart. Why do they want to spend their time to save me money? You know, I mean, they kind of want to. Some of them did, you know. But at the end of the day, if you set it up where they care, and now most of us have such high deductibles and out-of-pockets that there's a lot of ways to ensure where the plan wins and you win, and the employee wins. You know, it's gotten so expensive.
And some of the basic education, I think, is helping people understand when they use the plan, it's not the insurance company's money, right? They love to blame the insurance company, like, oh, who cares? It's just Aetna or whatever. So helping them understand, no, this comes out of our checking account every time you have a claim. So they're like, oh, yeah, really? So I think that helps incentivize them as well.
If I can walk down this road just a little bit, because Chris and I have had this conversation from an employer standpoint. You know, they're going, we need to get employers talking about hospitals. This, in my opinion, this should be set up, it's the employee's money, just like a 401k. You put it aside. If you're trying to save yourself money on your health care plan, then you're going to get the same conflict of interest that the hospital does when they're doing stuff. It's a bad thing, and your employees will not trust you. I think I have as much trust, I don't know about y'all's company, I have about as much trust with her too. You know, we're still pretty small, most everybody knows me. But we also set it up where, you know, when we switched from one of the BUCAs, we said, here, we're going to put 5% more money in here, but anything that's left over is going to y'all. So we're spending y'all's money, not our money, because we are just a fiduciary of it. And I truly believe there's a couple of reasons. One, I think it will work much better. Your employees will appreciate it more. They will trust you more. The second, from a political standpoint, nobody cares when there's an argument on the floor between Turner Industries and Blue Cross. If you are actually defending your employees and their money, we can win the political side of this. When it's one big company fighting another big company, eyes glaze over. Okay, but if people feel like they are getting taken advantage, or employees are getting taken advantage of, and they are, then we have a chance of moving the needle a lot more than if we talk about the employers and trying to save, you know, a percentage here or there, in my opinion.
Representative Frank, you brought up a concept that I wanted to hit on, and it's the kind of the next place I wanted to go in this conversation. So looking at the federal landscape and thinking about legislation there, efforts to let employers have more flexibility around requiring tiering of hospital networks and creating incentives in that way. Also thinking about the legal landscape where we're seeing lawsuits like the Kraft Heinz Aetna lawsuit where we're employers are increasingly looking at what role does the carrier have? Are they really acting as a fiduciary on our part, even though you may have that in a contract? What opportunity do we see there for creating incentives for the carrier, who is that more direct touch point with the employee on their health benefits than the employer? What opportunities are there to create incentives between the employer and the carrier to help us solve the problems? I'll throw that out to our panel. I don't know, Elaine, I'm sorry to put you on the spot. I just know that, with that consulting mindset, that you're watching that legislation, what's going on in the legal landscape, and what are your thoughts there?
Absolutely. I think the hardest part as employers is we are fiduciaries. The reality is everybody else we work with, they are not fiduciaries to our plan. And so there are always questions. How is this operating? What are you doing? Why are you doing it? A great example in the consulting world, I had a smaller employer that was self-funded and had a NAP network in the background. And that network claimed to save 30% on all, out-of-network claims. Well, an MRI came in for over $20,000, and we got a report back that said, "Isn't this great? You're only paying $15,000 for this MRI." And I thought, what the heck? That is terrible. You should be paying $2,000. And so we got into this big debate about the incentives they had to, quote, save money for the plan when they weren't really, it was all, nobody was saving money. And in fact, they were gaining a percentage of the savings from that, which was ridiculous. So, looking very closly at how your plan operates can be very tedious, but you can uncover some things sometimes that are a bit scary.
I mean, when we looked at it, you mentioned the word fiduciary. I don't think you can look at yourself and say you're a fiduciary if you know you're paying twice as much as it should cost, and so you're going to go out and shop 3 insurance companies and you're going to pick one of the best. You're paying twice as much as you should than if you would go direct. I mean, I looked at our plan and I felt like we were spending over $1 million, and I felt like less than half of it, really probably about half, was actually going to people that were actually taking care of the employees. The actual drugs, the actual doctor, or the actual hospital, and we talk about overpriced hospitals, but then you have all these others, the PBMs, all this stuff going through, and I think unless you ask about the carriers, I don't know that there is hope for the carriers, because the carriers are so perversely incented as well. When you really boil it down, it's like, do you have incentives to drive costs down, or do you have incentives to pretend that costs are high? The incentives are everything. It is not real. I mean, we make it tremendously complicated, and it is in a way, but in a way it's very simple. What does stuff cost? Are you competing for it? And does the person actually getting the service care at all how much it costs? You look at simple things like even a copay. A normally structured copay doesn't encourage somebody to shop. It just encourages them to defer something they probably need. They don't care whether it costs $40,000 or $20,000. They just decide whether they take it. That's crazy structure. It's a crazy structure. It incents you to have people stay sick, or they're going to go ahead and go to the place with the valet parking. I shouldn't say that. But because we do want, I mean, really, the quality matters a lot. And again, the price and quality, thank you, Julie. I saw my chief of staff's over there, and she hates that line, because I like, really, you do want quality, but it's not based on price.
Yeah,
so.
I had that argument years ago with an employee that went to a very expensive local freestanding emergency room, right? And he's like, but it's so nice. They give you a little clock and some juice. I'm like, next time you need to go, call me. I will drive and bring you juice if you go to the cheaper place, because it's ridiculous. We were eating the cost, but he got juice.
Expensive juice.
Very expensive.
Very nice juice.
From the legislative perspective, and as a fiduciary, the Consolidated Appropriations Act brings this to light, that fiduciaries are responsible to act in the best interest of their employees and their participants. And there will be a brighter light shown on employers as fiduciaries as it relates to healthcare. And I'm old enough to remember back in 2005, 2006, when the Pension Protection Act passed, right? And that looked at 401k plans who were charging excessive fees and had non-competitive funds or they were self-dealing. The Pension Protection Act went after plan fiduciaries, plan sponsors, to get that stuff cleaned up. That's what the CAA is modeled after. We'll see if that happens, and it's a shame that we're at a point where the healthcare system has to lean on the heavy hand of government to handle some of those things, but that's kind of
But in
where we're
fairness,
at.
the healthcare system has leaned on government to protect them at every stage of the game. We literally can't import drugs from other countries. We passed a bill in the House this year or in the legislature to import drugs from Canada. Why does that matter? Why are drugs that are made in the United States selling for 4 times more in the United States than they sell for overseas? Competition. But you have an FDA that doesn't allow importation of drugs. Like there's a lot of people in Canada dying from bad drugs or from Europe. I'm not saying we import them from everywhere, but it is protectionist at every turn.
And look at the recent initiative to negotiate drug pricing at Medicare, right? That, the lobbyists, talk about the people, the money, the lobbyists pushing against that. It's huge.
There were 2,500 lobbyists that showed up in D.C. for that. 2,500. There's only like 500 of them. It's like that.
How many
It's,
legislators
are
are there? Not that
there's
many.
400
Yeah.
and some, 435.
It's no wonder it feels like it's
Yeah.
a hard hill to cross.
Yeah.
Let me ask,
Hard to get a restaurant reservation that week.
for sure.
The alcohol was flowing. Yeah.
Can I see your hand? I want to ask one quick question of the group here. Who self-funds in the audience? And who is in an insured plan? So overwhelmingly self-funding. Okay, great. I'll go Ken and then over here. Oh, well, here.
Yeah, thank you.
I appreciate all the things that you've said and strategies, but I work for the city of Plano, by the way. One thing that we're getting killed on that I just don't think transparency works with is the large claimants. Because, yes, we can shop on MRIs, yes, we can shop on planned procedures, but the vast majority of our spend is coming from large claimants. You can't really, and frankly, you don't want to shop for where's my cheapest cancer treatment going to come from, or I just have all these things going on. I end up in the ER for 3 weeks and I have this crazy high bill. Have any of you had any success in managing that aspect of your spend? Because it seems like while we're getting better on, providing alternatives and taking care of things on the MRIs, on the less expensive things, it seems like it's getting worse on the high-cost claimants, and there's really no incentive for that member, because who cares if it's $1 million or, $100,000? They're going to hit their max out of pocket, so they don't care at all.
At least on our plan, they can have big claims and still never pay out of pocket as long as they are doing the shopping. And I do think on the big claims you have to shop. And frankly, you have a lot of incentives in some of those places, whether it's cancer treatment or whatever, to treat more and more and more and more. There's not much in the way of minimalist to stay inpatient, because you make a lot more money on inpatient than outpatient, yet most people don't really want to be in the hospital. So I think you can do it with incentives, because again, most of it, and we only have, we have 200 employees and there's probably 5 to 6 high end. Most of them don't pay a dime out of pocket until they decide that, hey, we're going to do whatever we want, wherever we want. But there is incentive all along. And really, those are the ones that are somewhat most excited. I'm almost hoping people don't find out and try to start, every high claimant comes to work for us or something like that. But I think you can still do it with proper incentives and communication. But I just want to pop on one thing. When somebody says self-insured, I really hate that word, because most of y'all are not self-insured. You may be paying the claims yourself, but you have some back-end protection. And frankly, if you have insurance, I was in business 25 years with a fully insured plan and never had a year where I didn't pay more in premiums the next year than whatever I had in claims. So you're getting a 1-year loan with a 20% markup. You are not fully insured. They're just making money on every dollar you pay out in claims, but they're not really insuring your risk, in my opinion. You may disagree, or we may have some insurance people here.
Oh, I completely agree. If you have stop loss, there's often a 30% markup on that. So
Yeah.
you're not really saving yourself from those claims. It's just smoothing out the cost and a 30% load for doing that.
Yep.
I want to add one thing on the high cost. So I do agree, a lot of them are not preventable. There's cancer, there's, that's going to happen. I just learned we have a patient at Rice, an employee, who is going to have over $250,000 of claims for an eye drop, but it's going to prevent her from going blind in that eye. So how do you quantify that? Like, blindness is significant, so is it worth it? I guess there's no other choice, right? Should those eye drops cost that much? That's a whole other question. I would say no, but again, they're pricing it based on the value of what you're getting, which is not necessarily, to me, that doesn't make sense. But back to your point, if you look at your high dollar claims, I almost guarantee there are a few in there that are sepsis, right? Sepsis is infection gone wild. I argue that some of that is preventable. How can you educate people not to let themselves get to the point where their body is shutting down because of infection, right? Did they wait too long? Did they, some cancer can be caught early. Again, we have people that put their head in the sand. They wait until they're doubled over in pain before they go. So there are preventable things always in your high dollar claims, but how to get to people and educate them before they're in the hospital and before they're $1 million.
So a couple of things. On the cancer front, one thing that we've seen, we're headquartered in Louisiana, we're in Baton Rouge. We're lucky to be within 4 hours of MD Anderson, right? It's one of the best cancer care centers in the world. And what we've seen is that employees will want to take advantage of being geographically close to MD Anderson. We'll drive over and get care, but it's expensive. And they can get that care within an hour of their home in Louisiana. So what we've seen happening over the last several years is folks will come over to MD Anderson for the diagnosis and the treatment plan to get treated locally. Really good outcomes, lower cost. And that's not a benefit design thing. That's just something that has taken place over the course of time. Sepsis. Glad you brought that up, Elaine. We, on Turner's plan, and Chris and I have had this conversation, we have seen a number of sepsis claims over the last 2 years. We had a gentleman in the hospital for 3 months at the start of this year with sepsis. He lost 4 limbs due to this infection. It's crazy. We have identified a hospital in the Houston metro area that is a high flyer when it comes to sepsis. It was almost a half dozen, 4 to 6 claims there at that hospital. We let our people in the market know about that. We created a hospital value scorecard based on outcomes, based on cost, and based on patient experience. So high cost claimants will happen. We call them lightning strikes, right? Sometimes they happen. We had a couple of hemophiliacs on the plan. Those are expensive, but to Elaine's point.
That's also what insurance is for.
It is. That's what insurance is for. If the eye drops are $250,000, keep someone from being blind, okay. That's the right thing to do.
Ken, I saw your hand up.
We need another mic.
Yeah. As a recovering insurance executive, for those of you who know that I used to run insurance companies, I very rarely defend the insurance companies, okay? It's just like, they are part of the problem, okay? I will say that. I was part of the problem. But what we haven't talked about a little bit is the issue that insurance companies make bad deals with hospitals and other providers because the employers require us to do that. And I still remember.
Meaning we want everyone in the
Yeah,
network.
you want everybody in the
That
network.
yield.
And
That is a yield.
it's like, you know, probably offend somebody here. Sorry if I offend. But, you know, there are two really good children's hospitals in Houston today, Memorial Hermann Children's and Texas Children's, and both great institutions, great physicians, and all the rest. At one point, I was involved in negotiations with Texas Children's and Aetna, and saying that we might drop Texas Children's out of the network because they were being unreasonable in their pricing demands, and we had another children's hospital. You know, I was going to lose my job as the head of network if that happened, right? It was like, you got to take the best deal you can get because, well, I'm trying to think. I can't even think of the right way to describe this, but employers' unwillingness to work with us on this and stand up to some of the price pressure out there. And I think that's one of the things, when I think about a perfect timing, you know, is this the timing where employers, now that we have better transparency, can actually say, we're not going to take it anymore? Or are we there yet?
That's a really great point. Transparency, and I was looking at this slide while we were talking, so I'm thinking about House Bill 2090, the all-payer claims database that has been gaining momentum in Texas,
But didn't get funded.
but didn't get funded. That's
So the
right.
bill passed, it's just not going to be implemented.
It's
Speaking
been,
of ways to kill things.
I will say it has been underway, but yeah, it was going to have that next level support, and it had a lot of momentum and then fizzled out at the very end. But it is something that we participate in at the teacher retirement system, and we work with other large state agencies that are purchasers of healthcare, and it does give me some hope that we can provide more information to, you know, if you can't get every employee on your plan to understand the incentive structure in your benefits, maybe we work with the employers to get more employers to be savvy about what they're buying, give them the courage to make those decisions around network. I see Chris standing. Is this?
Yeah, well, just to stay on time here, we need to cut this. But, you know, I don't know if folks were looking at this while listening. These were wonderful speakers here, and I thank everybody for being here. And James, I was sweating, you know. God, I hope he gets here. But
I was sweating too as I was trying to make it through Houston traffic.
Yeah, no,
From hobby.
I get it. But as you can see here, this is the perfect time and the segue about employers collectively doing something is the way things are going to change. We can't change the state. We can do certain things in the Houston market. You can do certain things in your market. It truly is local, and it requires a collective of employers. Transparency is here to stay. You know what else is here to stay? Lawsuits. And I was mentioning to Ann Cook, I'm going to be going around the state here in the next month to different cities talking about House Bill 711. One of the folks I'm bringing with me, her name is Chris Deacon, who's very well known nationally. These suits are happening. There's a dozen of them where the plans are being sued by the employers for breach of fiduciary responsibility. But as someone on the panel said, they're not the fiduciary, folks. It's your C-suite that is the fiduciary. You can see that the CAA requires attestation. I don't know how many folks know that your C-suite people have to sign off that you know all of your gag clauses are no longer there. You know exactly what is being done under the table. It's just, this is the tip of the iceberg, and we're going to see a lot more of these lawsuits. And the employers, they're actually, I can't remember his name right now, but the guy who was the feared name in the 401k lawsuits is recruiting employees now of these companies to join in these class actions. So it's just, we don't want to have that to make the change, but the change is coming. And the employers really have the opportunity and perhaps the upper hand right now, but as Representative Frank said, this doesn't do anything if the employers don't act. So I think that's a good segue to thank these folks. James, did you have a?
I just want to hit his point, because you're right, the insurance company has perverse incentive as well. And there is no reason for them, they cannot take that person out of network. But if the employer does it and says, we're doing it to save money for us,
Yeah.
you're going to lose. I'm all of a sudden going to have, you know, my wife, or if you're a female, going to have a baby at a place you didn't want to have it. But if you're just saying, no, it just costs more there because they're charging us more, everyone understands that. Everyone understands that, but we don't set it up that way. And so if you just look at the incentives, it's an incredibly complicated system until you actually just set it down and say, who's incented to do what? Because that's what's happening.
Yep.
Sorry.
All right, so I want to thank these folks, and Katrina, thank you so much for moderating. Great job.
Good job.
So just want to thank these folks. Next is just one of many case studies in which the employer said, I'm mad as hell and I'm not going to take it anymore. And so I'd like to invite our next speakers. Where's Brent and Peter? This is great. Come on up here, folks. This is a really good discussion here. They'll handle it, but I've known Peter. Peter was the CEO of the Maine Business Group on Health. He, prior to that, though, was head of benefits for Hannaford Foods. He's going to tell the story, but this is what is just a perfect example. I respect him so much in his mission to make a difference for his employees, first and foremost. So here you go.
Well, good morning, everybody. Glad to be here. Glad to share. Great conversation we just had. So I think what we're going to do is I'll give a little bit of background of just me, and then we'll kind of move into sort of a case study or a story, and then we'll kind of talk about how maybe, you know, there's been sort of a call to action this morning around purchasers really doing something, and so we'd really like to kind of talk a little bit about that. So a little bit about my background. Chris just shared it. This is the third time I've retired. I was the director of benefits at a supermarket chain in the Northeast, which is actually HEB, which was here, was part of an innovation group that we participated with. So it's a small world. I was there for about 25 years, and I was the director of benefits. I retired from there and actually moved to Castlight Health, which was really one of the early adopters of transparency around quality and cost and helping people making good decisions. I retired from there. And as Chris referenced, I was a co-founder of the sister alliance, or we're an alliance, this is a coalition. Very similar mission and direction. We were multi-stakeholder. We had employers, health plans, systems providers, employers. Much like this, in the prior panel, about half of our membership is made up of public pay. Maine's a pretty small state. There's only 1 million of us. But we had all the state, we had the state employees, we had all the teachers, all the municipalities, and then businesses. So I'll talk a little bit about that. And I did want to talk about that entity that I just described is about 1/3 of the commercial lives. We started off by having everybody under the tent, and we now have transitioned to something else. I came back, and I am now I just retired in June for the 3rd time. And I was the CEO of that. And I'll talk a little bit about what we were doing. I talk a little bit about the state of Maine. Maine has some of the highest healthcare costs in the country. It actually has a very, very concentrated market. 2 dominant health systems own 80% of the physician practices, and they account for 80% of the total healthcare dollars spent. So it's really kind of hard to we talked earlier about competition. So what I wanted to talk about is really kind of coming back to, we were a multi-stakeholder alliance. I came back and we really thought about how can we as a community come together and position or pivot to value-based care. When really we're looking for things that we could do, we selected 3 things as the alliance. One was the whole issue around affordable prescription drugs. We found transparent PBMs that were actually saving employers 50 cents on the dollar. That is about the spread that is being taken by the major PBMs. 4 PBMs dominate the marketplace. We put that in place. We had some difficulties with it because, as you had heard earlier, there is just tremendous perverse incentives in the prescription drug space. We put that in place, though, and some employers adopted it. We also adopted sort of the right sites of care, high-value sites of care. You heard a little bit about that this morning, about how do you incent members to go to the higher value providers. The state of Maine itself actually led the way. They tried to put that in place. I'll give you an example. Infusions in Maine done in the physician's office is $4,000. If it's done at the inpatient facility, it's $12,000. They put a design in place to really try to, incent folks to go to the physician offices. The major Bucca plan didn't want to do it. They ended up doing it, and then they have now introduced it into their products. So you can move the market. But the thing I'd really like to talk about is the Center of Excellence program and the partnership we have formed here that we'll talk about. But this is where the story will begin. And again, we were 20,000 employees. We were a self-insured plan, truly self-insured. We had no stop loss, so every dollar that we paid in claims came up from the bottom line. And for supermarkets, our bottom line's 1%, so it really makes a big difference. But the story was we really had a mantra, and we spent a lot of time educating our employees, but we really had this mantra of make sure patients get the right care, because in this country, about 40% of the time it's not the right care, the right either diagnosis and or therapy. 2, let's make sure you go to the right place, because where you go to get care can make a huge difference. If you look at Leapfrog, they rate hospitals A to F. If you go to a hospital rated C or lower, you have an 88% higher chance of not walking out of the hospital, which is just really significant. And then there's huge price variations that we can talk about, and we'll show you some data in a second. But in that, we actually had a person. We have a lot of retirees that work in our stores because they're in the community, it's a supermarket chain. They love the interaction with their friends and colleagues in the community. We had an older gentleman, probably well beyond the sell-by date of 65 for Medicare. And it violated all 3 of those things. He really should never have had a hip replaced in the first place. He had all sorts of other health-related issues. He went to the hospital in Maine that had the highest infection rate in the state at the highest price point. And the hip failed 2 times. He actually had 3 hip procedures. We are on the hook for $1 million. That's what the total cost was for those extended hospital stays. And under our umbrella is the Alliance. We asked everybody at the table, the health plans and the health systems, about, gee, is this right? Is there something we can do about this? And they really were not interested in the conversation. So I actually partnered with Aetna, actually traveled with Aetna's medical directors to several different countries. We arrived in Singapore. At that point in time, Singapore would do hip and knee replacements for $10,000. Our average cost in the state was $75,000. And not only would they do it for $10,000, they would warranty it for a year. So the real cost of a lot of these procedures are the complications. So we put a benefit design in place at that point in time. We came back, talked to our employees. We said, if you want to go to Singapore with a significant other, we'll pay 100%, we'll pay for travel, we'll get you over, we'll get you back. The employees were actually excited. Some of them said, I've never been out of the country on vacation. This would be great. I could go to Singapore, and a whole different story. We put a benefit design in place. And the interesting thing is the Wall Street Journal picked it up, and they ran an article about what we were doing. This is about 20 years ago, 15 years ago. The next day, as a benefit director, I started getting calls from other hospitals across the United States saying, we'll do this, because what we got was $10,000 a procedure plus the warranty. We actually had one of the hospitals in Maine call and said, are you really doing this? We said, yeah. They said, well, we want to play. And they actually came to the table. We put the benefit design in place. A patient didn't go to Singapore, but a lot of our procedures went to that hospital that stepped up. And not only did it change the price point and the quality, they actually re-engineered their rooms. They got all their providers together and patients, because in Singapore, it is around the patient. When you go to a facility, they have a whole suite outside where family and people can visit and other things. So, you can make a difference. So with that, I'll kind of segue that was our experience when I was the director of benefits. With the Alliance, we started looking at things and decided centers of excellence we wanted to pursue. We also realized with a 7-person staff, we have absolutely no medical credibility to decide who's a center of excellence. With that, we found a partnership with Karen. We started conversations, and I'll introduce Brett and let Brett talk a little bit about that and who they are and the process.
Thank you. They gave me one of these things here. So thank you, everyone. My name is Brent Nicholson, co-founder and chief partner officer here at Carum Health. We started the company back in 2014, really inspired by some of the homegrown employer direct contracting programs that Walmart and others were famous for that started 10, 12 years ago. And recognizing that there was some inherent goodness in the principles of those programs in driving more care to value, but recognizing that they're not scalable. And so what we did was try to say, well, why don't we try to create a scalable solution to achieve some of those same objectives? And so that became Carum Health. And what we ended up doing is saying, well, we are going to then go out into the market, find the best of the best providers, and so we run a quality evaluation methodology both at the facility level and down to the individual surgeon level, so that we're looking for the top 10% performance nationally. And then we will strike our own contracts for prospective bundled rates with those top providers. So that means that there is an all-inclusive bundle for an episode of care with a fully transparent and predictable price point. We will bring that on our platform. We will surround it with an amazing patient experience, with a human support and a technology platform, and then make this available to purchasers in the market. That was the idea behind Carum Health, and we felt that if we could do this, we could really achieve a win-win-win out there in the market. From an employer point of view, the ability to actually drive meaningful, tangible cost reduction by using these prospective bundle payment rates, and have transparency and predictability in your spend. From a member point of view, the ability to say, we are giving you a benefit to get you to the best of the best, and if you go there, we will cover it at 100%, right? So every client that we work with waives the cost share to the extent that they can, without infringing on HSA first dollar coverage rules, obviously, but providing that as an incentive for the member to then go to one of these top providers. And then the providers that participate in our program, they are receive preferential steerage, right? So they get more patients in the specialties and areas where they truly excel. And then with these bundle payments, they get 100% of the negotiated amount right away. So all of the time, effort, costs that they may spend chasing down the payer or the patient to collect the funds, all of that goes out the window. And so this is really meant to be beneficial for everyone. And so we've spent the last 9 years scaling this across the country, working with employers from California up to Maine, and some of the large employers that even did direct contracting solutions themselves, like United Airlines, found it to be difficult to scale, and then turned their Centers of Excellence programs over to Carum. And so you can also see some of the providers that we work with across the country. We've built this out so that we have regional access. We don't want people to have to get on airplanes and fly across the country for care. We believe that we can find top quality care in most major markets across the country. And so we've continued to build that out. And so, and then, I know the RAND Corporation was referenced earlier by Chris as doing a lot of work in hospital transparency. Carum Health was actually the subject of a RAND Corporation study where they said, well, we've done a lot of time studying the problem. Let's actually study a solution to the problem. And so they looked at Carum Health results data and found that for members that use Carum Health, we were able to avoid an unnecessary surgery 30% of the time. And then for the necessary surgeries, we were able to get them done with an 80% reduction in readmissions and complications, and also at a lower rate through our bundle payment arrangements to the tune of $16,000 per procedure, right? And so this leads us to kind of connect our story to Maine, because as we started talking to Peter and the team in Maine, the closest center of excellence that we had was in Boston. right? And so, we enter this kind of chicken and the egg argument or situation where what's going to be the first domino to fall, to kind of break the stalemate, because there had never been prospective bundled payments available in the commercial market in Maine at this point when we started conversations. So maybe Peter, if you can help us understand, how did we then kind of break that stalemate there in the market?
Yeah, and I think it goes back to the story I told that part of when I was at Hannaford, we tried to do it. We actually had health systems that would stand up and say, we don't believe an employer will dare to move care. We don't believe patients will move for care. So we don't need to participate in the dialogue. And so we kind of thought about that. And the key, I think you heard it, a theme of this piece will be, we as purchasers can move the market if we just demand more and stand there. And I'll use a good example. The state has been part of our entity, which was the Alliance, since its inception. And they actually have leadership that they will state articulately, and they'll state it publicly, that they understand they're using public taxpayer dollars to buy benefits. They think it's their responsibility to provide the best value benefits they can for their employees and families. They also think that they have a responsibility to use those dollars to make healthcare better for everybody in the state. So they really had a bigger principle of how can they use their purchasing power as a public payer to move the market. So, they had been with us, and we had partnered a long time as the supermarket, but they really believed in the value of power. They were an early adopter, member of Leapfrog. We were a member of Leapfrog. We had some of the most unsafe hospitals in the country. The state and the supermarket chain at that point came together and said, we will waive co-pays and deductibles if you go to the safest hospitals. And we did. Maine just accepted an award last year, the governor did, for the safest hospitals in the country the past decade. So there is ways to move the needle, and they decided they needed to move the needle on this because they were getting nowhere. They had asked their health plan to do it. The health plan wouldn't let them tier or drive care. So they really said, yes, this makes sense to do. We think if we say we're interested in this, they actually put it in place. And that really started the fact that it was there, really got the attention. And actually, they did send some patients to California for bariatric surgeries. So it really opened the door, and the main providers all of a sudden started to take notice that patients would move for care, that a major purchaser would move care to the higher value centers. And that really opened the gate where there was a health system that stepped forward. Yes?
Just real quickly, we're having a mic issue, and maybe it's just my presbycusis, but if you could either talk louder or we're going to try to raise the volume on the mic.
Oh, I apologize. So again, purchasers can move the dial. The state stepped up. They put it in place. The systems, one system in the state noticed it. They started to move a lot of their knees and hips to that procedure, in bariatric procedures especially. And to fast forward, that's been in place. I think you have some slides about their savings. And going back a little bit in the data analysis, which was our shop, when we started this process for the state of Maine, what was being paid for hip and knee replacements averaged from a low of about $15,000 to $80,000 for the same procedure. And that really, we talked earlier about, the best value for members. They were really, they really recognized that at $80,000, the patient's copay and coinsurances were a significant issue. So that's how we sort of started the ball.
Yeah, and really, we said, well, let's start with that Center of Excellence network that Karam already has, with the idea that we will then be able to, within a year, establish centers of excellence in Maine. And so the state actually was required through legislation, I believe, to send out letters to every hospital in the state, notifying them that they were going to begin tiering their benefits for certain surgical procedures. And so as soon as those letters went out from the state saying we're adopting Karam Health, we're putting benefit design behind it, we actually started receiving applications from these hospitals in Maine that had never done bundled payments before, right? And had kind of resisted in a way, saying we want to participate in the program. In our office in California, we started receiving binders that they actually printed out and laminated. It was very nice, that they sent all the way across the country to say, we want to play in the program. And so we were able to use that. That was like the first domino to fall, right? then this is how we can start moving a market, right? So then all of a sudden we were able to then apply our quality evaluation methodology to those providers and say, okay, where can we get the best value equation for our clients in the state? And so we were able to find a few partners that we signed contracts with. We were able to get them up and running in less than a year. And then all of a sudden we were able to provide a more local option to still adhere to all of the principles of value-based care that we strive for, but closer to home and within the boundary of the state of Maine. And that's where we started to see the results really come in terms of utilization of the program, really starting to build, and being able to see those tangible cost savings come in. This figure shows what the state had been paying in gray through their ordinary medical carrier. And then the bundle payment rates that Karam had secured in the state is represented in red. And so you can see for cervical spinal fusion, 32% savings. For hip and knee replacement, 28% savings, and so on. And so this was ultimately, every patient from the state of Maine that came through the program was saving the plan $15,000. But that's not really what it's all about. It's all about actually getting people better care by providing the right infrastructure and the right incentives to go to the top providers. And this is really the heart and soul of why we do what we do at Karam Health, and really just being able to deliver exceptional outcomes and exceptional experiences through comprehensive support and guidance offered by a dedicated care concierge that walks you through every single step of the program, and not having the financial toxicity of being buried by 15 medical bills after you're going through one of these procedures. And so we started hearing these stories come in from the state of Maine patients that they were really having exceptional experiences. And then that kind of motivated the next steps that the state wanted to take to continue advancing the cause here.
And I think two parts of that. So I share some of the other things that we had done that really hadn't moved the needle very much. This really moved the needle. A couple of real good examples is in one of the situations, Karam credentials not only the facility, but the actual surgeons. And in one case, a particular surgeon didn't make the cut, if you will, and actually wanted to understand why, and a year later had made the cut. They actually went back and learned from their peers about what they could do to improve the outcomes. So that helps move the bar for everybody. The second thing, which is really amazing, and it seems like such a small thing, the first patient that went through the program had a hip replacement, and there was a video done in her home, and she said it was just an amazing care experience, things that she had never discovered before. And she said it was an amazing care experience because, one, she was walking, I think, within a day. But more importantly, she said the surgeon that had actually performed the surgery called her personally and asked how she was doing. And so from a patient perspective, it has really been a much different care experience, which has been good. And so the next stage, they had such great success with it, they actually went to, it was voluntary, they could go, it was 100% paid, but they could still use their plan if they wanted to. They moved to a mandatory benefit for hips and knees to an ambulatory surgical center in the state. So it's really kind of changed the landscape, and it really has providers thinking and acting differently in our little local market. But it's a great example of how purchasers can do something that changes the trajectory of where we are.
And we're continuing to expand the program. We started with some of the lowest hanging fruit, which are the hip and knee replacement, spinal fusion, bariatric surgery, but we're continuing to expand the offering. And now we're bringing our program into oncology. So we're now, for the first time in the commercial market, have prospective bundle payments available with up to 2 years of coverage and providers that are actually on the hook through warranties for excision surgery, chemotherapy, radiation therapy, right? And the drugs are actually bundled into a prospective and transparent price. And so we're continuing to move the needle by adding more employers to the program, adding more providers to the program, expanding coverage to more service lines. We have providers that we work with here in the Houston market and in other areas around Texas. And so certainly would welcome any questions and opportunities to, raise a hand and continue to cast a vote towards more value in purchasing.
And just one quick thing. It's sort of like Mikey, the old cereal, but let Mikey try it. The other piece that happened, the state was the first employer that did it, and when it didn't blow up and it worked well, there were 4 other employers that have joined after that. So it really has it started the ball rolling to this is a different way to think about purchasing healthcare.
This is, any questions from the audience at this point on it? Because if not, it's not so much a question, but I've had more orthopedic surgeries than I care to admit. I abused myself as an athlete. And I had, in this market, using a few of the very recognized hospitals for orthopedic surgery. I know one, we talked about high-cost claims. I wound up with an infection after one of my knee surgeries. Wound up in the hospital for 2 weeks on intravenous antibiotics. This makes a difference in where you shop in terms of high-cost claims. Related to that, we're the regional leaders for the Leapfrog group here, which focuses on safety and quality. And I know Peter's involved with that, but we have on our website, the best hospitals. We created our own report card. One of the biggest issues that is prevalent right now is a rise in infections. Actually, infections, because there was so much adherence, went down during COVID. But they're the highest they've been in about 15 years. So this makes a difference. The point is, I assume if somebody wound up with an infection in one of your hospitals, because it happens, it would be covered, by a warranty. Mine was not. The plan had to pay for it again. Similarly, I have 2 artificial hips, actually 3 because of a hospital-acquired infection at one of our leading hospitals. I wound up having to, I needed that surgery again. That was not warranted. So I think there's a lot to be said for avoiding high-cost claims by some of this. But this is just an example of employers that are willing to, in the state of Maine, this was directly contracted, right? Is there still a PPO wraparound, or can they still use? So when I hear that employers can't do direct contracting, I'm thinking, where does that come from? Any employers have said we can't do direct contracting? Because we're going to hear from employers all day that are doing just that. And we think that is a solution. Any other questions? I can get around on my artificial hips and knees.
So if you're in an area that hospitals and doctors are very cliquish, it's sort of a big, small area, and they're very set in their ways, and it's really hard. We have gone to a directed care contract, but it's very hard to get them on board. How do y'all overcome that?
That is the million-dollar, if not billion-dollar question. And I think, at least in our marketplace, the way it works, they aren't going to really do anything until they need to, because it's going to impact revenue. And really, the health systems in our marketplace didn't believe that purchasers would actually do something and actually challenge them. And when they did, it really was an eye-opener. It really changes the conversation. So I think it's really, you need to kind of challenge them, and until they feel that there's something that's going to threaten their revenue and patient flow, that will start getting their attention. And actually, in our marketplace, I'll share 2 stories. There is a health system that didn't want to participate. They had some of the best, it was an orthopedic practice. They had some orthopedic surgeons that were some of the best. They really were high quality. And because of the transparency, they started to understand. They had no clue. They were getting like $1,400 per orthopedic procedure as a professional. When we shared the information that the health system was getting $65,000 for that same procedure, that was an eye-opener for them. They really started to say, is that the right share? Is there a different way to look at this? So I think information's important, patient's experience is important, but it really takes the purchasers, us that are actually paying the bill, to really start saying, we expect and want something different.
There was another question.
Just to answer your question, something I did back in 2003 with a university system that was in a more rural area. They were trying to get their local providers that were basically a monopoly in the area. We set the network rate at the rate we thought was fair, and then we reimbursed for out of network at a lower rate than what they could get in the network. And the balanced billing and the noise they got from their patients was so great, we eventually got them in at the rate we wanted them. So that's a strategy, is just penalize them for not being in there.
You know, and I think you heard it referenced earlier. I think the real game changer is the planned fiduciary, the CAA. It's going to be much harder now for plan sponsors to, I mean, in our state, we not only have the cost, but we have the quality. Again, I said it ranged from knee replacements at $15,000, which is one of the highest quality facilities in the state for that procedure, versus almost at $80, that is a very low quality. That becomes a real issue for a plan sponsor, that are they using benefits? They have personal fiduciary responsibilities. So hospitals are going to start engaging their board members and the community in a different dialogue. And I want to pick up something on Chris, and Brent can share it, that because the hospitals have the warranty, their level of readmissions and infection rates and other things are clinically lower than sort of the average. And we actually had, and this speaks volumes to some of the perverse incentives, we actually had one of the hospital CFOs in our community say to us, their purchasers, that they make 30% more revenue when there's a complication on procedures. So the whole issue about infections and using CPOE and other things, it's the revenue flow, that they make money when there's complications on a fee-for-service model. And so that some of those conversations need to take place. But I think from the clinical perspective, is that right, that the infection rates are low?
Sure.
Sure. Frances Monroe with Memorial Hermann. It was a great presentation. We're on the journey to moving towards value-based care. And I had a question specifically for Brent. As you were going on the journey to get these hospitals and providers to sign up with Carum Health, I would assume that you had several people, not want to or not be incentivized to. What did that journey look like, and how did you overcome that? You talked about price transparency. What other mechanisms did you use?
Are you talking about the provider side of the market? Yes. So I mean, it's really about. I think it's first establishing the environment that provides the right incentives. I mean, we talk a lot about incentive alignment, and so really just making sure that there's alignment on the value proposition of like participation in this program will ultimately yield, incremental volume, will drive down revenue cycle cost and effort. And then some of the providers that we speak with, need some enablement help. Like maybe they've never managed risk before. Maybe, they need to put some downstream contracts in place to be able to then, pass, part of the bundle payment to the physician or the anesthesiologist. And while that's not work that my company does, we can certainly recommend and know of others in the market to help with that enablement. And so I think it's really a combination of the willingness and the alignment around like the why should we do this, plus the administrative or technical capabilities coming together to then say, we have a model that can work for all sides here.
Yeah. And it takes a collective, I think, in a community, and that's what we're trying to do at HBCH, and we hope to be able to have enough belly buttons, if you will, to work and say, we need something better. We can't justify paying 316% of Medicare because of the impact it has on our employees and our families. So this is just one example of direct contracting, again, still within a PPO model, but it's not a fee-for-service offer.
Right.
So anyway, I want to thank these folks. I think the world of Peter, and I'm getting to know Brent over the last years. I just think they have a real good option here for employers. So I want to thank them for sharing time with us this morning.
Thank you.
I learned more recently about First Stop Health. So again, another direct contracting opportunity here. So take it away.
Great. Well, thank you, Chris. My name is Lisa Elder. I'm with First Stop Health, and as Chris mentioned, we are a virtual healthcare service. So we provide virtual urgent care, virtual mental health counseling, which Melanie is going to talk about today, that we have in place with Q2. And I also want to mention we do also offer virtual primary care, which entails navigation to the amazing solutions like Carum Health, or to high quality, cost effective providers that are in your network. And with that, I'll hand it over to Melanie.
Good morning. My name is Melanie Jones, as Chris said, and I'm with Q2 Software, headquartered in Austin, Texas. We are a financial development, software development company. Other words for it is fintech company. And we are a global company. However, we are mainly in the U.S. We have about 1,800 employees across U.S. And as Chris said, BC, before COVID, we were located in about 5 strategic offices across the country. And now, after COVID, we are in almost every state, at least have an employee in every state. So our challenges have been a little more than they were BC. I like that term, so I'm gonna take that. And so one of the things that, as we entered into the pandemic, we had already, quite honestly, been looking at virtual health as a consideration for our benefit offerings, but weren't quite convinced that our employees would really use it. We didn't have high utilization of the telehealth embedded in our carrier and our medical plans. And so we then entered into the pandemic and saw that now everybody was forced to use some sort of virtual care for at least an undetermined amount of time. And that's when we started talking with First Stop Health, and really felt like it was, now we had the utilization. One of the problems we were solving besides just that was the embedded telehealth program was difficult to find for the average employee or their family members. And so there wasn't high utilization. There was a lot of questions to my team about how do I find it, where do I go, those kind of things. So from that perspective, we thought surely there's a better solution out there. So we engaged with First Stop Health, and we implemented this in 2020, at the beginning, or in December of 2020, and then beginning 21 from that point forward. And our results have been amazing. We just had our mid-year review for this year, and already had 711 appointments through virtual health, through First Stop Health. And the responses that we are getting from our employees is overwhelmingly positive. Makes my team look really good that we put this benefit in place. And let me back up to say, when we put this benefit in place, it is carve out of our medical plan. So 100% of our employee population has access to First Stop Health, regardless of whether they're on our medical plan. And it's zero cost to them. So my company pays for the premiums to engage with First Stop Health, and then every time an employee or their family members reaches out to First Stop Health, they pay $0. So talking about the incentives earlier, that's a pretty big incentive when they don't have to pay anything. and they can access it from wherever they are, 24 hours a day, 7 days a week, 365 days a year, is a very nice incentive and beneficial to the population. And then one other thing I would say is on the family support is our plan with First Stop Health not only allows the employee that access, but up to 7 family members. And that does not, they don't have to be living with you. They don't have to be under the age of 26. And this was something that we found was very helpful for a lot of our population. And one example that I think is in the title of this session is in regards to our international transfers. I mentioned earlier we're a global company. When we had employees coming from another country to the U.S., it takes a little while to get their benefits set up because they have to get their Social Security number. That takes a little bit, et cetera. And they're in a new place. They don't know anybody. They don't know any doctors. They don't know where to obtain the care. And we wanted to keep them from going to the emergency room like somebody was talking about earlier. So this is another way. Again, it's outside of our medical plan, so they don't have to be enrolled in the medical plan at the time to use and obtain care as they need it. I think I covered.
Yes, thank you. Before we dive into some more detail on, why Q2 partnered with First Stop Health, I do also want to mention we do have this giveaway. It is a book titled The Healing of America, A Global Quest for Better, Cheaper, and Fairer Healthcare. So in the vein of alternative sites of care and having conversations about looking to international health systems, this is a Washington Post journalist that traveled the world with a shoulder injury and had experiences with several different health systems and writes about them and kind of talks about how we can apply that in the U.S. as well. We'll be raffling this off at our booth, the First Stop Health booth, so come by and we can talk about it. So we were originally going to launch along with the plan renewal year for 1/1/2021, but you called out that we actually were able to start earlier. So I do want to call out, because we're separate from the carrier, we can be implemented off cycle. So we actually launched 1 month early in December 2020, and then 6 months later in May of 2021, they had originally started with our virtual urgent care, which is the 24/7 access to a doctor. You can talk to an MD or a DO within 7 minutes. But in May of 2021, mental health was really the focus for a lot of employers, and they wanted to provide a benefit for their employees. So they implemented mental health. And here we are 2.5 years later plus. Can you talk a little bit about how this solution has specifically supported employees that are on a high deductible health plan?
Sure. Well, as I mentioned earlier, it's a carve-out plan, so it's 100% of our employees can participate. And we have, I think it's 94% participation on a high deductible health plan. We have 2 high deductible health plans and a PPO plan. 94% are on the high deductible health plan. And because of this being a carve-out plan and direct contracted, then they don't have to pay that first dollar visit cost as they would if they were going on using a provider through the health plan. So again, another win for our population, both those on our plan and those that are not on our plan. And I would say that, excuse me, I want to go back to the mental health part. The reason why we didn't implement it to begin with is because we were new to exploring this virtual health product. And so we were getting our toes wet, so to speak, with the urgent care. We had such an overwhelming response and ease of use with the plan that as you all are aware, and after the pandemic was a year underway, then mental health became a bigger concern. I think there was always been some concern, but even bigger concern. And, we had an EAP plan that was really nice, and we have, good mental health coverage on our health plan, but we felt like maybe there was something more that we could offer. And so we opened up the conversations again with First Stop Health, and very quickly and easily were able to add that, as Lisa said, mid-year in 21, so we didn't have to wait until the following year. And that was another big win. We have a much higher utilization on our mental health through First Stop Health than we do or ever have through our EAP. One of the great things, with the EAP is it's available, but you have a limited number of visits, and that's zero cost to the employee. But then they would have to, or their family, they would have to go through the medical plan. And as I mentioned, the 94% on a high deductible health plan, that's going to affect their pocketbook. And so by having another resource, telehealth, virtual resource, that they didn't have to be able to leave work and go, or make even a statement that I have a doctor's appointment, as an example. And they could reach out at any time to First Stop Health, and unlimited amount of visits and no cost to them or their families. So another big win for our employees.
Could you share a little bit about the engagement strategies that we deployed to ensure that the employees were actually going to use the service? I think there's a common trend within the virtual care space is a lot of times it doesn't get used.
Right.
But I would say that's an area where First Stop Health truly differentiates ourselves in the market. We have a 45% utilization across our book on average, and we have really great results with the Q2 population as well. So do you mind sharing a little bit about how we made that happen?
So, we've all, on the employer side, we've all heard the sales pitches from, various vendors, right? And so this was no different to begin with. And when we were approached with the information of the return on investment and the amount of engagement, I was like, I was still a little skeptical, I will say. But we, as I mentioned, we were already in the telehealth virtual world through going through the beginning of the pandemic, and saw a need. And we also saw our employees and their families that were accessing the care more regularly than they had prior. So with that, we kind of took a little bit of a leap of faith. And I'm amazed at how engaged our employees are with this benefit particularly. But the other thing that, me as the manager of our benefits program, I'm not in the day-to-day weeds like my staff are. And what I found was that they were, excuse me, that they were not having to answer all these questions about, well, how do I access whatever virtual health care it was? And when we looked at it a little further, I realized as the email strategy that First Stop Health has in place, they're relevant, they're age and gender appropriate. So I might be getting an email about something that would be appropriate for me and my age, but my coworkers are getting a different message, but they're all very relevant. And when they're coming in, you don't need it today, but I just got that email yesterday, and now I can easily access the benefit when I need it because it's fresh. It just came through my inbox, right? I don't have to go and find it on the web somewhere or in all of the benefit documents to determine where that is. And that was one of the things that we found has been a very positive impact, and we've had very good return on investment, as well as I mentioned earlier, the utilization. It's always a good thing when your accounting and finance leaders are happy with the benefits, because they're paying the bills, right? And every year when I'm going to talk to our leaders, accounting leaders, about the renewal for the next year and all this, before I even start, my accounting director says, just please tell me you're not getting rid of First Stop Health. So that's always a good sign, because she has said how much it has saved her time and money by being able to access it at any time with just children that often are sick. So.
Great. And so as you can see, we did have some really great utilization outcomes, but also return on investment outcomes. We do have a performance guarantees in place. So for virtual urgent care, we do have a 25% ROI guarantee. And for virtual primary care, which if you want to learn more, you can come by our booth today, we do have a 30% utilization guarantee. And I think that's a really important component of a partnership, is having your vendor partner, have some skin in the game with you. And we were talking about incentives in the past sessions, and making sure that your partners have incentives that are aligned with your own, with the employer's pocketbooks, with the employees' pocketbooks. And we've had, of course, we talk about the financial components, but as we ended the last session, at the end of the day, it's about the patient experience. It's about the employer's experience. It's about your consultant's experience. So we have a few quotes up here from Q2 Software employees. So I'm just gonna, I know it's a little bit of a small font, so I'll just read it a little bit. Simple process. It was nice to be able to talk to the doctor without having to leave my own home. I did not want to sit in the walk-in clinic or emergency room with people who were much more ill or possibly had COVID, so that was perfect. Doctor was very nice and professional, and I was called within minutes. I definitely use the service in the future. I had a wonderful experience with my visit today. It was quick, easy, and super helpful. And how often do we hear that in the health insurance and benefits space?
Yep.
Not all that often.
Well, and I can just add to that from my own personal experience, having used it. My husband always gives me a hard time and says, Melanie, just because you handle the benefits doesn't mean you have to try them all out. So anyway, but I have used First Stop Health, and I can state that it's an almost immediate callback anytime that I have utilized the service, and that, time is money, right, for all of us. And so it's just been a really, really beneficial plan for both the company, but most importantly for our employees and their families. And I don't know where the stats up there, but we're running at about 197% ROI. So I think that speaks volumes as well.
Melanie, quick question here. Everybody has an ROI. If everybody had the ROI that they claim, we'd be being paid for providing health care. Mm-hmm. How is ROI determined? Is this the standard, if we didn't use this, we'd go to the emergency room, and then how do you determine ROI?
Yes, I would say that First Stop Health uses some of the similar things that you stated. Like what would you have done if you hadn't used First Stop Health? Where would you have gone? And then using some average pricing, and correct me if I'm wrong speaking here. But the way I look at it, similar to what you said, is, close your ears. First Stop Health, close your ears. I think that sometimes that can be overstated, right? That, okay, maybe it would have cost $10,000, but maybe it would have only cost $5,000. What speaks volumes to me is our ROI based on First Stop Health terms are so almost double of what we're paying, that they're not that much higher, right, on the inflated cost for the different services. So I think that both, again, for Q2 software, employee experience, customer experience is high on our priority list, both as a company and as we administer the benefits to our employees. And so when we can find partners that we can work with to give that level of customer service, the ROI is important, but that is not our number one reason for doing it. It's probably the reason that we made the decision to begin with, because there was some level of, return on the investment. But at the end of the day, we are investing in our employees with our benefits. It is not about the cost per se. Of course, that's part of it, but it's really about their experience.
You're not on the primary care platform, so you're more on the urgent care. What would you say are the top 5 reasons folks contacted First Stop?
I would say upper respiratory infections, rashes, pink eye. Pink eye is one my family has utilized it for several times, but it also is one of our number ones. You said 5. What else? Those are the ones top of the head.
Most of those require medication. Is there navigation to value-priced medication through this, i.e., let's go to the generic instead of the most expensive branded? Maybe Lisa can, or somebody can talk to that.
Absolutely. So the clinical methodology that our doctors are using in these consultations is we can e-prescribe, and we will prescribe generics when possible, if a generic is available. So we are not trying to push antibiotics. We're trying to make sure that we're directing them to a cost-effective medication at a pharmacy of their choice.
Any questions from, here we go. Several, good.
I'm curious why you're not on the primary care platform, and are you considering it, and what are your considerations in that decision process?
Excellent question, and I was going to make that point and then I forgot, so thank you for the question. So the primary care module with First Stop Health is fairly new. It's been in place a year, I believe.
Yep, just over a year.
And so our philosophy behind it was starting with one and let's see how it goes, and then we added the mental health. We hadn't really explored the primary care because we just weren't thinking about it. Our plan operates well. We didn't have a solution to fix. However, it is something that we are in fact exploring now. And some of the primary, I mentioned we are headquartered in Austin. The majority of our U.S. employees are in the Austin metro area, and it's hard to get from one place to another. It's with traffic, similar here, Houston, those of you who are trying to come in this morning, bless you. But anyway, so that is an area where I think our employees would find value. And so definitely something that we're exploring. Then the other piece is, as I mentioned, post-COVID, we got to come up with a PC. So post-COVID, our employees scattered because now it no longer mattered where they're sitting to do their work. And when you transition or move to another place, you don't know the doctors and all. And so there's just been, again, another level of consideration now that we have such great response to the other virtual care.
I saw another hand up. There was that. Oh, Sue, here you go.
I'm interested in the mental health side of this. With the utilization that you've gotten and the positive feedback you've gotten, have you considered dropping your EAP? And have you seen a decrease in your mental health claims on your health plan because of First Stop?
Great question. I have thought about the EAP portion of it. There are some other factors our EAP offers outside of just mental health care. For example, oh goodness, on the top of my head, I can't think of
Like financial wellness.
yeah, there's exactly,
counseling.
financial and legal. There's also a help net. For example, you need a plumber, you don't know what to call, things like that. So those are programs that are outside of just the mental health. And then as far as the mental health claims on the medical, I would say that because there has been such a rise in mental health needs, that we haven't seen a reduction yet. It's likely, but for us, it was more about getting the access to the care, and for someone who is accessing First Stop Health, rather than not any care whatsoever, is a positive response.
Have time for one more quick question here?
Yeah, just a quick question. I have clients ask us as analytics company, what type of, how many follow-up visits do patients end up having after a virtual care session? So ironically, you guys are called First Stop. Is there a second stop in most cases?
That's a great question.
And how many end up going to a specialist versus a PCP? Because if we're just adding more visits, then
Absolutely. So that really lends itself well to the virtual primary care conversation. And so there's two parts to that answer. Yes, there are follow-up consultations that we can have with patients. So for example, we're not going to be able to draw your blood virtually. We're going to refer you to a LabQuest or a LabCorp or Quest Diagnostics to go in for your lab work. LabQuest, maybe they'll merge someday. Or if they do need to go see a specialist, an orthopedist for a knee replacement surgery, we can refer to in-network, high-quality, cost-effective providers that are in the network, and then still serve as that quarterback, the primary care, in the primary care environment to follow up and make sure they're adhering to their medications properly. If they have chronic conditions that don't require a specialist, whether it's diabetes management, hypertension, or a lot of times mental health issues, probably a third of our consultations present with stress, anxiety, depression, so we can manage that in the primary care setting as well as the mental health setting. But definitely we could talk more on that later this afternoon.
And I just want to mention one other thing that you made me think of on ours. So one of the things with the virtual urgent care is a participant can also get a 1-month emergency refill for, say, a maintenance med that they aren't able to get into their provider timely, or maybe they are on vacation and left it at home or ran out or any of those things. And that was another key factor that had us really interested in offering this benefit.
So I want to thank these folks for sharing their story with us. We've got several more to go, but let's give these folks a hand. Thank you for spending time with us. All right, folks, if we can have a seat, we're going to get started here. Folks will be coming in. It's tough being the session right after the break. It's like herding cats. So as I mentioned here, employers here, well, we can't direct contract and still have a PPO network. And my point is, yes, you can, and there's so much value in it. And these are more examples of employers who have decided to take the bull by the horn, so to speak, and make a difference. So these folks are great. I've been familiar with Green Imaging for years now, Next Level Medical for years. Right now, they'll describe this. I've just met recently Jean and Christina, both employers in this market who have figured out that there is a better way. So this is a 35-minute session, and we had these folks speak at a recent event. I'm sure the time will fly by, and you won't see slides. This is going to be a wonderful conversation. So y'all have at it. And
Thank you. Thank you so much. And good morning. We are here to talk about taking the plunge. So this is about a couple of brave employers. Kristen and I, y'all probably are familiar with us. We've been speaking here many times. So we aren't going to take up a lot of time. In Q&A, we would love to expound if you want on what we do, but we thought that this session would be best if we just heard from people who made the decision, the brave decision, to do something a little bit different with their benefits. And they're delightfully honest and upfront, so they're going to tell us both the good and the bad. But first, I just want to give Jeannie Toth from Chesmar a chance to introduce herself and her company, and then we'll move to Christina. Oh.
Now I'm on. Okay. Hi, I'm Jeannie Toth. I'm with Chesmar Homes, and we took the plunge about 6 years ago into reference-based pricing, away from a fully funded TPA into self-funded reference-based pricing, right over the edge. So I'm excited to tell you about that adventure.
And Christina?
Hi, I'm Christina Snyder. I'm the Director of HR for EHRA Engineering. So we're a civil engineering firm, and we kind of, as Jeannie said, took the plunge into a self-funded plan from a fully insured plan. This is our second year, so very big shift, and we went all in very quickly.
Excellent. So do you want to just dive right in and talk about why you made the decision you made and what you were maybe expecting to get out of the decision?
With us, we wanted to make a change, as everyone is seeing. We were consistently seeing exponential increases in our health insurance. Our team members not necessarily being fully engaged in the process, just finding providers, going, getting the care, and not kind of seeing the impact it can have as it relates to continuing to increase premiums. We all know fully insured plans, your premiums go up, but they don't typically ever go backwards. And once you're there, you're there. So we wanted to take some control back as an employer of the things that we can control, and then also be able to take and modify our plan to what our team members' wants and needs were. And what really helped us be able to start achieving that and seeing that vision come to truth was we made a transition of a broker and aligned with someone that kind of was very passionate about what we were trying to achieve, that also brought some great insight into things we may not have thought of, but added a lot of value to the plans we were able to build.
So 6, almost 7 years ago, we were in the fully funded rat race. I call it the rat race because it's every year exponential increases, and then you're fighting back with them, going, "Wait, this person's no longer in the plan, so our numbers are going to look better." And you're going through that, and our broker was giving us our renewal like 2 weeks before open enrollment, and it was just a nightmare. And so our CEO is very, very into just the broken healthcare system and how bad it treated not only us as employers, but our employees. And there's got to be a better way to do this. So we started researching and interviewing brokers and found a broker that was kind of doing things a little bit different. So number one, obviously reducing costs, and reducing costs not because as a company we want to spend less money, which is important, but also for our employees because they couldn't keep taking those premium hits and we couldn't keep absorbing them. So if you're in that rat race, I'm here to tell you there's a way out of it. So we were going through that program, and so we interviewed brokers, and we had one that just kind of made sense to us. But also I tell you, you have to know your company culture. And so our values and our company culture allowed us to, we just did the deep dive. We're like, I begged, I might have even cried, please let us stay with this TPA and do self-funded for 1 year and try it. And he's very bold and said, oh no, we're diving off the deep end, and we did. So it was, it was good because I needed that push to do it. And sometimes we need that push over the edge to try something new. But you also know once you dive off that edge, there's no going back, so you got to make it work. So, we really found the broker. We went reference-based pricing. We did a ton of education with our employees. And that's the key, is explaining to them why you're doing it, all the whys. Having them see, we went through charts and graphs of how hospitals price and how the BUCAs reprice and give you a certain percentage off, and where the Medicare rate is in conjunction to all that, and how we're going to pay percentage of Medicare. So we went through it all. We were completely transparent in the financials of all of this. But then we taught them to be consumers of healthcare. And that was the shift. You don't have to do it the way you've always done it. And if you're a consumer, your life will change. And so I think that for us was the biggest learning.
I think a lot of that for us as well is having the support and the buy-in from leadership as well. Because a lot of times, again, you're hesitant for that change, but having that buy-in from your leadership and them being open. And we had some tough conversations and saying, hey, some of it was, you just gotta trust me a little bit. Like, I promise this is what it looks like. I know it's always been fully insured. We're with an ACC going through their plan. United Healthcare, they've been with United Healthcare, which for many, many years fully funded, but showing that, hey, we can still keep part of this feel of when our team members want to utilize their insurance as they're accustomed to through a PPO. We were able to, this past year, we're using the United Healthcare Shared Services network. So they kind of have that feel of it's still there, you can use it, but let's try some other alternatives. Let's go through here. But that buy-in of leadership was a big challenge for us because it was something so different that they have done of a firm that's 85 years old.
So talk about the creative things you've done. Okay. Tell us about them.
Well, when we went through, when we started this process, one of the biggest selling features was green imaging, because in teaching your employees to be consumers of healthcare, imaging is a really easy way to do it. It is a great first leap because everybody understands imaging. And so I had an associate on our team that came in my office sobbing because she got a balance bill for an image, and she owed $4,000 above her deductible because she went to where her doctor told her to go. We trust our doctors, right? And if they tell us to go to this place, and I'll tell you, they'll tell you, we can only read imaging done at this facility. And our employees are so good now, they'll go, BS. Like, that is not true, because we have trained them. And they're like, just give me my orders. They're actually go to the doc, just give me my orders and let me out of here. So, they've learned that there's a different way. So that's a really great way to start.
Also, yeah, we were fortunate. We started partnering with Green Imaging. We always call them, we have our plan, and we always call them added value partners, because they truly add value in every aspect. They add value in the quickness you're able to get your imaging. They add value in the reduced cost that is costing our team members, as well as the plan on the back end. And showing that they're not just additional phone calls you have to make, additional things you have to understand. They're truly added value partners. And education is a big piece. And it's a big transition of a mindset for your team members. They're used to just going and handing over that insurance card, and when you're partnering with something like Green Imaging and Next Level, you tell them if they are taking that insurance card, something's not being done right. There's no reason for them to take that insurance card. But them being able to go in and go to a doctor and need that imaging, and they're kind of creatures, we do this every day. They don't always know that they can ask those questions, or like was mentioned before, you can say, no, I don't want to go there. I want to find someplace else. And so having your teamers be good to say, hey, can I get an order? And with Green Imaging, it is incredibly easy because you go in, you take that order, and sometimes it's as easy as you take a picture of it and you just text it to them. And that starts the engagement of the process. You text it, you give them your contact information, and then they're gonna reach out and start the process you'd be going through anyway. But the end result is they are able to get imaging done quickly. A lot of times at the same imaging centers that they would already be going to, but now it's a different type of experience in that they hand over this voucher that they are sent ahead of time. So that voucher is going to include all the details related to the service that they're needing. They've already worked out with Green Imaging of, okay, this is the imaging, this is my availability, this is where I would like to go. So when they go, take this voucher and go to that facility and they scan a QR code, that tells the facility everything that they need to know. And the best piece of it for your team is you're now giving them imaging that would normally go towards their deductible, their out-of-pocket maximum, anything they're gonna do, and they walk out not having a zero out-of-pocket cost for that same service. And showing a team member, even though it's a slight shift in a mindset, which is a huge challenge, is to shift that mindset. If you can go and say, hey, it's a shift, it's an adjustment, it's a new way to think of things, but it's not gonna take anything out of your pocket. When you say $0, that piques anybody's interest this day and age. And then within that, so an extra level to that, so we started with Green Imaging in 2021. In 2022, for this plan year, we engaged with an additional partner called Connect Benefit. So we are still utilizing and partnering with Green Imaging, but it is through Connect Benefit. And Connect Benefit, and I think actually we have it, and Jeannie and them are about to begin it with their company, but it is, we tell our team members, this is a concierge service for your benefits. If you have anything that needs to be done, I always say call Tracy. Tracy's one of our main contacts. Call Tracy. We have their cards. I think we have sold it up. We have team members that tell me, we're almost afraid not to call Connect Benefits this day and age. But you call Connect Benefit, and that is their sole point of contact for anything related to our added value partners. So instead of them having to remember all the different ones and who to contact, they call Connect Benefit, and they will navigate them if it's through Green Imaging for imaging. Is it through cancer care? Is it for, oh my gosh, physical therapy? Is it for blood work? Is it for specialty? Is it for chronic care management? Any of those things, surgeries, yes. That's the big one. Not sure I forgot that. I just had a call on that yesterday. But we've also partnered with the Coral Marketplace, and so they can get zero out-of-pocket costs. But the biggest thing is having the resources in place to make it easy for your team to be able to utilize them. I mean, that is huge. Make it easy, and then dive in. Also, I'll let you talk Connect Benefits, and we're gonna dive into next level because that is such an amazing, amazing benefit in itself.
Well, and we've been with Next Level for a year now, and I have to tell you, I was a holdout. At first, when it came to you, I was like, well, they're not in all our markets, da-da-da-da. I had 1,000 reasons why not, and then all of a sudden we did, and now I have 1,000 reasons. I can tell you, I was telling Dr. Breeze the other day, if anybody in our organization, they'll say, hey, I went to Next Level, and they start to say but, like there's a negative, all the other employees are like, don't you talk bad about our Next Level. Don't you dare say bad things about our Next Level. Because the ease of use and the experience, and you think it's urgent care, but it's not. It is so much more because they can do primary care, they can do labs, they can do health, they can have health coaching, they can have, and the reason we partnered, when we partnered with Next Level, and one of the driving forces for that was that their philosophy really much aligned with our business philosophy. And it's about taking care of the whole person. If you've got an employee who is diabetic, but they're also overweight, if they don't deal with the weight and the other underlying conditions, or they're battling depression, and so there's all these things, there's a whole person out there. And so partnering with other groups that also help you see the whole person, because then us as employers, we're getting our person, our teammate taken care of, all of it. And so that's the really important part about a lot of these partnerships is that they're more than just healthcare. They're really, really a business partner for you. And so, if you have a PPO, if you are, self-funded, these are easy programs to just kind of loop in and try if you're not ready to dive off the deep end and go all in. But I would tell you, the more of us that make that choice to change the way we do healthcare, like we said, we can move the needle if we do it, and it's really not that hard. It really isn't. These partners, finding the right broker that'll lead you through it, you can do it.
One thing, just for the folks that are not familiar, if just a minute or two, can you describe Next Level and green imaging and what you do and how you work your model. I know it's all direct contracting, so that's a point I hope we get to.
Sure. Green imaging, we've been doing this 13 years. We started to solve a problem here in Houston, which was there wasn't affordable imaging. River Oaks Imaging was bought up by a hospital system, by Memorial Hermann, and the prices tripled. Same thing with Kelsey-Seybold. They were acquired and the prices, went way up. And so I was a radiologist. I had a radiology group. We were reading, for imaging centers in Houston that were billing out of network and that were at 50% capacity. So we just flipped imaging on its head, started buying the scan from the imaging center. Our radiologist would read the exam, thus assuring quality across our entire network, making sure the right radiologist read it, that the protocol was appropriate, that the right exam was performed. And we built that in Houston. People wanted it throughout Texas. We built it throughout Texas, and now we're in 50 states. And we can save, there's soft savings like the patient not meeting the deductible with just one expensive exam, but there are also hard savings. Even at zero out of pocket, we can have 30 to 60% savings to the employer, apples to apples. And so, it does two things. Assures quality in a way that, and physician, I would say we've got to get physicians back in charge of healthcare, because this is physician-owned and operated healthcare. And, that physician guidance, that ability for us to jump in if there's ever a question, it just makes a big difference. We're not perfect. Nothing in healthcare is perfect, but we can roll up our sleeves and help.
Yeah. And Next Level, actually, I didn't know Kristen at the beginning of my journey, but we're kind of on parallel courses. We came into existence to present an alternative for Houston to high-priced emergency room care. And so we started out as just urgent care, as Jeannie mentioned, but we have actually expanded our services and evolved, and now we are an advanced primary care provider. We actually got really good at using the capacity of our own centers. Kristen uses the capacity of other centers. We realized we have facilities all over Houston and now Austin and San Antonio that have plenty of room. So we can bring in-person care, and our big differentiator is that we are open till 9 p.m. every day of the week. And so there is nobody out there in Texas right now that is allowing people to come to the doctor for their diabetes, their hypertension, or their physicals on a Sunday afternoon or on a Thursday evening. And so we're really proud of that. I spoke with someone yesterday who said, we don't have an access problem for our employees. And I said, I think that a lot of people think they don't have an access problem until they actually offer their employees $0 7-day-a-week health care that is until 9 p.m. And then you realize, wow, there are a lot of people not accessing health care. So what our program includes is not only just urgent care and primary care, but we also include health coaching, emotional wellness counseling, and we include all the wellness labs. So pretty much anything you would order, sort of the basic primary care offering is what we can provide, with a little bit of a kicker in that we do some higher level things that maybe most primary care doctors don't do, like broken bones and IV fluids. So we really do save, most of our savings is generated through avoidance of emergency rooms, lab savings, and what we're hoping to do is, over time, eventually catch those early cancers, catch those early diabetes and hypertension, and really move people away from the hospitals. So with that, let's get back to our employers, because they're the real story here.
So I wanted to just kind of piggyback on what you were saying with Next Level. One of the things that's great coming from kind of a consumer aspect of it is that, the big thing with Next Level is you download the app and you push the orange button. So that's a big thing, did you push the orange button? And if you do that, you download their app, again, push the orange button, but it takes you to the phone number that takes you to a team that is specific to Next Level Prime members. And within that, then you are in touch with them, you're telling them what's going on, what you're looking for, and they're gonna help guide you of, yes, we can absolutely take care of that. If they can't, they're gonna give you some guidance of, hey, you may need to go to the ER for that. But they're great at navigating where you are. But within that, just kind of taking on that experience is they're going to say, hey, how quickly are you wanting an appointment? I'm incredibly fortunate that I live about 15 or 20 minutes within 3 different next level locations. I'm not sure how that worked out, but it is very convenient. Because let's be real, kids and things are sick after hours and on the weekends. So having next level gives you that ability to be like, hey, we can go somewhere. They're really great in being able to get you an appointment very quickly. Sometimes I've been on the phone and they say, we have one in 15 minutes. Can you get here? And I'm going, yelling at my kid, go put your shoes on, we're leaving, you know? And so the quickness they're able to get people appointments and your team members and their families appointments is phenomenal. I think the longest we've ever been in a waiting room is about 10 minutes. Hence, during flu season, they do get quite busy, just as all urgent care facilities do. But the wait times that you go in are incredibly reasonable. You're not sitting there for an hour. Also, with being Prime members, this is something y'all take on is, I wouldn't say it's a skip the line, but you know, if you go to next level, there's different doors and patient rooms that say Prime on them. So there's appointments that are put aside for the Prime members that kind of gives you the ability to get in more quickly. And then when you get there, the experience that you have is phenomenal. The quality of care, the doctors, everyone that you meet when you walk in the door, we have gotten incredibly positive responses from our team members of the quickness, the quality of the care, the things that they're able to no longer have to go somewhere. It's a single point of service for so many different things that you can do. And I know nothing is absolutely perfect, but when we have run into issues or things that we've had go on, a lot of times we'll call, get in contact with Dr. Breeze, and they have been amazing at being, okay, what happened? This happened. Let's check this out. And they're looking at the records, they're looking at the timing of everything, they're looking at phone calls, and I have to say, I applaud y'all at how wonderful you've been at that there's error, like it is addressed, a solution is found, they're reaching directly out to that team member. So while we know nothing is perfect, when things come up, they take action quickly, and then we'll actually follow up with the team member and let us know the resolution they're taking. There's been a couple instances where it's like, you know, this actually enables us to improve our practice, and they're putting different things in place to improve things across the board, just not for that one instance. So it's an ever-growing and modifying as it sees where its needs are for its team. And I know when we go through renewal, our team members, just like Jeannie was saying, is, okay, we're going to be making some changes. And they're going, but are we keeping next level? Yes, we are. Okay, but we're keeping next level, right? I'm like, yes, it is not going anywhere. We promise it will still be there. You can still push that orange button. And the same with green imaging. We've both experienced this with our team members. And you have to chuckle, but also let you know, we're doing something right. If it's something that your team members it's not going away, is it? It means that they're using it, they want it, they see the value in it. And transitioning this mindset of having our team members just handing over that card, but being truly engaged in the process, it's phenomenal because they see it differently now of what do I need to do? What resources do we have? And sometimes they bring and ask us for help, and we're going, that could have cost you nothing if you called Connect or you went to next level. And they're going, I completely forgot. Well, they forget once, and then we hand over the information again, and then it's at the forefront of their mind. But education is huge, but the team members see value and that they're asking for it to stay as part of our plans.
Well, and like you said, nothing's perfect. Having been on this journey now for almost 7 years in that alternate healthcare space, we've made some mistakes. I mean, it hasn't been perfect. We've tried a TPA, and the TPA and our repricer and our navigation were all in the same group together in same ownership, and we found that didn't work because because they all were looking for the same end profits. There wasn't a whole lot of encouragement for them to send them to the green imaging or to one of these alternate solutions because it took them out of their normal pricing structure. And so, that didn't work, and we were paying a percentage of negotiated charges, and we're like, and that didn't work. So then we tried another one that was a per employee per month. That didn't work. So I'm not saying like we've jumped off and we've done everything perfect, because we haven't, and our employees have been through a lot. Any plan changes now we make, it's like, okay, I survey them every year. I actually been doing now two times a year surveys and asking about all our providers and asking about how their benefits are running and asking them what they think, and they are really, really honest. But I love it because then when it comes time for us to start evaluating, we can say what partners are meeting our associates' needs and what partners do we need to look at changing. And so we've had private TPA, and we've been using PHCS and Health Smart networks, but our problem was hospitals. Our hospital systems were really pushing back against it. So it was like, how do we overcome this, right? And that's a challenge, absolutely. I'm not saying it can't be done, but so for us, we're like, how do we reduce our noise this year? And so we're gonna try something else, and we're gonna try the United Shared Services. Our plan expenses are gonna go up. It potentially is more than we're paying today. But again, we're gonna try this because our employees are telling us that they're struggling with this part. But then we're also layering in navigation, and our navigation is completely separate than everything else. We're bringing in navigation that is not tied to anything else. And I would tell you that's something I've learned, and our fingers are crossed that by bringing in this navigation that's not tied to any, that their own sole purpose is to help our employees. And we talk about no cost. No cost doesn't mean it doesn't cost us something. And so we're well aware, but what we've designed into our plans and in these programs is that if you use these services, these bundled pricing, I call them the easy buttons. If you use the easy buttons within the plan, we are not going to charge you anything. If you want to use the regular network and go to the hospital and incur all those costs and pay your deductible, you are welcome to. You have choice. You have absolute choice in this plan. But if you use the easy button, then we are going to not charge, we're going to make it zero cost to you because we're saving money as a plan, so you deserve to be part of that. And so that's a really big part of the message. So I've had employees at open enrollment, they're like, wait. So you're telling me if I need to have knee surgery, and I go to next level, and they say you need an MRI, so I go to green imaging, yes. And then I use our surgical bundled program, and I have my knee surgery, and then I recover, and I come home. I don't pay anything? Like, yes, that's what I'm saying. Yes, you don't pay anything. They're like, seriously? So again, they're starting to hear, they're saying this out loud in the meetings and in your open enrollment meetings, and they're saying it in front of their peers, and then they're telling their peers, I had this done. So it will build momentum. You will struggle. I'm not telling you the first year won't be a lot of challenge, so be ready. But as you go through it, you'll find it gets easier and easier, and your associates will understand. And I know we're probably running out of time, but I've had employees leave our plan. So I hear healthcare plan's so difficult, and I have to make all these calls, and I don't recognize the name, and it's not the name, it's not the brand name on the card, and so you're gonna hear all those things, right? But I've had employees leave our company, go to a different company, and they'll call me and go, I apologize for everything I said about our medical plan. They're like, now I have this HSA, and now I have to hit my deductible, and my prescriptions have tripled in cost, and this is more expensive, and I can't get this done, and we don't have green imaging, and they're calling me, telling me. So again, while they're in it, you might not hear it, but then you'll get these experiences.
Any questions from the audience right now on this?
Good morning. So this is for Dr. Breeze. Jen, I know you mentioned diabetics getting care after hours, and with diabetes becoming such an epidemic right now, I'm just curious, when it comes to chronic conditions and those employees coming to get care, what is that next step? Because there's that medication adherence, and there's other steps that chronic members have to deal with. And so I'm just curious, when they come to you for that first time, is there ongoing coaching or is there outreach?
Yes, thank you. Thank you for throwing me a softball. So we're really proud of how we're approaching chronic disease. It's a little different than maybe other practices. So because we are a 7-day-a-week practice, we have to operate as a team because there's not one person who works 7 days a week, right? So we give patients, especially our chronically diseased patients, a care team that is working on them. They have their virtual provider, so they have the opportunity to get virtual care. They have their health coach. They may have emotional wellness counselor. They will definitely have a care navigator who may be performing outreach on them to check on them to see how things are going. So we really know that it sort of takes a village to really take care of patients well, and it's something that really isn't the way that we're taught in medical school. You know, you come out of medical school as a doctor and you're kind of taught you're the doctor and what you say goes, and that's just not the way that the world is kind of moving now. We are really seeing that collaboration actually makes for better care, and we have something that I am just in love with as a physician, which is something called IDT. We have every week our team, it's an interdisciplinary team meeting, and we get together as a team, and we, any member of the team can propose a difficult or complex patient to talk about, and the entire team jumps in and talks about different things. So many amazing discoveries and learnings have come out of those meetings that I'm sad when I have to miss. I just like to listen in because it's so great. But this is where medicine is going, and we just it's not fully embraced yet, but I think a lot of practices, you'll hear this more and more across the country. There's not going to be one doctor who takes care of one patient. It just doesn't make sense. And we're running out of doctors, so that's another thing.
This is for Gina. When y'all did reference-based pricing, I'm just curious, how did that go? And did you receive a lot of members getting balance billed and things like that?
So basically, most of the time for reference-based pricing, what we're doing is, and again, it's that education. If an associate just goes to care and they walk in and they go through it, when it goes back to the repricer, they reprice it, and then they'll pay that claim, right? And a lot of times that's when the hospitals or systems will balance bill. We have always had on our plan the balance bill defense built into it. So if there's a balance bill and the associate has gone through the right steps, then we have balance bill defense, and they take it from there. And you just have to encourage the employee, every time you get a bill, you send it to this company. I don't care if it's a year from now, every time you get a bill. So that's been an important part of it. And then again, sometimes there's negotiation on the end, and you just got to get some of those cleared out. But for the most part, it's been a little bit of a challenge. And again, a lot of it is education. But it's also allowed us to, over the past 2 years, decrease our employee premiums. This year, we're dropping at $100 a pay period for a family.
Yes, one more here. Yes. Yeah, one real quick. No, everybody needs to hear you unless you shout it real loud.
This is both for Jenna and Christina. With your members, I came in a little late, so I'm not sure exactly about your population size, your group, your member size. Education, getting in there. We work with a lot of employers, and that's the key. And you've changed navigators a couple of times. What has been your utilization within that navigation component, and have you seen that going up, or how are you getting that education while you're changing the education metrics and changing the education delivery? I mean, there's a lot of change going on. I'm trying to understand that, and that's going to give me a good information.
Well, we're in home building, so we're a very, the thing we say is the only thing that's constant is change. So, markets and things like that. So we have our population is fairly good with change. The first year I did it, our navigation was called Nurse Navigator. And literally, if an associate came in my office, they go, I already called Nurse Navigator. That was my first question to him. Have you called Nurse Navigator? So really, you being the person to go, I'm not going to answer this question until you follow the process, and pushing them back through the process helped a lot. But yeah, it is tough, and we've changed navigations, and so every navigation from that point on, they called Nurse Navigator, even though that's not their name. But again, it's just that repetition, and when they don't follow the process and they feel the pain. So we had somebody earlier talk about that, when they don't follow the process and feel the pain, there's a lot of education there too.
Yeah. How many, just raise your hand, have heard the term, you heard it today, advanced primary care? A good portion. So, you've heard one definition of advanced primary care. You've heard one definition of advanced primary care. I think these folks, and you'll hear others, primary care is critical. It's got to be capitated. It's not in a fee-for-service model. The highest cost bucket, if you will, for any employer that has a health plan is what? Anybody? Hospital services, right? And so that ability to have that primary care effectively navigate to value, which is price and quality, is critical. We're really focused on that with HBCH. You'll hear a little bit more about that. The other thing that it incorporates, and you touched on it, is the mental health. And we have to figure out that the head is connected to the body, and they don't work separately. And I would say that this is one organization, and there are others, that have effectively integrated behavioral health into that. That requires an investment as well. So there's others, but as we learn about this model, as Dr. Breeze has mentioned, these are components that we're all going to become familiar with, because healthcare is changing. It has to change. I'm going up tomorrow to Dallas to speak to a bunch of hospital CFOs, try to avoid the rotten apples, but talking about this change and how we can find opportunities to work better, because the model has to change. And this is being part of the change, the culture of change. We often hear, well, we just can't have that disruption. That disruption can be a good thing. And that's one of the themes we're going to hear today. So I want to thank these folks for being part of our panel. Thank you so much. Again, another type of utilization of clinics, but another example of direct contracting. If we hear anything today, you will know that direct contracting is not a terrible word. It's actually two words, but that said and done, it can be part of this. So we're going to hear another example of direct contracting, this with a large school district in Beaumont, and their provider partner, John Farnsley, with 90 Degrees. So introduce, do we have your,
yes.
Do we have one on?
She's got handheld and I've got the.
Oh, okay, well, shout loudly if it doesn't work.
So we are mic'd up. Good morning. As I said, my name is John Farnsley with 90 Degree Benefits. And we're going to talk about near-site clinics, but it's important to understand, and that last session was so perfect because it is one component of an integrated, comprehensive healthcare strategy, because none of these things work in a vacuum. All of it works together, and we've got to tie these pieces together, and our goal really is to find a way to, we're all trying to solve the exact same issue. How do you lower the cost of health insurance, right? That's why we're sitting here. You can't lower the cost of health insurance if you don't lower the cost of health care. So how do you lower the cost of health care? That's really the goal that we're trying to get to. One of the things that's interesting, I'd almost want to see a show of hands. How many people offer insurance and how many people offer insurance in name only? You know the difference? In name only. If you have an $8,000 high deductible plan and an employer with $500 in his bank account, you don't offer insurance. You offer insurance in name only because they can't afford to use it. So how do you offer insurance that people can actually use? And that really is one of the things that we talk about a lot. And so we have a near-site clinic that is integral to the success, and Peggy leads the benefits team, and she's actually got some of our other folks here as well. And we want to talk about that, but I want to make sure you understand the bigger picture. We really look at the cost of healthcare kind of in three buckets, if you will. Where's your healthcare spend? Where are you spending your dollars? Most groups are going to look the same. Where's the, there you go, hit the next one. Your health plan may look a little different than this. It's not going to look drastically different than this. You've got a fixed cost component, and it's your stop loss and your vendors and the people in the plan. Your biggest spend is likely the facility. Today, which is kind of crazy because it wasn't this way just a few years ago, your second biggest spend is probably your pharmacy spend, then your physician spend. And so each one of these has a different challenge, and we kind of go at each one of them in a little different way. On the hospital side of the equation, we have a direct agreement with the local facility at a Medicare derivative agreement with no carve-outs, no stop-loss outliers, none of that stuff. It's a 4-page hospital agreement. They're generally about 40 or 50. And it's a true partnership with the hospital. You've got to bring value to the facilities. And one of the things we were talking about in some of the other sessions is, overpriced hospitals. Well, I would ask you, what value are you bringing? If you walk into Memorial Hermann and say, would you please lower your cost? And you're not doing anything in your plan, tell me how that goes. What's the value you're bringing? So what are we bringing? We have a $500 hospital copay. What's that mean to the facility? You're not going to have to chase the member for member responsibility that you're probably never going to collect. Prompt pay, low copays, low member responsibility, and an exclusivity. They're an EPO model. And that's a challenge in a 2-hospital community, right, where you have 2 hospitals and one, you're steering to one or the other. And Peggy can talk to some of that. But we use care navigation to steer to that direct contract. It's lowered the cost of the facility side by over 40%. So it works really well. The pharmacy side is the second biggest spend probably of your plan. It certainly isn't ours. Over the next 5 years, it'll be your top spend if things go as they should be. And the dynamics have changed drastically on the pharmacy side. Used to, we were just trying to go, how do we get more generic, right? How do we get our generic spend up? Today, it's specialty drug, high-cost drugs, all of those things that really 1% to 2% of your population is driving 50% of your pharmacy costs. So what do you do with it? We have a program that uses kind of a tiered arrangement with specialty drug vendors, international pharmacy, 340B, copay assistance. Every mechanism we can get to lower the cost of pharmacy cost has been lowered by 40% by running through those different avenues. And then you get to the physician side. And the physician side's interesting because hospital is incredibly inflationary. Pharmacy, I don't have a good adjective that goes above incredibly, but whatever that is, that's where the pharmacy spend is. It's insane. If you ever really want to get scared, go to the pharmacy conventions and see the drugs that are coming out next year. It'll scare you to death. Physicians really are not necessarily the same. We tell people all the time, go find your primary care doctor. They're working their tail off. They're not the cost drivers in the healthcare system. They're just not. And they can be so valuable for referrals and everything else beyond just their basic function of primary care. But there's an interesting dynamic which has taken place over the last 10 years. 10 years ago, if you looked at the healthcare system, about 30 to 40% of the docs were owned by a health system. About 60 to 70% were independent physicians. Today, that number's flipped. The majority of the physicians are owned by a health system. Well, 2 things happens when that occurs. Number 1, your cost is going to go up. But number 2, and it's a real challenge in consumerism, referral patterns get tight, right? The system is buying that doc, not so they can refer outside of the system. And one of the challenges in consumerism for a different session that I put out to you that we see is when you do the consumerism, you can have all the incentives and all the great things, but if my physician is owned by the facility that I really don't need the member going to, that's a problem. And it's a challenge. And that's, I think, one of the biggest challenges that we have trying to navigate that case. But what we've done is we've worked with Access Today to put near-site clinics in for Beaumont ISD, and they really act as the hub for those things. Peggy's going to talk about the value and what it means to the school, but from an overall plan perspective, we use care navigation on the hospital. We use the pharmacy side. But the near-site clinic is the hub of the program. Most of your, 20% of your membership is actually going to go into the hospital next year. And it's important because it's a big spend. 1% to 2% of your population is going to have a specialty drug spend. It's really important because it's crazy expensive. But the vast majority of your membership is going to go to the doctor. They're going to take their kids in for strep tests. They're going to have things that they need. So this is where the interface with the health plan really begins. And so one of the best things we've been able to do to tie these pieces together is the near-site clinic that understands the referral patterns that we need, that understands what we're doing on the specialty drug side, to help really educate the member on the plan, the programs, and the incentives to get them where we need them to be to help them lower their cost and the plan's cost. So that's kind of what we're doing from a 10,000-foot level. Peggy, I'll turn it over to you, and you can kind of talk from an employer perspective on what you guys have done and what you've seen.
Thank you. And I have been doing this for a long, long time. So since I was in my early 30s. And I've been very fortunate. I've always been on the corporate America side. This is my very first time to go to work for a public school district, and I did it for a very great purpose. My husband has always been in the public school district. Always, that's the only job he's ever had. So, you know, I watched his TRS care over the years, the cost skyrocket, the benefits plummet. And honestly, after about his 4th year in the public school district, I got him on my plan, and he and my kids were on my plan and never went back. So when I retired from corporate America, I went to work for Beaumont ISD for a very specific purpose, and that was to get them on their own plan, for them to be driving in the driver's seat and be controlling where their medical plans are going. Thus, we have an incredible broker that, and I'm so happy to see people thinking outside the box, not staying status quo, not being that cookie cutter, because in this day and time, we all need to get out of that box. But, we have a great broker that we've partnered with and therefore partnered with 90 Degrees, and we're doing some great things. So, as John said, we have that direct care model for the hospital, but the hospital spend is only about 20% of your population. Where's the rest of your spend going to be? It's going to be at your physicians. So we have 49 locations within Beaumont. So we partnered with a local urgent care. Now, this urgent care is unique, and we're very fortunate that they do x-rays. They do, you can go in and get stitches. You can go in for a broken arm. You can go in for a sinus infection. Whatever you need, they provide for our employees. This was very important to myself and my district because if you're in a school district, the majority of your population is transportation drivers, food service, custodians, teachers' aides. The majority of these employees make anywhere from $12,000 to $16,000 a year, folks, and that's it. So before I came and they were on this high deductible plan, well, they had catastrophic coverage, but they're never going to use it because they don't have $35 to go to a physician or $40 to pay for a prescription. So the goal was to put in place this on-site, we call it on-site, but we partnered with a local urgent care. And we very much, my team and I drove our employees during open enrollment and explained how this program works. When our employees go to this urgent care, number one, when they find out it's a BISD employee, those employees are moved to the front of the line. So the very first exam room that's open, they get it. So that's great for us because the employee's in and out and they're back to work. But the other thing that's great is when they walk out of that visit, they do not owe one dime. It's free to them. And we have a very special generic drug program that we've also educated our employees to. They don't pay a dime for that if they use 4 local pharmacies and they get generic drugs. So we've educated our employees to say, hey, raise your hand. If your doctor's saying, hey, I'm going to put you on X, Y, and Z, first of all, if it's a commercial, run. But ask your doctor, why are you putting me on that name brand? Why can't I get generic? So the great thing is, in this program where we've partnered with 90 Degrees, this urgent care is doing phenomenal for our employees. We have 1,900 employees. We had 2,600 visits to this urgent care in 1 year's time. And the great thing that's happened is we did it to try to help our lower paid employees, but guess what? Everyone from our superintendent down is now using this urgent care facility. So it saved about $140,000 out of pocket for our employees because they don't pay anything for it. So that $35 or $45 copay went away. Same on the pharmaceutical side, on the prescriptions. They don't pay a dime for it. But let's talk about ROI. The return on our investment is that bucket that holds all of our claims on the physician side, it's dropped about $340,000. On the prescription side, we're in the millions because we're saving that money, driving our employees to generic medications, which work. But the other thing that has just really been very important for my staff and I is we have employees, and I'm going to give you a couple examples. So we have a custodian that was very ill one day. I happened to be there with my lead custodian. He didn't feel right. And, I said, Joseph, have you been to the doctor? He said, Miss Peggy, I haven't been to the doctor in 15 years. We took him to the urgent care. Folks, his blood pressure was 220/125. It's a wonder he didn't stroke out. He had never been on any medication. He's now on a maintenance medication, feeling great. Every time I see him, this custodian has to run up and hug me. He hadn't been to a doctor in 15 years. We have another bus driver, same thing. She's gained a lot of weight, just feeling bad. Her blood sugar was off the chart. So once again, she goes to this urgent care, so now she's on a maintenance medication. How these employees have survived without medical attention is beyond me. But now our employees are going to this urgent care. They're getting prescriptions filled. And it's not just them, it's all of our employees. So it works, it's great, It's easy. Education, as we keep saying, is the key part. Make sure your employees know about this, and we spout it every time we see them. But it's great. It works not only on the cost-saving side, but it is health care. So we know it is affecting the health of our employees. They are now getting the attention that they need.
We talk to employers all the time, and healthcare is hard, but it's not nearly as complicated as people tell you it is. The cost of healthcare is driven by the unit cost times utilization. It's just like every other good or service that we purchase. Everybody in here has an electric bill. What's the kilowatt? What's it cost you for a kilowatt hour of electricity, and how long do you leave the light on? You got a gas bill. What's the price of gas? How many miles you drive? You got a food bill. Do you eat hot dogs? You eat steaks? You eat one? Do you eat three? There's your cost. Healthcare works exactly the same. So unit cost and utilization are the two components. And obviously, we're doing a lot of things on the unit cost side. We want to have Medicare derivative agreements on the hospital side. We want to do all the specialty drug carve-outs, do all the things we can on the pharmacy side. But how do you control utilization? And that's always kind of a tricky thing. There's wellness programs and DM programs and predictive modeling, and there's all these suite of services. This is opinion only, so you can take it as it will. I don't think there's anything more effective for utilization than direct primary care, advanced direct. Having members engaged in the physician does more to control utilization than any of the other programs I've ever seen put in place, and I've seen them all through the years. And so having that really balances the equation, because it is healthcare, and there's a cost component to it. And we got to be cognizant of the fact cost is real, right? It's just a real thing. But there's a person there that needs healthcare, and how are we helping them get high quality, affordable healthcare? That's the goal. I think that's the goal of everybody in this room. And so we try to work that equation from both sides, and the Nearside Clinic has been the most effective thing that we've seen for really kind of balancing that equation to help people get preventative care early and do all the things that everybody in here knows that we need to be doing. And then when something serious does happen, to have the other point solutions in place. Again, hospitals, pharmacy, green imaging. We use green imaging. We've got all these wonderful point solutions. And that primary care clinic helps direct and helps route and helps make sure the member is getting where they need to be.
I mean, excellent discussion here. And another example of primary care in some form driving the system. But your model, it's capitated, right? It is per member, per month.
Right. So that steerage, and I think the reason that this urgent care bit and said, hey, yeah, we would love to partner, is because they're getting that steerage and it's guaranteed. We couldn't say, hey, you're going to get 2,600 visits. We didn't think it was going to be that great, but they knew they were going to get patients in their door. That way they're getting that cost per employee that steps in there. So for them, they love us and vice versa. So yes, they're getting that extra visit, which puts money in their bucket, and then we're profiting because that cost has gone way down for us.
Was there one of the things in organization is the cultural change. Most of the folks that I deal with are benefits directors. I won't say they're just following orders, but the urgency at the C-suite is not there enough to create change. Was that an issue within your organization? Did you have to convince someone, well, we're going to do something a little bit different here?
Well, yeah, so, and I wouldn't tell y'all anything I haven't already told my superintendent, but a lot of I came from the business side, so a lot of our people in our administrative office were teachers that become a principal, that become an administrator. They've never dealt really with insurance. It's just, oh, this is what so-and-so told me to buy, or this is what I received last year, that's what we go with. So in rolling out this big plan, I'm on cabinet, so I would meet with cabinet and explain to them how it goes. But the great thing was they were so intrigued by what we wanted to do. And at first they were a little bit apprehensive. Oh, I don't think our employees are going to do it, and I don't think you're going to save this money. Well, boy, that happened in a year. So you always have that fear factor in the beginning. But the ladies that work for me have worked for me for a long, long time. They came to Beaumont with me and left their other jobs. But fear has never been a problem for me. To me, if you don't fear it a little, maybe it's not right. And when it comes to healthcare in this day and age, you need to fear a lot, but you need to lead your way, be that trailblazer, because if not, you're going to get that same cookie cutter that really does not affect the health of your employees.
The questions?
Can I ask a question?
Yes.
Can you talk through the reinsurance discounts that you're getting as a result of the capitation that you're putting in place at the primary care level?
I'm sorry, can you?
The question was the reinsurance discounts that you're putting into place. How is that working in the capitation model? Is that roughly the question?
Yeah, well, the challenge is it's not really defined to that because it is a program, and the reinsurance decrement is very strong, but it's a combination of what happens on the facility, the pharmacy, and the primary care. And really, quite frankly, the cost driver on the reinsurance side is what's happening on the hospital and the pharmacy side because, of course, they're buying the big claims. They're not buying the small claims. So the driver for the reinsurance really happens more on the contract that we have with the local facility and what we're doing on the pharmacy side to lower the saves on the cost on the specialty drugs.
I think there was another question here. There we go.
In the negotiation piece, I'm just wondering, how did it go with developing that contract? Is that something that 90 Degrees you specialize in, or do you have boilerplate contracts ready to go, or just how did that negotiation go?
I'm a recovering PPO contractor, so I lived in the world of hospital contracts for many, many years. And there are some areas it goes really well and some areas it does not go as well. That area went really well. It's a 2-hospital community. We, again, met with the hospital system, put an agreement in place. That whole time frame probably took 2-3 weeks, so it was not a prolonged. Now, a couple of things that go into that, and I mentioned it earlier, but it's really important. You can't, we're all in business. If I just come to you and say, lower your cost, you've got to bring me something, and hospitals are in the same boat. We've done in Beaumont, we have a very similar arrangement in Houston with Memorial Hermann. Some of the same dynamics in play. It's going to be really low cost member responsibility. We're going to take that off the table for you, try to pay you promptly, make sure you get cash in your pocket, and really drive through an EPO model. Now, that sounds easy. The challenge there becomes on the employer, and Houston's a really good market. You've got, probably in this room, Methodist and Memorial Hermann. If you're going to have every hospital system in your program at the same benefit level, and I'm the hospital, I'm not going to give you the rate that you need to lower your health care. I'm just not. So you've got to make some choices, and you've got to make partners. And when we say we partner with the hospital, it's truly a partnership. We're driving business. We're doing everything we can to create value for them because we expect the value back. And the biggest part of that is not just the contract rate, but the contract structure. When you're carving out, you're getting rid of those exclusions for implants and high-cost drugs and stop-loss outliers. And again, back to the question on reinsurance decrements, when you can go to your reinsurance carrier and say, this contract doesn't have a stop-loss outlier, it doesn't have a carve-out for implants, it doesn't have any of this language which really kills the reinsurance on the high-cost claims, they're willing to give you decrements that you can pass on to the groups.
And another offset to that was one of our cabinet members happens to be on the board of one of the hospitals that are under our program. And she came to me one day and said, hey, Peggy, the whole discussion last night was BISD and their new directed plan with us. They love y'all. They absolutely love BISD because they're getting paid like that. They don't have to file a claim. They don't have to have somebody take that itemized claim and just butcher it and send it back to them and fight over it. They're getting their money up front and they love it. So that's been another big positive for us.
We talked earlier, there was some talk reference-based, and there's that whole continuum of full network to full reference-based. Where we try to play and where I think there's a lot of value are direct agreements, narrow networks. It's hard in metro markets especially to not have any anchor facilities that you can steer membership to. It's a different conversation with a member going, hey, in Houston, here's where you're going. In Austin, here's where you're going. In Dallas, here's where you're going. San Antonio, here's where you're going. You go in the Valley, you go Corpus, you go El Paso. You can have those conversations. And then outside of that, play with cash pay models, single case agreements, navigation to get to those pieces. That works really well. We've seen the RBP plans struggle in just a pure RBP. Hey, good luck, go there. We hope they'll take you at the door because hospitals have figured it out and they just turn you away at the door. And now you've got a member that needs a service that's getting turned away at the door because of the benefit plan, and the message that comes back to the HR and the group is, boy, they just told me our insurance stinks and they won't take me. Well, I'm just a member. I'm just Bob. I don't understand anything about healthcare. All I know is what my doc's telling me. So, okay, I guess my health care stinks. So those models that have anchor facilities, narrow networks, those types of things, we've just seen have really good member satisfaction and still run financially very well.
This is true. We talked about House Bill 711 earlier. There are three main components to it, four, as Representative Frank said. The one thing that didn't pass, the hospital said we will not even sit down at the table if we have all or nothing, meaning if you have one hospital and one provider from that hospital system, you have to have everybody. That was taken out. But the opportunities through House Bill 711 allow now the removal of any clauses in contracts that prohibit navigation and steering based on value, which means price and quality. So anti-tiering clauses, anti-steering clauses by legislation are prohibited as of January 1. The gag clauses part, which hopefully you're doing this for your attestation, you're checking that they're removed, but your ability to see your data, your ability to understand how the negotiations are done, how the sausage is made, those are supposed to be removed now. And if you're not working with your consultant and your health plan to do that, and they're not asking you, let's have a sit down and look at this, I'd ask, why is that not happening? There was an article, and I know Memorial Hermann is represented. There's a really good piece. I don't know if it was in the Houston Business Journal, but it was Dr. Callender, Dr. Callender, who, along with the University of Houston, Dr. Spain, right? I got to pronounce that one right. Are talking about the need to move to value, which means getting rid of fee-for-service. We'll see how that works because that's what has to happen. And I just pulled this out of my briefcase. We're talking about the perfect time for change. This is just another example. I saw this on the 21st, which is, I guess, Monday. In the Keckley report, it's a nerdy journal, if you will, for folks who are in healthcare. But this came out in Paul Keckley's, the Keckley report. Payers declare war on corporate hospitals. Last week, 6 notable associations representing health insurers and large employers announced better solutions for healthcare, an advocacy organization dedicated to bringing together employers, consumers, and taxpayers to educate lawmakers on the rising cost of healthcare and provide ideas on how we can work together to find better solutions that lower healthcare costs for all. So this is 492 large employers, 34 Blue Cross plans, including Texas. We'll see where that goes. We're not going to be able to put the genie back in the bottle. One of the things I mentioned about HBCH, we're working on trying to work with health systems and hospitals to direct contract. But this has been caused through 30 years of vertical and horizontal consolidation. That genie is not going to be put back in the bottle. It will require legislative fixes like we passed here, House Bill 711. Again, you should all become aware of it if you want. There's a pamphlet on our table. You can pick one up and see what it does. And one of the messages on there, you should be working with your health plan and your consultant now because this can impact you and create great opportunities for you.
I'll just kind of close with this. The last Kaiser report said the average insurance premium in the United States for a family of 4 is about $21,000.
$22,469.
So it's roughly so do the math, that's roughly $1,800 a month. Now I want you to think about this. In Houston, Texas, now this was accurate as of about 4 months ago, so it may have changed. The average mortgage payment in Houston, Texas was about $1,600 a month.
Yeah.
So think about that. I'm serious. Perspective matters. Today, right now, this moment, as we sit in the room in Houston, Texas, the average person is spending more on health care than their house, their car, college. It is arguably the single most expensive thing people are purchasing in the city today. When you get to that point, and that and I'll say that sometimes to people go, well, yeah, but the employer's paying a portion of that. Somebody mentioned it earlier. Every dime that they pay is just a dime they can't pay you in salary. So that money is coming directly from you as an employee. When you get to the place that the single most expensive thing in your life is your health insurance, it's probably time to, aren't we obligated to at least look and try something different at that point? I mean, how long is that sustainable?
I think that's the message. And that's why we've got these presentations. You'll hear another one. One of our partners is Kelsey-Seybold. They're doing a lot of good work on this as well. And so that'll be our case study right after lunch. So we'll look forward to having everyone back here. Of course, you know me, I'll be shouting in the room there to get everybody here. But thank you so much for your attention this morning. We've got the lunch. It'll be served a lot more efficiently than it was last year. We've got a little bit different setup. So we'll see you all in whenever that is. Thanks.
Hi, everyone. My name is Dr. Donnie Aga. I'm the Chief Medical Officer at Kelsey-Seybold Clinic, and we're really glad to be here.
One other thing real quick. If you want, before he scans to that next slide while he's introducing, go back one. If you scan a conference website with your phone, you can get access to the bios for all our speakers, to the summaries of the sessions, to content, marketing content, for lack of a better word, PDFs, website links to Kelsey-Seybold, and other materials that may be of interest. So I just wanted to put that up there for a minute before you get started. Thanks.
All right, there we go. So glad to be here to present with Omar. Omar and Kelsey-Seybold have gone back a long ways, and we want to share a little bit of our healthcare journey with each other. Kelsey-Seybold as an ACO, and Omar has been gracious enough to send his employees and members of where he works to Kelsey. But before I started, I was doing a little bit of prep this morning, and I don't know if you guys saw that, but it was in my email this morning, the Aon report, which I thought very interesting, very timely for y'all's discussions at your conference here. But the title was Rise 8.5% in 2024. So employers' healthcare costs are anticipated to rise by 8.5% in 2024. This means that the average cost for an employee is now $15,000 per employee. The usual rise each year is 4.5%. And what's driving that is inflation. Inflation and all the things we do. And so I think this is timely that we talk about at least one possible solution for lowering total medical costs and helping our employers. So Omar, why don't you talk a little bit about Harris Health and who you guys are?
Well, thank you, Donnie. And I'm going to go back to that point that you were making about the rise in healthcare costs, because I was actually just having a conversation with our board this morning talking about the healthcare cost increase that we're seeing at Harris Health System. And so you're right. However, because of our great partnership with Kelsey and our great partnership with Cigna, our healthcare costs are only going up 3.5% for our employees. And so we are very proud of that. We are very satisfied with that. And we have, seen great results over the years. So in case I am Omar Reed. I'm the Executive Vice President, Chief People Officer of Harris Health System. You can see some information about Harris Health System up there on the board. We have about 11,000 employees. We have 2 hospitals, Bentab and LBJ. But the thing that is certainly I am equally as proud of is that we've been #1 in the Houston Business Journal healthiest employers for 2 years in a row. We were voted last year, 2022, America's healthiest employer. And in the state of Texas, we've been the #1 healthiest employer for 2 years in a row with the state of Texas. So we've had a lot of success in healthcare. I attribute that a lot to our relationship with Kelsey and the partnership that we have with both Kelsey and Cigna. And so we look forward to talking about some of our results. However, before we go forward, I have to say this. Does anybody in here watch Chopped? The show Chopped? Anybody watch Chopped? What about B. Bobby Flay? Anybody watch that show too? So my wife is like, she makes me watch those shows. She makes me watch those shows. That clock in the back is so intimidating, Chris. It is like really, I'm like, I keep looking at it and I keep getting distracted. So I'm gonna keep looking at my paper because the B. Bobby Flay things just keep popping up in my mind.
I think it's more like the show 24.
Yeah, I just like, wow. Yeah, thank you so much. I don't know who that guy is, but give him some money. Whoever he is, give him some money.
Exactly
Absolutely.
Right.
Thank you. All right, I'm good. I had to say that. Thank you. All right, go ahead, Donnie.
Okay.
Yeah, got it.
So who is Kelsey Siebold Clinic? Let me ask, raise of hand, on your way to work today, who did not see a Kelsey Siebold Clinic on your way in? It's almost impossible to miss now. We're now 37 locations, multi-specialty group, 750 docs and providers and growing. We listed kind of our recognitions and stuff, but I think the thing we're most proud of is that we were the first NCQ certified ACO in the country, and that doesn't happen by accident. It happens with a lot of hard work and kind of the formula that we use at Kelsey to drive lower cost care, et cetera. Let me Lisa, talk about a little bit what an ACO is, and then Omar, I want to get your impressions of this. So, an ACO, at least in our opinion at Kelsey, does not always have to involve a hospital or hospital system. So, as was mentioned earlier, we don't have any hospitals, we don't own any emergency rooms, we don't own any urgent care centers. But it's a healthcare organization to us that's kind of around two main principles. One is the right doctor or provider at the right time at the right location. And in doing that with the triple aim, and I see y'all have on your agenda to learn a little bit about the triple aim if you don't know that later today, and that is evidence-based quality care, also at a lower cost, and do it with happy patients. And that's the hard part, but if you can bring all that together, it's a secret sauce. What is the accountability though? So at Kelsey, we feel like we're not only accountable to our patients to deliver this model, but we're also accountable to the health plans. We're accountable to our employers who choose to bring us those patients. And those accountabilities are very important to us, that we succeed and we work together with our employer partners, whoever that may be. Now, Omar had his first experience with Kelsey at the city of Houston, so going way back, and then moved to Harris Health. So you had a chance when you moved to drop Kelsey as your ACO, but you didn't. So tell the audience about your thought process in choosing an ACO or an organization like Kelsey to be your healthcare provider. And then what have you seen as far as the ACO model work for you?
Well, thank you. And I'll talk about as you talked about the triple aim, as we have moved from the city to Harris Health System, we also had a triple aim, and that was affordability, accountability, and accessibility. And so that was very important for us as an employer to make sure that those things were in place, those themes and things are in place for our employees. Accessibility, I got people all over, and so we need to make sure that there are opportunities for people to have services rendered when they need services rendered. So certainly important. Accountability, we expect our people to be accountable. We want them to, and affordability, public servants don't make a lot of money, and so we had to make sure that we partnered to make sure we got the best bang for our buck. And so we have been very satisfied with those intersections between the triple aim that you talked about and the triple aim that we seek to balance as an employer, and making sure that those things are provided to our employees.
Yeah. Well, we know that when we're working with an employer partner, that there are certain expectations of the things that we need to do. And I think our partnership, especially with Harris Health, We look at those chronic diseases, those conditions that lead to higher costs, and how you can engage with those patients to get better outcomes. I think the stats that you have for your employees at Harris Health, as far as diabetes care, asthma, heart failure, kidney disease, and hypertension, is remarkable, and it's something that we would hope we could reproduce elsewhere. How do you get your employees engaged to participate with your ACO partners to get them to come to the doctor?
Well, thank you for that question. And I wrote down this quote because I wanted to make sure I got it right. And it says, the greatest hindrance to tomorrow's success is today's success. And so we are always focused. And I'll tell you, I fear, Amanda works for me, Amanda Jones, who's on the board, can tell you, I fear complacency more than I fear failure. And so we are always pushing to make sure, and oh, by the way, I'm a data nut. I'm a nerd. I admit it. I like to have data to make decisions, and the decisions from the information that we get from Kelsey. And we started off with this motto: can we keep the people who have chronic conditions from getting sicker, from going from chronic to acute and catastrophic? Because that's where you start seeing a lot of the costs escalate. And also, by the way, can we keep them out of the most expensive place to treat somebody, which is the emergency room? And so we've been able, through our partnership, so as you can see on the slide up there, to make sure that those chronic condition visits, the visits take place. I think it might be on the next slide when you start talking about visits. 86% of our employees are enrolled in our wellness program. And so that helps a lot because that wellness program is driving results. How do we do it? The carrot and the stick method. So we offer a discounted rate to persons who participate in our wellness program, so you can get a discount on your premium, but you can also get your chronic condition medications for free. So if you have hypertension, we give you your medication for free. If you have diabetes, we give you your medication for free. We've also partnered with a group called Livongo. If you've heard of Livongo, we partnered with them. We were one of the first clients that they signed, large clients that they signed up, and our results have been absolutely amazing because we have people who's checking their A1C all the time, and if there is an elevated A1C, there's a notification that goes out, and so our persons who are participating in Livongo and also, partnering with Kelsey, we are able to monitor those conditions and try to keep people healthy as opposed to watching them move to acute and catastrophic.
And we do on our side for these chronic conditions, we have our own disease management programs that we outreach as well to get those patients engaged and to come in. Your wellness and your physical results are incredible as well. I think if you pan the audience, there's no way that over 80% of you have had your physical in the last year. And if you were a whole group of doctors, it's probably less than 25% have had your physical in the last year. So getting people in for their wellness exams are super important. And I think, to be one of the healthiest organizations to work, in Texas and in Houston and the nation, it doesn't come by accident. So how do you do that?
Well, we talk about it a lot. And one of the things that I know, and when I started at Harris Health System, what we said was the people who take care of people don't take care of themselves. And so we started with that premise, and we started with communication campaigns. We started with going around old-fashioned conversations. We have champions all across our organization, strategically located, who have conversations. And so when we send out a wellness blast, which we send out every single Monday, there is a response to that wellness blast, whatever it is. Here's how much time you have to accumulate your points. Here's some things we have coming in. So we believe in taking care of, certainly physical, but we have a whole wellness program that's designed for total health, total wellness, which is mind, physical, and spirit.
So dollars and cents, right? You can do all this, but do you save money and does it work? And I think your numbers are also, if you compare the ACO population at Kelsey versus the fee-for-service PPO, at your organization, it's 27% less. In general, the Kelsey Care plans run between 15 to 30% less in total medical costs compared to their PPO and fee-for-service peers. Two areas that I think drive that, and this is one metric is it's difficult to understand. You think it's a fluke, but it happens year after year after year, is the catastrophic claims. And so those are those spends over $50,000 for, you have one motor vehicle accident and, there you go. But I think Kelsey's system of how we manage inpatient hospital with our hospitalist and making sure that we have time to see those patients multiple times a day, to have case conferences, family conferences, good discharge planning, and also having those difficult conversations whenever you need to. But also those kind of conversations also happen in the outpatient setting. And so I think those help lead to those conversations that lowering those catastrophic claims. And then the last thing is, I think...
But before you
yes,
go past that, let me just jump in and tell you how that practically impacts employees in their day-to-day life. So I told you, you could probably remember, it wasn't, I don't see the clock anymore, but it wasn't that long ago. I just told you our costs had went up, our employee premiums went up 3.5% this year. But I'm gonna give you another statistic. That's the first premium increase we had in the last 2 years. So for the last 2 years, it was 0 and 0, and this year was 3.5%. That's all directly attributable to a relationship that we have with Kelsey and the way we are able to control the costs.
And this is big. I don't know if you guys have talked about this.
Can I just ask a quick question?
Yeah.
Go back to the previous slide, because I saw something that kind of freestanding outpatient facilities. Are you saying that the procedures referred by Kelsey for colonoscopy, joint replacements, or radiation oncology, that is the percent referred to freestanding locations?
Outpatient.
Freestanding outpatient locations?
That's right.
Hospital or freestanding?
So some of it is freestanding. We have our own ASCs, ambulatory surgery centers, where probably the majority of this happens. The other thing, especially like joint replacement, it's we're moving that into the ASC, and that was on my next slide to talk about, is that place of service is a huge deal. How do we pull things out of the hospital? First step, don't make it inpatient. Can you make it outpatient? Second step, if it is safe to be done in the ASC, you do it in the ASC. Third step, if it's safe to be done in a procedure room, we do carpal tunnel syndrome, carpal tunnel repairs in an exam room now. Doctor just washes his hands, a little anesthetic, you're done in 5 minutes. And that savings not only is for the total medical cost, but lower copays for the patient. They're not paying inpatient, they're not paying ASC, they're paying, their visit type to go to see the specialist. So we have a huge effort now. We're expanding our ambulatory surgery locations. We're doing more and more. We're doing gallbladders routinely in the urgent care, not in urgent care, in the ambulatory surgery centers. But we're really pushing the envelope on anything we can do not in the hospital.
And that's the key. I mean, navigation, focus on that. If we can do something in a non-hospital setting, the better off. There's no question that that is the highest cost bucket for every employer.
That's right.
Is hospital services, both inpatient and outpatient.
Absolutely. So you're right, Chris. Thank you.
So ER and inpatient, obviously big spend. And so we know, at least post-pandemic, that the criteria or the threshold to get admitted to the hospital is everyone's trying to make their money. I mean, it's just part of it. And so if you go to the hospital, your likelihood of being admitted to the hospital is now 40%. So how do we keep you out of the ER? How do we keep you out of the hospital so we can manage you outpatient? And these are strategies that we're working on every day. That includes having access to your primary care doctor, same or next day, having access or a plan when your primary care doctor is not available, which may be 24/7 virtual health. It may be going to an urgent care as opposed to an ER. It may be we bring the urgent care to you if you don't know Dispatch Health, great vendor as well. All these things to keep you out of the emergency room. And I'm sure you guys have seen that too.
Well, I'm going to tell a little story here. My wife got bit by fire ants. And the fire ants, she had a reaction to the fire ants, and she was able to use telehealth to get a prescription called in. So it is absolute, it might have been an ER visit at some other time because they were looking pretty bad, but certainly because we have Kelsey, she was able to take a picture of it. Kelsey Doc came on, and so those types of things help to keep the cost down. And so we're very appreciative. I will also say we have a deliberate and intentional strategy inside of our organization to try to drive more people into Kelsey through our premium structure to make sure that, they can go to PPO if they want to. We do have PPO, but we deliberately, intentionally try to keep that premium for Kelsey. And that lady back there in the purple, if you have any questions about anything I'm saying, she can answer them all in detail when I leave, okay?
That's Amanda Duncan-Jones.
Amanda, absolutely.
She's great. She's also on our
She is
our
on your board.
Hey, Omar, what is the percentage on the Kelsey care versus the PPO? And I know that has been rising steadily over the years.
Yeah, so right now, 60% of our employees are in Kelsey Care. So we continue to try to, is that right, Amanda? Okay, I have to check with her to make sure that's right, yes. 60% of our employees are in Kelsey Care.
So, and then finally, you do all this, the last thing you want is complaining patients, right? They go to the HR, they call their health plan. Do we make the patients happy and want to continue to do what you're doing, right? And so we all measure the Net Promoter Score. If you're not familiar with it, it's the ones who really like you, minus the ones who really hate you, and then in the middle, you're ambivalent. And so I put some examples of common Net Promoter Score. So HEB is 65, Southwest Airlines, this is probably before December, January, 48. These numbers are Harris Health patients, Kelsey-Seybold. It's extremely high Net Promoter Scores. We use a vendor called FeedTrail, and we're doing real-time information, data collection, and pinging our patients. Sometimes it's right when I'm talking to the patient, they're getting text, how's your visit going? But we're trying to really make sure the patients have a good experience, and then if there is a problem, we try to attack it immediately.
Well, that's extremely important because I don't want the employees calling me, because I call Donnie if they call me. So, but yes, it is extremely important, and we want our employees to be satisfied. And any time we have any type of challenges, we are able to reach out to our Kelsey representatives and have great conversation. This is our last slide right here. I don't know how much time. Can you take that jacket off? I'm really intrigued about how much time I have left. All right, yes, absolutely. All right, absolutely. I'm starting a plate right now, in case everybody who knows I'm starting my plating right now, okay? All right.
I think we can take some questions. Is that all right?
So, questions for Kelsey-Seybold?
Thank you both. That really great and amazing results. So I know the goal is to keep people out of the hospital. And so I'm interested in what you're doing to reduce your hospital costs, your high-cost claimant costs. Are you just working in the Cigna network? Do you have any direct contracts or any ways to kind of reduce your costs?
Yeah, it's all with the Cigna network, so we don't have any direct contracting. I know Chris keeps talking to me about, this is the way of the future, and so we're looking to see what that looks like. So I appreciate the fact that this dialogue continues to go on, and we continue to have conversations about the future of healthcare. So we don't, but it's all through Cigna network right now.
And I know we've had multiple discussions with Kelsey, trying to move things along.
Yes.
As we heard from several different folks, you can have a PPO, you can do direct contracting, doesn't have to be an all or nothing. But the issue with us on the direct contracting has more to do with negotiating for hospital services more than anything else. Again, in Houston, hospital services, median price employers pay is 316% of Medicare. We think there's some room for improvement, and we'd love to work with the hospitals directly or indirectly.
And Kid Yonda over there too is like a guru at that stuff.
I want to say that Kelsey Care products, we do our own direct contracting with the hospitals.
So, Omar, with your award-winning wellness program, do you integrate that at all in some way with Kelsey Care? Or Kelsey, do you have some prevention wellness type programs that are then passed through to Harris Health?
So there is a collaboration, and there is certainly intersection, and so we have something going on, and Kelsey is able to send a blast out through their My Chart system to our employees and say, hey, October's focus is whatever care it might be, and so there is a partnership and a collaboration that takes place.
That's not always common, and that is fantastic. I listened to a podcast yesterday that focused on those payer-provider partnerships that are really successful because, quite frankly, the doc is trusted more than the insurance companies.
And the employer, in a lot of instances, the doc is trusted more than the employer. So to be able to get that information through that portal is extremely important, and it's a process that we have been able to put into place.
Yeah. Holt and
we have over 85% of our patients are online with us on our portal.
That's the buzzer, so I'll be quick. We are in the Dallas area. Is there something, I'm not familiar with something like the Kelsey model, and is there plans to expand to other regions?
So we are expanding as fast as we can. I think you saw our slide, 37 locations. In the next 2 years, we'll be up to 61 locations. We've gone as far north, breaking news, to Huntsville. So you can call it South Dallas if you want. But we're working our way. But I think there's so much work to do here in Houston that's where our focus is right now.
Yeah. Anybody else?
I just want to say I did an evaluation for an insurance company of like a few hundred point solutions last year, and the point solutions, or NPS, like there was only 2 that have exceeded 92. That's pretty impressive. What do you think was the main thing that you've done to achieve such a high NPS score?
Yeah, so I think the main thing that is different is the instantaneous feed and then instant monitoring of a negative and trying to turn that negative around to a positive. As opposed to waiting several days, you get your survey, they may not return it back, et cetera, and then it might be too late to do kind of a recovery type action. So I think recovery and real-time actions is the key.
Okay, well, Kelsey's going to be around here. They have the biggest booth right out the door here with several reps. Again, talk to them, and Dr. Aga, and wonderful for you, and my buddy, good to see you again.
All right, well, it's time to take it to the judges. You all are our judges, and so we'll see how you like our food.
One of the things that I've heard, and I know Kelsey's doing this, by the way, on their Medicare Advantage program, is a lot more home health. That is something that's going to be more and more common. And so I wanted to have a session that focused on home health in a particular area. And I happened to become familiar with the lactation network when I was at a national conference in DC a few years ago. And in the last year, I have educated myself about the importance of lactation, and I'm the guy in the room, asking all the questions. And it is so valuable. We are working actually with the Center for Houston's Future on an event that involves a maternal care project, and so I've even become more immersed in this. So Kim Kozany is with the Lactation Network, who I've known for a little bit now, and Johnsy Holt she is with the Nashville public school system. I may have butchered that a little bit. They are, without question, one of the top leaders in innovation in this country when it comes to school districts thinking, what can we do? I mean, and it's almost all through direct contracting, and yet you still have the PPO. So I think you'll enjoy this discussion.
Thanks for having us, and thank you for the beautiful weather that you've provided for a Chicago girl here visiting Texas this afternoon. Really looking forward to sharing a little bit with you the work that John Z, her team at Metro Nashville, and the Lactation Network, or TLN for short, has really collaborated well on to provide care to mothers and their babies in a really vulnerable time in their life. Many people don't know that over a decade ago, the Affordable Care Act mandated breastfeeding support as preventative medicine. So what that means is it should be as easy to access lactation support as it is to see a primary care doctor. It also means that there should be no out-of-pocket costs associated with that care for the family seeking out that treatment. Really sad, most health plans offer in some capacity, some not at all, support for mothers in this fashion. Most often, though, we find when partnering with employers that their networks for this care are severely inadequate if they exist at all. So a lot of the work we're doing is partnering with employers to ensure that throughout that prenatal and postpartum period, mothers have access to this care. So ultimately, they're feeding their babies however they so choose, and they're also coming back to work in a way that alleviates stress and mitigates anxiety, as well as postpartum mood disorders. So with all that to say, the misconception about breastfeeding is that it's free, it's easy, it's a body's biological response, and you should be able to do it because you are a woman or a lactating parent. And that is so far from the truth. We know that 92% of the people that choose to breastfeed have issues within the first 2 weeks of bringing baby home from the hospital. So not having access to that care ahead of labor and delivery or knowing who to call means that it's 3 in the morning and mom and dad are Googling, right? Parents are Googling for solutions. And if they're having to pay out of pocket for it, oftentimes they're foregoing that care altogether. So we're really eliminating a choice from that family on how they'd like to feed their baby. And as Crystal mentioned, John Z, David, and the team at Metro Nashville have done a beautiful job building a really all-encompassing maternity bundle, in addition to just an extensive wellness program. And I couldn't be more excited to have you share a little bit about both of those programs and how you've developed them.
Yeah, thank you, Kim. Yes, I'm from Metro Nashville Public Schools, so I know we're not local to the Houston area, so I'll just take a minute to kind of explain where we are. We have about 6,000 teachers on our health plan, about 12,000 covered lives on that health plan. If you include our under 65 retirees, it's about 18,000 covered lives. Some of the things I'm going to talk about today are specifically around our teachers' self-funded health plan and some are population-wide. We started out, as Chris mentioned, we are pretty innovative when it comes to benefits design. We started in 2009 with our on-site healthcare centers, and so we've been operating them for 14 years now, and so we have 5 on-site healthcare centers across our county, Davidson County, strategically located within 15 minutes of any work site with no more than a 15-minute wait. Our healthcare centers encompass care for our employees that's offered at no charge to them. They have no copays for primary care, health coaching, physical therapy, chiropractic care. We have personal trainers on staff for employees and on-site behavioral health nurse practitioners who can prescribe medications for behavioral health needs as well. So we have a really holistic approach to healthcare and really believe in treating the whole person, not treating the condition. And we've put a lot of things in place to support that model. I'll talk specifically about the things that we have in place to prioritize maternal health care. So a couple of the things that we started with, we are with Cigna, and we do participate in their Healthy Pregnancies, Healthy Babies program, and so we incentivize parents to engage with that program with a maternal nurse and get that advice early into their pregnancy, and they earn incentives for that. In 2019, we partnered with Progeny Fertility, and so we cover fertility services for our employees. We know that, our population, we serve teachers. We have a lot of growing families. We see about 250 babies a year. Our average age is 42, 32 for expecting mothers, And yeah, so lots of babies happening, and people need a lot of support when it comes to infant and maternal care. So we partnered with Progeny, and from the perspective of it's the right thing to do to help support a growing family, and from also the mental health perspective, when a family's going through fertility struggles, that's not only hard on you physically, but mentally as well. And so we're trying as best we can to remove as many barriers to care as we can. So that's why we entered into that partnership with them. From there, our on-site clinics are through Vanderbilt University Medical Center. We are staffed by board-certified nurse practitioners. And so to build onto that contract, we started our My Health bundles. The first bundle that we launched was My Maternity Health Bundle. And so the way that bundle works is the new parent who, when they find out they're expecting, they can engage with their healthcare provider through Vanderbilt, their care all throughout their pregnancy, the delivery, postpartum care is all bundled, and it is no cost. And so they never receive a bill for anything related to the birth of their child for a regular delivery. So they don't have to worry about that. Our tagline is, welcome a bundle of joy without a bundle of bills. If you've ever had a child, you know that you keep getting bills in the mail forever after you have the child. And so that's, again, stressful. All of these things we're taking into that mental health perspective. Teachers are short on time. They have a lot of things that they're juggling, and they shouldn't have to worry about these things in order to get that health care that they need. So we started that in 2020. We have about 100 to 120 births through that maternal health bundle every year. And then, entering into some of our new things, before I get into the lactation network, we're going through integration right now with Mama Lift, which is a self-guided app that new mothers can use that gives you tools and tracking abilities to help avoid postpartum anxiety and depression as best as possible. So it's a self-guided thing, and it's just a tool. But we're adding that to our bundle of care here. And then we're excited that we are currently in implementation with the Lactation Network. You probably might look at this and say, well, you guys got a lot of maternal health things going on. Do you need one more thing? And the answer is yes. We have our own data warehouse, and so we look really closely at all of our health needs within our population to identify gaps in care. And then Kim and David, my executive director, met at a conference and started the conversation about lactation consultants. And so we know under Cigna that service is covered for us. But the first time that I ever talked with Kim, she shared with us, she was like, yeah, it's covered, but if you take a look at if you search in Cigna right now for care, you don't see anything. There's not anything in your network. So note from that, don't take for granted that just because it's covered that you have access to care. You have to dig a little bit deeper into that. So we learned that. And so Kim shared with us, overnight when we enter a contract, it gives your employees access to 80 lactation consultants. From day one, which is awesome, and that's huge. That access to care is just incredible. And another thing about the services that they offer that makes them unique is not only can you see a lactation consultant in office or via a virtual visit, they also offer home care, which if you have experience with a breastfeeding mother or you've been a breastfeeding mother, the first days it's tough. It's tough, and maybe you don't want to get on a virtual call and have to do all of those things virtually. And maybe you have other kids, or you don't want to get yourself together to go to the hospital and see a lactation consultant in the hospital. So the ability to have that consultant to come to your home and offer that care that is going to be so impactful, the beginning of your journey in motherhood, and help with those outcomes if you're wanting to continue breastfeeding but you're having trouble, it can make all the difference. So when we're looking at adding the best in class services for our employees, looking at things like, yeah, there's other lactation services, but that home care, I think really was, for me, I was like, wow, that's what sets it apart. And I think it's the best service for our employees.
Thank you.
Yeah.
I know we're here in Houston for the first time, so just a little bit about the Lactation Network. We are the largest network of lactation consultants in the country, in the world, but we'll just stick with country for the sake of today's conversation. We are in all 50 states, DC and Puerto Rico, and we have 2,200 clinicians growing at a rate of about 50 to 100 each month, all of whom have an IBCLC level of education. And if you're not an expert in breastfeeding support, which I'm going to take a shot in the dark and say not many in this room are, that is the highest level of education you can receive in breastfeeding care.
What does it stand for?
It stands for, thanks for asking, Chris, it stands for International Board Certified Lactation Consultant. Close to 50 of our practicing clinicians are also registered nurses, doctors, dietitians, physical therapists, speech therapists. So we know that it's a very highly sought after level of education when we're looking at this type of care. And as John-Z said earlier, I think one of the key differentiators for us is that we see 88% of our patients each and every month in the comfort of their own home. And for many of the reasons John-Z stated, it is a very vulnerable, stressful time for a mom to have to think about leaving the home to take their child and or multiple children perhaps to seek out care. Sometimes telehealth, although that is a modality that we offer if that's the patient's preference, it could be uncomfortable. To observe a feeding, there's often disrobing that is happening. Doing that in front of a computer or over the phone may not be the most comfortable for the patient. So knowing that we're able to meet our patients where they'd like to be met is something that we are super proud of. And if you were to Google the Lactation Network, we've got over 2,000 five-star patient reviews. Our NPS score, since it was brought up earlier, is 97.
Competition.
I know. I made them redo the math like 6 times when I started. I'm like, there's no way that's the NPS score, but I'm super proud to share that figure. As I said before, we are in all 50 states and DC. We pride ourselves on being to deliver in-home care. And implementation for an employer is, I'll let John-Z speak about it, so it's not just me up here pontificating, but we try to make it as easy and as seamless as possible to add our network of providers in with the health plan offering you're making available to your employees today. Would you say, is that fair assessment?
It is fair, yeah. I do a lot of implementations with point solutions and different healthcare services, and we're in the implementation phase right now, and let me just tell you that if you've met with vendors who have it together and those who haven't, if you've been in this space, but they have their marketing materials ready to go. They have their messaging, catered to our population in a way that's helpful and really makes that implementation easy for us as an employer and easy to digest for our members. And so the implementation is really, we expect to be seamless. And it's covered by our health plan. So we bill it, it's billed as a claim. So yeah, it just increases that access to care that we were already, in network to pay for anyway. So we have a direct contract with them for a service that is provided under our plan.
And when you're looking at cost or pricing, I know that's been a theme of the day. The visits, it is a fee-for-service model. So as an employer, you're only paying for the visits that are utilized by the new parents or families that are within your health network. And as John-Z said, we're able to administer as a claim. So if you're self-funded and you have autonomy over your health plan, and you're noticing that your network may not be as adequate as you'd like it to be, it's really easy to add a partnership in with the Lactation Network to expand that access to care. And if you're smaller and fully funded, there's a way for us to invoice you directly so that those employers are going without care. We've got partners that also cover those that don't fall underneath the health plan, and we're able to invoice for those folks directly as well. And as we alluded to earlier, it's all about choice. By giving patients a choice to see a provider in person, in their home, in a clinic, or virtually, allows them to meet with a provider in a way that gives them comfortability, and with a dedicated IBCLC throughout your feeding journey, what we'd like to do, or our clinical recommendation, is matching that new family with a lactation consultant ahead of labor and delivery. That allows us to give the patient somebody to call on if they need a patient advocate during labor and delivery. We know only 1/3 of the hospitals in this country have on-staff lactation support while you are inpatient. So knowing that there's somebody there to have your back if you need them during that 2 to 3, however many days stay, is important. And then when you're coming home from the hospital, right, 48 to 72 hours later, we want to be there with you. So by knowing who that person is and having that appointment pre-scheduled, we're eliminating a lot of that stress and anxiety from the new parent. And then that third visit that we clinically recommend is, how do we plan for going back to work? In the case for many of Johnson's teachers, you have to figure out when to pump, how to pump. Do you have space? Do you have time? It's different for each and every parent, and knowing that you've got somebody you can call or lean into to help you plan so that you can go to work and feel like you've got some support in a solid way forward, allows us to, above and beyond impacting positive health outcomes for mom and baby, we're helping employers attract new talent. We know that's a big thing that we're focused on in the employer space today. We also know that the people that are there, we're supporting a lift in productivity. We know that parents of formula-fed babies, more often than not, are taking more absence away from work because those babies are more susceptible to things like ear infections, asthma, allergies, GI issues. So ensuring that when they're coming back to work, they're able to be as productive as possible is important. And then ultimately staying at work, right? I think the most recent statistic is that 53% of parents that take, or mothers rather, that take parental leave end up leaving within 90 days of coming back to work. So how are we helping employers keep those folks coming back to work and staying there after they've taken leave or short-term disability or a combination is something we're hyper-focused on helping benchmark for our employer partners.
Yeah, and just to add, I think when she was talking about the model that they recommend for visits, that return to work visit with their lactation consultant, that was a big thing for me too when I heard about that, because teachers are in it. I know some of you guys are from education, and teachers are in a unique situation where they have a classroom full of kids every day, and it's really hard to schedule. And so they have that consultant that they can speak with about their individual circumstances, and they can work with them to develop a plan that's going to work just for them when they return to work. And I think that's so important because it seems that it's easy to go back into work and you think you're ready, and then the schedule's not working out, and it's easy to just be frustrated and give up. So knowing that you have that trusted relationship with that person who can give you support, I mean, it's federally mandated that they receive access to space for pumping as they return to work. We have policies through MNPS, through our local government and the state. And so, also giving them the tools to feel like they can advocate for themselves when they go back. Like, this is important to me, and be educated on the ways that they can continue their journey and have a plan going into it.
Yeah. And just a quick addition to that, we know that 59% of people who take leave come back in any capacity. Our retention rate for those that participate in the TLN employer program is 92%. And I attribute a lot of that to helping new families and mothers plan in a way that feels customized and individualized to their unique needs and the needs of their family. And this clock, it is overwhelming, but I think I'm doing a decent job. We're at 5:37, and Chris told me I had a hard stop at 5, or I would be told to be quiet. A couple of things you can do as an employer, as some actionable next steps. The first is just get curious. Put yourself in the shoes of a new parent, hop on your health plan, and see what's available. From there, start conversations with your brokers, with your health plan, with your benefits teams to figure out if that coverage is adequate. And if not, let's do something about it. I'm more than happy to take a call. I don't know if I want to fly back down here necessarily, although my colleague Kim, she sits in Dallas, so she's nice and close, and I volunteer her as tribute to come and make the trip back down to Houston to meet with anybody in person. But we're more than willing to make sure that you're able to easily expand access to this critical care for the folks that I know you try real hard to take care of every day. And thanks for having us. It's been great.
Any questions? As I said, I've just been immersed in this for a little bit here, and I've learned so much about the positive benefits of maternal care programs.
So was looking at your website while we were on this, and I saw that it also lists a bunch of breast pumps on there. Is that part of what would that look like if I was going to engage with a lactation consultant? What's that look like from my perspective, and is there assistance like helping figure out what's the right pump and things like that?
Yeah, absolutely. A lot of our patients ask for guidance on if you've ever been a new mom, or if you've had a friend or a family member try to figure out which pump is best for them. There's dozens in the marketplace today. So a nice benefit to the Lactation Network is we do have a sister company that is a DME for breast pumps. That allows us to ensure that we're checking insurance coverage, understanding patient needs. Again, as an MPS teacher, there's pumps that are silent that you can wear super discreet under your clothing, so that if you're a teacher and you want to wear that in the classroom, it's not super disruptive or distracting. So a typical visit for back to work, right, or even prenatally could be recommending a pump based on your unique needs. Other things that are taken into consideration is baby's weight before and after feeding. We screen for mental health, postpartum mood disorders. We know 1 in 8 women now suffer from some level of postpartum mood disorder post-pregnancy. So being able to be one of those first clinical points of intervention coming home from the hospital is something we pride ourselves on. Looking for things like jaundice and tongue tie in babies, latching, weaning, right? And even if breastfeeding is not for you, you're still lactating as a new parent. So how do I make sure that I'm able to mitigate that in a safe way? Those are all some common things that we address in our visits with our patients.
Do you work with all major carriers, TPAs? Have you had any problem with them accepting the network on top of the network?
So that's a great question. For self-funded employers, that health plan is yours, right? You have autonomy over what that network looks like. So we've not encountered a challenge yet with a self-funded employer who wishes to have this baked in or added into the network in addition. For fully insured employers who don't necessarily have that level of independence or authority over their health plan, we're able to bill them directly each month to help counterbalance or counteract that ghost network that they may experience.
Actually, I have a question going back to what John Z was talking about earlier about the bundle payment program with Vanderbilt. So the way your benefit plan is set up is women can go to other network providers, but if they go to the Vanderbilt clinics, then they have less deductible co-payments.
Yes, yeah, exactly. Yes, so we have multiple bundles. Maternity is one of them. They, of course, have the freedom to choose any facility that they would like. We have a lot that are in network and a lot in Nashville, but no payments. It's completely covered if they go to Vanderbilt.
And did Vanderbilt work to set that up with you guys, or was there one of the other? I mean, there's some companies now that are starting to do that in the maternity space, and I was just wondering.
Yeah, we did.
Who you worked with?
We did it directly through Vanderbilt.
Okay.
Yes.
Thanks.
Good, a lot of questions.
Well, first of all, I just want to applaud you guys for supporting women professionals. That's amazing. And then second, in a time where maternal morbidity is at one of the all-time high, have you guys seen an impact in that or any kind of measurement with your program?
So what we know to be true is that, I didn't know this until I started working at the Lactation Network just about 2 years ago. Suicide is the second leading cause of death for a mother 12 months postpartum, and that first year after giving birth. And we know also that if you are exclusively breastfeeding, if for that recommended minimum that I had up on the screen earlier, 6 months. That's sanctioned by the American Academy of Pediatrics, the World Health Organization, CDC. You're mitigating or offsetting the risks of postpartum anxiety, postpartum depression by 89%. So the longer that we can help encourage those parents to breastfeed in any capacity, we know we're able to mitigate those risks as well.
Any other questions? I have one.
Oh, no.
No, again, this is more a testament to what Nashville is doing. Schools are not rich.
No.
They really have to be judicious of their funds.
Yeah.
You provide a lot of free stuff.
Yeah.
How much of what you're able to provide is due to the courage of folks like David, who said, we're not going to do the same old, same old.
Yeah.
We're putting these on-site clinics in because they save us a boatload of money, and we're able to do these other things. If you could speak to that for a minute.
Yeah.
Somebody's looking at the bank accounts here.
Yes, they are. Yeah, like I said, we're very innovative. David Hines, if you've ever heard him speak at a conference, he's my executive director, and so I'm honored to serve on his team and do this work together. But we take a lot of risks, and we do a lot of things that no one has ever done before. But most of the time they work out really well. So like I said earlier, I mentioned that we have our own data warehouse. And so we do make informed decisions about these crazy new things that we're putting into place. But not only in terms of ROI, but in terms of the outcomes that we're seeing as well. Like our maternity health bundle right now, we're operating at a break even on that, but we're seeing those increased outcomes. Our C-section rate is down 34% for women who deliver under that bundle. So of course we take the money seriously, and we have to, and we have to keep those rates low as well. They were just talking about the rate increases and not having increases every year, and we didn't have an increase during COVID. And teachers, they get a cost of living raise every year and usually a step raise, but we have to be careful to not counteract that with rising healthcare costs. And so we're very cognizant of that, but being innovative has worked out in our favor. So don't be afraid to take some chances to best serve your employee population and get them the best outcomes too.
That's the point I wanted to make, and I'm glad you made it that way. It does take a little bit of a risk and a little bit of courage, but you usually find that pays off, not just this session, but the sessions you're going to hear after this and the sessions you heard before. These are things I'm asking, how many of your consultants are bringing these ideas to you? Is your health plan coming to you with these suggestions? And I'm not saying maybe it's a two-way street and you bring these to them to get them involved, because there's a lot of good stuff happening out there, but sometimes you've got to help navigate the ship to make it go where you want to, and your opinion matters. So I want to thank these folks and then say a word. So thank you so much again.
Thank you.
Our next session, and we've got folks coming on in, is on the pharmacy side. And I can't remember how I heard about this, but the big three are ESI, Optum, and CVS as the PBMs, and there's a lot of, they have probably 80% of the market, maybe more, a little less, I'm not sure, but close to it. But there's growing frustration with the lack of transparency in PBMs, and I won't name the company, but a major pharmaceutical company invited myself and about a dozen other employer leaders from around the country to get the employer's perspective of pharmacy. And I'll say that it wasn't necessarily what they had hoped to hear. A lot of positive stuff, a lot of courage for putting this together, but the transparency seemed to be rising to the top. And much like in hospital transparency with the NASHB and the RAND studies, there's a lot of a lot more opportunity there because of that transparency. We think that should happen in the PBM space. And so I got to know Josh. Well, he'll describe his company here, but I think they're one of the leaders in this alternative space, and there's a lot of large employers who are seeing the light, if you will. So with that.
Hey everyone, Josh Golden, Senior Vice President of Strategy with Capital RX. It's a pleasure to be here today. Thanks, Chris, for the warm introduction. I think she's got the clicker. I used to say that Capital RX was a small, disruptive PBM in the industry. I can't really say that anymore. In a relatively short period of time, we've grown to now represent over 2 million member lives and over 200 clients that have moved largely from big, entrenched, traditional PBMs to our fully aligned PBM model. It is a reflection of, we believe, where the industry is going, and all leading indicators point there. Things like the FTC investigation of the large PBMs, which Karen will, I think, touch on, as well as state and federal laws and regulations that are quickly developing, all of which seem to really challenge the status quo of how business was done in this industry. So my job here is to mostly get out of the way and let Karen tell her story of her journey of through the industry and how she ended up deciding to partner with Capital RX.
Awesome. Thank you, Josh. Hi, everybody. I'm Karen McConnell. I'm the System Vice President of the Pharmacy Enterprise and Chief Pharmacy Officer at Common Spirit Health. Just to give you a little bit of information about our company, we're actually one of the largest not-for-profit health systems in the country. We really are a house of brands, and so St. Luke's here in town is one of our brands. We also have Virginia Mason up in the Pacific Northwest. We have Dignity Health in California and Arizona. We have Centura in Colorado. So we're really all over the place. So we have 143 hospitals in, 21 states. Sometimes it changes because we do a lot of M&A and divestiture, so I just wanted to see what number we had on the slide here. We're a $34 billion operating company, and we actually provide nearly $5 billion a year in charity care. So us being nonprofit, we really put our money where our mouth is. We take care of a lot of indigent patients to make sure that they get the care that they should be getting. So I took the VP role about 2.5 years ago. And at that time, we started thinking about what do we need to do to make sure we're optimizing our pharmacy costs. So we have a lot of inpatient hospital pharmacy costs. We have 40 retail pharmacies. We have 2 specialty pharmacies. And then we have clinical pharmacies that work across the spectrum of care. And so we had actually a lot of opportunity in a lot of different places. But I partnered with our employee benefits colleagues because previously pharmacy really hadn't been involved in our PBM selection or even our PBM formulary. And when you have a house of experts in the pharmacy space, it only makes sense for us to partner together. And we were a client of one of the big 3 PBMs, and we started asking a lot of questions that the employee benefits team may not have thought to ask because of our clinical background and because of our familiarity with medications. And the more questions we asked, the more it became super clear that we weren't getting exactly the transparency that we deserved based on how much money we are paying every single year. And so what we did is we set a timeline for decision making and said, okay, we need to do an RFP. We need to look at several different options across the system. And so we brought in traditional PBMs, and then we also looked at some alternative options like Capital RX and others to say what exactly, what kind of value can they bring to us above and beyond what we're seeing today. And so the more we dug into it, the more interesting it became. Because when you start looking at, well, your current option is actually being investigated by the FTC, and I'm just going to walk around just a little bit because sitting is not usually my jam. They really started looking at some things that you're like, oh, maybe we need to look into this more further than just about a cost savings initiative. So the FTC is looking to shed light into several PBM practices, charging fees and clawbacks to unaffiliated pharmacies. There's these things called DIR fees that your local retail pharmacy actually has to pay after your prescription has been dispensed months ago. And they don't even know what those fees are going to be. And so this is a common PBM practice that's making your retail pharmacy margins smaller and smaller, and why you're seeing your local pharmacies close and not be able to service their communities because of a lot of these practices. It's also steering patients to PBM-owned pharmacies only. Well, you're not supposed to do that, right? You're supposed to be able to have choice in the market. Potentially unfair auditing of unaffiliated pharmacies, which is a huge administrative burden to those pharmacies, and again, racking up their costs. But what about employers? How does it affect you? Well, use of complex and opaque pharmacy reimbursement methods, i.e. spread pricing. That means the more expensive a medication is, the more money they make. Wait, what? So they're adversely incentivized to actually dispense a medication that costs more, even though you're paying more out of your pocket? Yep, that's exactly what that means. And then they're negotiating rebates and fees with drug manufacturers that may skew formulary incentives. Again, they're adversely incentivized to have your employees take higher cost drugs when a lower cost, clinically efficacious drug would work just fine. So these big traditional PBMs own about 80% of the market, and they're quite profitable, like $30 billion in profit. But those oftentimes don't align with employer interests. So next generation PBMs are now entering the market, and they're offering greater transparency and more consistent pricing models. So what we did is we did a very big analysis. We actually used a third party to do our internal analysis. And one of our biggest take-home points when you're doing your expense analysis is don't let them tell you what % of money they're going to save you. Like, oh, we'll save you 25%. Oh, we'll save you 30%. Off of what? Like, what's your denominator? Like, what are you going to save it? What you really need to do is have all your PBMs that you're getting bids from give you a PM per member per month price. That way, what you're doing is you're comparing apples to apples, and then you'll know exactly what your cost is at the end of the day when you're comparing these PBM options. You also need to ask them what kind of pricing model they use. Are they using spread pricing? Like, tell me exactly how you are profitable. Because if you can understand that, then you know what their incentives are. Are they answering all your questions? And then really ask yourself again, are they really coming down to the nitty-gritty of what I want to know? Because oftentimes they'll give you an answer, and you're like, wait, was my question answered? Also, tech-enabled framework for optimization and ease of use. A lot of the systems the traditional PBMs use are like 30 years old, right, Josh? And so the question is, are we using the most technologically advanced place where we can actually have innovation and we can actually do the things that we want to do with our employees and offer them the benefits that they're looking for? Great customer service is always great. If you've ever called a PBM, you may have not had great customer service. I can definitely speak from experience. And again, that optimized medication use for more cost-effective, clinically appropriate drugs. We see this all the time in the hospital space. Did you know that if you're paying a lot of medications for a drug, there may be a more cost-effective medication available to you? So, what is our choice? Our choice was, I know everybody giving a guess. It was Capital RX. So why did we choose Capital RX? Well, they're a fully aligned PBM company, so their motivations and our motivations are the same. We all want lower drug costs. And when you have aligned motivations, it's much easier to meet your goal than when you have divergent motivations and it's a little bit of a push-pull all the time. They also have this technology called Judy, and I'm going to let Josh talk way more about that because I am a PharmD, but I don't know a lot about technology, so I'm going to stay in my lane. Also a different pricing model. So they charge per adjudicated claim. So if you see the little table up here at the top, usually PBMs charge the more it costs the medication, the more they charge for each claim. So you can see how the price ekes up, ekes up, ekes up. With Capital RX, it's a flat fee. So that's how the costs really come. And that is like to the tune of about 10 to 20% less than what we were paying for our previous PBM. So it really, really stacks up. Also, demonstrated great customer service. So if you can see here, their NPS score is 96, so not quite the 97 we heard earlier, but it's pretty close, And they have a 99.5% client retention rate, which is huge. That means people are happy with the services that they're getting. And then there's some other accolades there that you can see on the screen. And also they have, other great customer service metrics as well, like how long does it take for them to answer a phone call? How responsive are they to your actual questions? So we have not implemented them yet, but we will be implementing them on January 1st. And so this is really just a presentation on what our journey was and how we got there. And then I'm going to have Josh talk a little bit about how they can keep those costs.
While you're on that slide,
Oh, yeah.
we must have the best in the world here because everybody's got a plus 90 net promoter score.
I know.
I don't know. We're just choosing right.
Chris, you know how to pick them. All right. So we put in 4 slides for Josh because what I really wanted him to do is to talk about how they can get those much lower costs. So really compare what do the traditional PBMs do and then how are they different. So please take it away.
Sure, and I'll keep these comments brief, but the way I describe the typical PBM profit model is that it's really, in essence, a dual ledger model. It's 2 sets of books. There's the ledger that the PBM negotiates with the supply chain, right? Like the rebates that they negotiate with pharma, the pricing they negotiate with retailers, et cetera. And then there's the ledger that PBM decides to offer to each client. And the first thing we need to acknowledge publicly is that that ledger is different for each one of those PBM's clients. That is to say, the PBM price discriminates. They'll give a good price to one client, a terrible price to another client, and everything in between, right? Which means that you don't even know whether you're getting a good price from your existing PBM. The reason they have that dual ledger model is because the space in between the ledgers is what they mine for profitability. That's where they generate profit. And it is, in essence, a big black box, right? Now, I want to be clear, Capital RX is a for-profit company. We're looking to make a sustainable profit. We're not against companies profiting. But I think what Karen talked about earlier is really important, and that is that how a PBM makes money, where they get their revenue from, their profit, really matters. Okay? It's the most important thing because that's what influences their day-to-day decision making, what I call the 1,000 tiny decisions that the PBM makes on your behalf as a plan sponsor every day of the week, right? How they're going to create their formulary and build it and promote certain products, whether they're going to waive patients through a PA process or actually serve as a vigilant gatekeeper, things like that. And that's what we've seen play out in the industry is that clients will go through a spreadsheet process and they'll look at pricing from different PBMs, and the traditional PBM will look good on paper, right? But then they implement them, and the costs go up next year. And it's because of that misalignment that Karen mentioned. You can go to the next slide. What we've done is eliminated the gap between the ledgers. We've merged everything into a single ledger. We describe our model as a single ledger model, which means that there is no hidden source of profitability. We do make profit, but it's isolated to an admin fee, which is out on the table. We think that this is where healthcare is going, not just pharmacy, right? Pharmacy is a leading indicator of this. But this is really where healthcare is going, which is pay a fair price for good value, but understand in a transparent way exactly what that price is, right? So you can assess value for cost. Again, the industry is going here because it will be forced to go here by way of state and federal legislation, the FTC, and all of those very, very powerful forces at work. We're just getting there, I think, before maybe some of the other vendors have arrived. So, Karen mentioned our tech. I'm not going to geek out too deeply on this, but suffice it to say, most other PBM platforms, the prevailing ones in the industry, the code for them was written largely in the 1990s, before the creation of the internet as we know it, right? So try getting those platforms to interact with the 7 point solutions that you want to implement next year, right? Have you tried to do this? I don't know, with your traditional PBM. I've seen it play out when I was a consultant, and it was a massive headache. And so what we created was a cloud-based platform, API integrated, which means that there's endpoints that these point solutions can just plug right into, get real-time access to our platform. Again, we are, at heart, plumbers in this industry. We want good plumbing that works well, that can connect well with other systems, And if it's working well, folks like Karen don't notice it. Things just work, right? And they get done quickly. And that's what we found with our clients.
Yeah, it's true. The less problems that reach my desk, the better. So we like to have reliable solutions.
And again, I don't want to get too geeky. If y'all have questions, this kind of highlights some of the more technical differentiators on the platform side. Honestly, most employers don't get this deep. They don't think about this until things start to go wrong, right? Until they ask their PBM, can you make a benefit change? We've got an emergency here. I just found out that we have to set a copay for insulin at $35, or for COVID. This happened with the COVID vaccines, right? The government came out and said COVID vaccines have to be at a specific copay. We had that fixed within our system within 24 hours. That's the agility you get with a modern platform. So it really is an important element of how we are successful.
And I also think it's super exciting because their interface with your employees and how they order their medications, it just makes things so much more streamlined that it should be a big pleaser also for your employees. All right, so let's talk a little bit about checklists. I love checklists. I'm a pharmacist. We like detail. And so what I wanted to do is to have you guys bring something home with you that could help you when you're making your PBM decisions, right? We're not saying that Capital RX is the right one for everyone. Well, maybe Josh is. But I'm just saying that my advice is to do really good evaluation and not take any shallow answers as the only answer. Because the more you dig and the more you probe, the more you might find that they're either A, not willing to give you the information that you're looking for, or when they do, it really makes you think if that's the right solution for you. So number one, how do the costs stack up? Everything's about costs, right? Like how can we decrease costs as much as possible and continue to have high quality outcomes? And so the first thing is consider having analysis by a third party, because then you don't have any bias in there. You can send all of the information, all the claims to a third party, and they can independently analyze it and say, this is actually where we think how your costs stack up. Because I'll tell you, like for us, for employee benefits, thought it was going to be one solution. Pharmacy thought it was going to be another solution. And so when we had somebody completely independent do it for us, it was very eye-opening. Also, again, consider the total PMPM costs. At the end of the day, what's it going to cost per member per month according to each PBM, and that way you're comparing apples to apples. Do not let them sell you on percent savings. Is spread pricing used? So are they making more and more money the more high cost drugs that you buy? Because that's a adverse alignment to what you want. So make sure that your incentives are aligned. Are high-cost medications being approved by your prior authorization process when clinically appropriate, cost-effective medications are an option? This is where pharmacists can be really great because they have that clinical expertise to evaluate saying, okay, well, this medication is actually 2 generics that were put together by pharmaceutical companies, and now they're charging you a brand name copay. Whereas you could, for a fraction of the cost, just buy the 2 generics and be just as well off, and it's actually even the same ingredient. So really think about what kind of medication mix are your employees using, and is there opportunity there? And employees often like it when you can lower their drug bill. It's a win for everybody. What are the PBM's net promoter scores? We've talked about this all day. Just make sure they're good. How easy is a transition to the new PBM? What's their implementation satisfaction scores? Obviously really important to your employee benefits. Is it streamlined? Is it easy? Or is it going to be a lift if you need to make a change? How up-to-date is the technology they're using? Can they flex? Can they innovate? Can they change with the landscape of technology? And what innovations do they have to drive cost-effective and convenient care? Can you access it on your phone? How are you ordering medications, et cetera? And I'll just say it one more time. How transparent is your PBM being? I'll tell you, they will tell you that of course they're being transparent, and oftentimes the answer they give you is not exactly the question that you asked. So really, really, really probe deep. All right, that's all we had. And look, we're a minute, almost 2 minutes
we've
early.
got some time for questions.
Yeah.
Yes, because I've got a couple.
I'll sit back down.
No, I'm last.
Are y'all doing anything with alternative funding and removing drugs off the plan altogether?
Yeah, that's a rapidly shifting landscape right now. There's kind of a cold war going on between pharmaceutical companies, plan sponsors, and patients. around this, what I call direct-to-consumer funding that is offered. And so, we offer it as an arrow in the quiver. I'll be honest with you, around the total carve-out to PAP programs, we're not seeing a lot of uptake because there's just, I think, a lot of concern around the longevity of that solution right now. Yeah, but we do leverage coupons, which are widely available for covered benefit members, and that offsets a substantial portion of the specialty cost for both the plan and the member. Yeah.
So do you have formularies?
We do, yeah. We have a formulary. I would say our approach or our philosophy around formulary is a little different than a typical PBM. The big PBM, the formulary, is a vehicle to generate rebates. And that's because they retain a portion of those. That's a sizable share of their profitability, right? And so they are single-mindedly focused on using that formulary to generate as much rebate revenue as possible. We will optimize rebates through our formulary, but in the context of lower drug cost overall. That is to say, we're not going to put that combination product that Karen mentioned, the two generics put together, that may have a massive rebate associated with it, and it may end up on traditional PBM formularies because of that. But we would, on behalf of our clients, we don't keep those rebates, so we don't have an interest in putting that drug on the formulary. So I would say, yes, we have a formulary, but it's a little bit of a different animal than a typical PBM's formulary. Where rebates are available, they're still an important economic component of the supply chain. So if a drug makes sense and if it has, if it's good efficacy and there's value there, we're still going to try and get a rebate for our clients and pass the full value of that rebate back to the client. Yeah.
I think it also helps with market share. So if you pick one type of insulin and you're using all of that one type of insulin, one brand, versus having it across the board, then it's harder to get good pricing because you're dabbling. And so if you can really focus on one brand, then it really helps with market share and better pricing.
Yeah.
Kind of like all or nothing in hospital networks.
Yeah. I mean, that's what we do for the inpatient side too.
I assume you have ultimate flexibility on your formulary, then you can pick and choose whatever medications you want.
That's right. This is one of the reasons we've been so successful with health systems and with health plans right now. And that is because while we do have a good formulary as a starting point, a lot of health systems want to do some unique things. For example, they may have special arrangements for acquisition of drugs for their own pharmacies, right? They may want to prefer a different subset of drugs. For us, we're agnostic on that. So we'll administer the way they want to, and it doesn't affect our bottom line. Our answer is, sure, we can do that. And if that's what you want to do, let's do it. And then with the agility, honestly, it's two things. It's the agnosticism, right? We don't have a stake in it, but it's also system flexibility. And that's the other point of friction for customization that a lot of health systems saw with traditional PBMs, is that it's hard to customize those old platforms. So.
Well, and I would say the other great thing is that if we want to use a particular medication on the inpatient side and they might have something preferred different on the outpatient side, they'll allow us to switch so that we have continuity of care across so that people aren't changing medications off and on, off and on.
Yeah, the other key to making smart decisions like that is that the client really needs to have access to drug level rebate economics. They need to understand what the rebates are at the drug level. And if you ask most traditional PBMs to share that information with you, they will flip out. They'll say, whoa, that stays behind the curtain. We can't divulge that. That's a trade secret, right? That's bull. I mean, that makes no sense. These are your dollars. They're your economics. You're spending the money. You should have full visibility into your plan economics. Any attempt to sort of hide or conceal those economics is likely a sign that the PBM is monetizing it.
One quick question, maybe not a quick answer. How important are biosimilars in controlling overall drug costs and specialty?
Yeah, and Karen's a pharmacist, so she can speak to the clinical side of it. I'm a supply chain expert, and I will tell you that it does hold promise to bring price down, right? More competitors in a class is a good thing. But there's a reason that your PBMs are smiling every time they talk about biosimilars. And that is because they have spent years preparing for the wave of biosims that are coming out, contractually, from a rebate standpoint, and all the behind-the-scenes stuff. And the truth is that their margins are likely going to increase substantially under biosims. And they'll say this on their earnings calls. This is not a secret. They will say, we've got a profit tailwind from biosims that's going to add X% to our margin over the next year or two. They're acknowledging it because they get more dispensing profit. And here's the kicker. most plan sponsors don't realize this, but there's heavy rebating going on with specialty biosims, and most PBM contracts have been crafted to allow the PBM to retain those rebates. So check your contracts for that type of language.
Well, and I would just say, biosimilars they are a game changer because of competition. Like particularly in the hospital space, we're able to purchase, biosimilars at a way lower cost than we would any reference product. And so it's not only having a lower cost for biosimilars, but also the reference products as well. But then there's also a decrease in how they're reimbursed because as the AWP goes down, so does the reimbursement. And so it really is a game to watch. The lower the reimbursement is, the less cost that there is for the margin. And so there's a lot of moving pieces, I would say, right now in the biosimilar range. But my health system, we've embraced biosimilars, and we're about 80% compliance rate right now.
So I actually swim in the oncology market. Community oncology independent, which is almost unheard of, in this market, nationwide actually. And we adopted biosimilars as long as, right on the top of it, as long as the efficacy was the same as the brand.
Yep.
And we use generics too, as long as it's acceptable. But I have to warn you, with the health plans playing with the PBMs and owning PBMs.
Yes.
Okay? It's really, because we mix everything we buy in our office. And we're having to push back on the clear bagging, the white bagging, and the brown bagging.
Yeah.
Same.
Because our malpractice insurance won't cover our physicians if we accept drugs from unknown people and unknown entities into our practice.
Mm-hmm.
Plus, we have done it way in the past with the government program, and the patient starts treatment. They have 1 or 2 treatments. They have a reaction. They have to be switched to another. And you have to have individual cubby holes for every patient, square footage, and every treatment and every site. We have 17 sites in the city of Houston. So we have clean rooms where we mix these drugs and get them directly from the distributors and everything. It's impossible. We have to push back on that because essentially it's unaffordable for us to take that inventory of individual. And then 1 or 2 treatments, the patient has a reaction, they can't take that drug, we have to switch it. Drug gets thrown away for
wasted.
6-7 weeks.
That's right.
Yeah.
Totally.
And
Hundreds of thousands of dollars.
Yeah, and I'll say, like in my policy, in my health system, we have a policy that bans white bagging. And so we only do it if payers absolutely make us, and then we'll push back on them and say, try to use it in our contract negotiations as well. And so if we can negotiate in our contract that we're not going to accept white bagging, that's really a win. And there's also a lot of legislation right now around white bagging. I 100% agree. Those high-cost medications need to be mixed in the building that they're being made, in the clean room by the staff who are going to then administer those medications so that we can have safety for patients.
Patient lets it sit on their front porch for 2 days.
Yeah.
Oh, yes, 100%.
So we've got to close this session out. In spite of Omar, the clock serves a useful purpose to keep us on time. I think next time we use it, I'm going to put a clown face or something on it to really intimidate. I don't know, but it's.
We did end early, for the record.
Yeah, you did great. One of the things, how many in this room know who Eric Bricker is, Dr. Bricker? So actually, I hooked up with Josh a little bit earlier, but he had a really good video a week or 2 ago, and it was on following the money flow of the PBM, not the PBM, following the money flow in pharmacy, following the drug flow, following the services flow, and following the patient flow. And as only Eric can do this, he did it on, a confusing whiteboard. But I wound up actually taking it and drew it myself in different colors, and maybe I'll put that out at some place. But it was really informative. The point I wanted to make, though, is we all talk about rebates, and I remember a couple of my board members saying, we just want a good drug at a fair price. Can we just get rid of rebates altogether? We've got a ways to go before we're there. But in terms of questions, I don't think rebates is the question, because he who defines what a rebate is gets that definition. It's not the rebate. I want to know every dollar that you're getting from the drug manufacturer and where that ends up. I mean, is that a fair question that should be asked?
Yeah, I mean, those definitions are fluid, and the PBM controls the paper, controls the contract with you, and they therefore control the bucketing of those dollars. So they'll very easily take a dollar that used to be called a rebate and reassign that to a clinical program fund, or to an inflation protection penalty, or a rebate administrative fee, which sounds like a rebate but isn't technically a rebate, and so it doesn't need to be passed through to the plan sponsor. So, I think at the heart of it, you can spend all your time haggling and negotiating over the fine print of a definition like that, or you can just find a vendor that you trust, and that's really at the heart of it.
Works on an admin fee. So that's great. I mean, pharmacy is a huge issue. We're going to be spending a little bit more time on that next year in HBCH, especially with the Consolidated Appropriations Act. Oh, yeah. So I want to thank these folks for sharing their time with us. And since you are in our backyard, is Paul Arrington in the room?
He just left.
He just left?
Yeah, he just waved at me.
Paul is the senior vice president that we work with St. Luke's, and so we're going to be following this closely. So again, thank you so much for your time. So we're going to go back to the direct contracting model right now, and I'd like my next panel to come on up. While they're coming up here, I've known a few of these folks for a little bit. I became familiar with Texas Medical Management a few years ago. I think their headquarters are in Austin, right? And think direct contracting for surgical bundles. I've met George recently with L&F Distributors, and I want this guy in the back to raise his hand, Joe Montilla, who is L&F Distributors, but he is, and his organization is one of the more proactive organizations as an employer and as a possible answer for employers looking for a different way to do business. And George has been, you have a hospital background,
yes, sir.
I know, so he knows where the skeletons are buried. And then last but not least, Andy Martinez, who I've met some of these folks from the head up, on Zoom, so I'm getting to recognize folks' whole body here. So I've known Sean for a little bit. They're doing great work, but I like what they're doing, so I thought it's worth hearing. You probably have a net promoter score of what, 98?
I don't know.
I don't know.
We're transparent about it.
Yeah.
It's 87.
All right, so it's your show, guys.
Today we're going to tell a story about how a direct contracted provider can work very closely with a self-funded employer health plan that is very interested in not only saving money, but improving the quality of care that's delivered to their members, and then also tacking on top great service. And then over this span of 7 years now, we'll show what we've done together, and then we'll get to see the results. So my name is Sean Kelly. My brother and I founded Texas Medical Management in 2015. My brother's a pediatric reconstructive microsurgeon trained here at Baylor College of Medicine, and we both worked in Dell Children's and the Seton system, or the Ascension system in Austin. I ran the neuroscience service line on both the pediatric and adult, got out just in time before I probably would have had some lasting damage. And so when I got out, we decided we could fix this part of healthcare. That is, we understood surgery well enough that we knew how to choose the doctors, vet the doctors, to get the quality that we knew is out there, but lay people aren't able to discern. And then at the same time, we knew that we could raise the service level tremendously. And then the last, but probably easiest part of this was to cut the cost. And that is, we're going to provide the right care with the right provider at the right side of service, and it almost always ends up saving tremendous amounts of money. So, George works for L&F Distributors, Andres as well. I'll give a little bit of history about Texas Medical Management, and then we'll hand the keys over to these guys. We're going to run through a little short deck, a couple minutes, and then we think that's going to set the table for a panel discussion that hopefully you'll find very valuable. So we started, as I said, in 2015. We grew the business. We're from Austin. We've been in the medical community for about 10, 15 years in Austin. So my brother, as a reconstructive surgeon, knew all the really good surgeons because he was right across the table from them while they were resecting. And so we used that as our first initial go. So we grew really quickly in Austin in terms of scope and depth of service. And so we were attracting some clients. Austin's kind of a strange community in terms of self-funded employer health plans. There's a whole lot of government. There's a whole lot of public sector. There's some private, but you know what? A whole lot of those decisions are made in Silicon Valley, and IBM makes them in New York. So there's not a whole lot of self-control. So we started talking to employers outside the market. And so a lot of our customers were flying in. A lot of the patients were flying in or driving in. So in 2018, we moved to Houston. My brother and I are both sixth-generation Houstonians. My sister's a pediatrician here at Texas Children's. And so we knew we needed to come to Houston. We love Houston. I grew up in West U, so it's a natural for us to come here. This is a really big market with a ton of opportunity. And when I said what I said about Austin in terms of self-funded employer health plans, it's the exact opposite here. So I think it's a really, really great opportunity. And Chris, I'm glad you guys have put together this organization to bring this kind of information to employers in the market. And then just most recently, we expanded to Dallas and the Rio Grande Valley. So as I mentioned, we vet the surgeons, but to ensure the quality, we also measure our outcomes. So we do patient-reported outcomes on every single patient, and we collect an NPS score. And, oh, there's a typo. It's 97, not 87. I'm joking. It is actually 87. It is actually 87. I'm still very proud of that. If you look at hospitals out there, they're like in the 20s. Yeah. Pharma's like in the 5 or 6. I mean, there's not very good service in healthcare for a lot of different reasons. It's not because people don't care. It's just I think we are working in a mixed-up industry. So next slide. So next, I'll hand it over to George and let George tell a little bit of a story about how L&F, their journey to today.
Yeah, sure. Thanks for having us. I'm George Brown. I'm with L&F Distributors. And a little bit about us, just for some context. We're in the beverage distribution business. So anybody in the room who likes beer, we're your guys. We've got a total of about 1,500 employees in our organization, 12 warehouse locations distributing in 35 counties in Texas and New Mexico. Most of our locations are actually in South Texas, West Texas, southeastern New Mexico. We're headquartered in McAllen, Texas. So we have warehouses in McAllen, Harlingen, Laredo, Corpus Christi, El Paso, all the way up into Roswell. And then we have a wine and spirits division that has operations here in the Houston area, also in Austin and in Dallas and Albuquerque. The slide behind us kind of talks a little bit about our journey. So we've been at this for quite some time, and I think that's one of the key takeaways that we've heard in some other presentations, and I'll reiterate it, is that when you're working to revolutionize your health plan, it's not something that happens overnight. It's not a lightning in a bottle type of an experience. It's a marathon. It's not a sprint. And so it's been a long journey for us. We really started on the health side, I guess, back in 2013, and there's a strategy and a methodology behind kind of what we've done over time. The first thing was really getting into the right type of an arrangement, the right chassis, if you will, that will allow us to enter and transact into direct contracts. And direct contracting is very central to our strategy. for a lot of different reasons, but how it ties into the topic today of the triple aim is if you think about the current healthcare environment, let's talk about the unknowables, right? If we have an employee who is receiving, say, surgical care, and they're just using their network card cost, you're basically standing at a roulette wheel is the way I like to describe it. You don't know what that's going to cost until after the fact. It's highly dependent on where they go, who they're seeing. From a quality perspective, again, it's another turn on the roulette wheel. Obviously, variation in terms of quality out in the marketplace. It's going to be largely dependent on who they see. You have no control over that. And the same for experience, just like quality. I mean, it's healthcare in general. I think the NPS score last time I saw was in the 30s. Competes pretty closely with cable companies. So, some are good, some are bad. But as an employer, in the current status quo environment, you have no control or influence over any of those. But when you enter into direct contracts, well, now all of those things become knowable and become more easy to influence. So when we partner with Sean and his crew at Texas Medical Management, it's completely reversed. We know the price, we know it up front, it's transparent, it's all-inclusive, no balance bill guarantee, the price is the price. We understand the quality, they're measuring quality, they're collecting patient-reported outcomes, they're collecting NPS, all of that information is shared with us. So we as employers feel like we're in a lot more control and have a lot more insight into what's happening in the care that the members are receiving and ultimately how much it's going to cost us. So as we've gone through this journey over time, we've implemented different strategies and different solutions, and I sort of just put them on a timeline just so you can visually see. But all of these solutions that we implement, whether it's direct contracted surgery centers, direct contracted imaging centers with our friends at Green, to whatever that solution may be, on-site clinics for chronic disease management, these are all in direct contracted type of a relationship. And we do that, specifically for a reason. And when we do that, we're getting so much value in return that all of those services we offer for free to our employees. So our employees, if they utilize our contracted clinical partners, they get their surgery for free. They get their imaging for free. They're getting chronic disease management for free. They're getting telemedicine for free. They go to urgent care for free. The list goes on, and they're all behind me. But the real takeaway here is that it is a marathon. It's not a sprint. And don't let it be overwhelming. We heard this earlier today. Just start with something. Imaging could be a great solution. Get started on imaging and see how that works. And then over time, start layering in other services. And over time, you'll see this huge compounding effect. So we'll talk a little bit about utilization. There was one question in one of the panels earlier around utilization. And this is something that we completely obsess about at LNF. And when we talk about utilization, some people use different terminology, maybe engagement, but these are going to be folks, this is surgery specific because we're here talking with Sean about surgery. It's the percentage of people who would qualify to get a surgery at a facility like Texas Medical Management who actually utilize it, right? So all these clinical solutions that you put into place mean nothing if you can't get people to use them, right? So we obsess about utilization, and we've been on a utilization journey for several years. In the surgery world, really starting in 2017, 10% utilization, which is probably pretty common. Sometimes it's a lot less from what we see. But by having an intense focus on utilization, you can see how that's climbed over time. And so in this past year, 2022, with our direct contracted surgery centers, we were at 86% utilization, which we're extremely proud of. You start talking about how that translates in terms of savings, and I'll just put it up there, right? So when you look at, when we're able to get our members who need surgery to Texas Medical Management, and you look at what that would have cost us had they not gone to Texas Medical Management, just in 2022, it was over $700,000 a year in savings. So significant cost savings to be had, but again, that's really the probably second or third most important thing. The most important thing is that we understand that they're receiving really great care and they're having a great experience. I'll also point out, based in our markets where we are, in achieving that level of utilization, only up until recently have we had a Texas Medical Management option in the Rio Grande Valley. So all of these members have traveled to receive this care. They've traveled to Austin, mostly Austin, sometimes Houston, but mostly Austin. And so even with traveling folks to have this done, we've been able to achieve over 80% utilization. And Joe in the back likes to tell a story that I get fired up every time I hear, and I'll probably not do it the same justice that he does. But to give you a sense of how much cost savings is at play here, we can take an employee and their spouse from our El Paso location, and let's say they need a knee surgery. So we can take the employee and their spouse, we can put them on a plane, we can fly them to Austin, Texas, we can pick them up at the airport in a limousine, we can put them up in a 4 or 5 star hotel, pay for all their food, all their meals, all their travel, all of that. We waive their copay, we waive their deductible, make it free for the member, and then we even give them $1,000 cash incentive, and we're still saving about 30% than what that procedure would have cost at the local hospital in El Paso. So we're pretty proud of that. Some of that's font's a little grainy, but we're beer distributors and not content creators, so I'm just gonna embrace that. But so this is our per employee per year cost. You just talk about all of these strategies, including surgery, that we've implemented on our plan year over year. This is our healthcare costs on a per employee per year basis. And you can see that it's remained relatively flat and stable over the last, a lot of years.
10 years.
10 years, right? The line is compared to industry. It's not uncommon that employers, self-funded employers of our size are receiving double-digit increases every single year, unless, you've got a smooth-talking broker that can get it down to 8%. Either way, it's unacceptable. That's how we compare to industry, and so we're very, very proud of that. And then in return, we're able to share those savings back with our employees. Slide's a little busy, but our costs have remained very stable over the last 10 years, and in return, we've been able to lower premiums to employees, keep their premiums stable as well. So we're able to return those savings back to the employees and make it a really affordable plan with all the free options embedded. So I'll stop there and we can have more of a discussion.
Yeah, so I think that's a pretty clear picture about the results. What Texas Medical Management does by bundling high-quality surgeons into surgical bundles and then delivering those to a client like L&F. We take care of a portion of that savings, an important portion, because what you'll find is that when you have successes with these surgeries, oftentimes that means a whole lot to an employee. So, Andres, I saw that beginning number in like 2017 at 10%. Mm-hmm. Give us a little bit of a history. I know you've been around in L&F and HR benefits since well before they got into self-funding. Right. Tell us a little bit about, though, after they got into self-funding and then they started layering in these direct contract provider options, and how did you and your team get these numbers?
So it's hard. Because it was unreal at the time, right? 2017, you're telling an employee or having all these meetings, open enrollment meetings, like, hey, we added, Texas Medical Management, you can have free surgeries, outpatient surgeries, and we'll pay for all the travel and we'll give you $1,000. And they're like, yeah, right. Like, there's no way I'm going to trust that person over who's down the street, right? So then year over year, explaining the same thing over and over, even to the point where I would tell them, look, if you go to use your Aetna card, that 20%, right, of that copay, like, you have to pay for that, and we can get rid of it by going through TMM and Sean's group. And then we added care navigation, and that was key, right? Mm-hmm. And then we added that element of like, look, call these people, call our care navigation team. They will explain all the little ins and outs that you don't know that's not in that benefit summary. It's in the guide, but they're not reading that, right? So then we told them care navigation, here's the number, call them. They will, if you need someone local, right, just in the Aetna network, they'll tell you where to go. But then they'll also tell you, hey, if you need a surgery, I can get that done for you for free. I mean, it took years and years and years to get the employees to catch on. Fortunate for us, the loudest, biggest loudmouth employee you can think of, and I know everybody, you already have a name in your head. That person was the first one to go to get a surgery. And water cooler effect, and it just spread. What? You know, I can get a surgery and get $1,000? Well, you're going to get a really good surgery, and then you're going to get $1,000, right? And then, you know, Sean collects all the information of what the outcome was for the employee, and you do it in a span of time, right, to understand. So was it easy? No, it was not. You know, as a self-funded plan, we kept adding features to our insurance, right, whether it be telemedicine, you know, care navigation didn't come right away, disease management, a wellness program. Like, so we just started adding and adding and adding. And as we went adding more things, they're like, oh, this is normal. This is what it is now. So now I'm able to have open enrollment meetings and really tell them, hey, remember back then when we added this, here's an additional benefit to that. And it's all zero cost to you as an employee. And we also explain that, look, you know, we understand that insurance is expensive, going to the hospital is expensive, doctors, et cetera. Like, we know that what you're getting deducted out of your paycheck is not ideal, all right, even though we've been keeping it very low for a very long time. And we tell them we want to offer more, which is zero cost benefit to you.
Yeah, and I think one of the things that's really important is that they would get the numbers. This is LNF. They would get the numbers from their care navigation TPA each and every quarter that would show the number of opportunities, outpatient surgeries that were done, claims that came in, and then how many of those actually were sent through care navigation to one of the contracted facilities. And each and every quarter, they thought of new ideas, like know as you go. And there's communications that happen
just so you know as you go are flyers that we put in the bathrooms.
Yeah.
That's why. Yeah, you know, you're in the bathroom. It's like, that's a great place to promote something, right? Anyways, sorry.
And so little things like that, they may seem insignificant, but it's the cumulative effect. So I liken this to like a flywheel. So a flywheel is really hard to get started, but once it gets going, it has a lot of momentum. And so tell us a little bit about what do you think is the key to why an LNF member today, when you add something, they automatically look at it in a favorable light?
Really, it's all the legwork HR does. It's a lot of work. It's a lot of work, but I will say HR and the company owners need to be very well linked up. HR needs to understand what a self-funded plan is and all these carve-outs, right? Like, they need to understand that, because if you don't, then you're like the employee. You're not going to be understanding. You're going to keep asking all these questions, like, why am I sending them there? It's probably just easier to tell them to use their card. It's the same money, right? No, it's not. Like, there's just so much more savings for the employer. And if HR doesn't understand that, it's going to be hard to explain that to the employee. So it is a lot of work, but I'd rather have all the employees come to me so I can effectively explain to them their benefits. Now I'm pretty lucky because I tell them to call care navigation. But I did some implementation with them as well, right? I had to get the care navigation team to understand what kind of culture we have, right? A lot of Spanish-speaking employees who, they like Facebook, but they don't like doing anything on any other app but that one, right? Just as an example. They don't know how to look up, their paycheck. They do know, they just don't want to because they know somebody else can do it for them. But I take advantage of that space and explain benefits, right? It's just that.
I think the other piece of it too, in terms of favorability and how it's viewed, I think over a period of time, the level of trust, I think, has really increased. The more adoption that we get, they understand that, the La Mantilla family, they're doing this to take care of us. This isn't just a cost savings opportunity. Like, we're getting really great care. And then once that flywheel starts going, they understand that once a new solution is kind of enters the equation, well, again, this is the La Mantilla family taking care of us. And I think the incentives are important, and I want to talk about that because I know we're running low on time. I mean, incentives are key. I would say if I were to strip all this back, and yeah, it can be complex, but to make it very simple, I think there are three really key things that need to be done if you want to be successful in direct contracting. Number one, again, you've got to have kind of the right chassis to be able to transact in that manner, okay? And there's a lot of different ways that you can do that. We do it through a captive mechanism, but there are other ways to do it. But you have to be able to transact in that way, number one. Number two, embed proactive, human-centered care navigation into the middle of it. One number to call, one team to talk to, simplify the process for the member. Anything you need, call that number. Call Nurse Dora, call whoever it is. So make it really easy for the member to access. Otherwise, you may have 20 different programs and clinical partners in place. It becomes a complete disaster for them to figure out how to get there. So embed really proactive care navigation. Number three, introduce incentives into the process. Incentivizing the employees is a huge part of success.
Yeah, and if you think employees are going to take advantage of the $1,000, well, no, they need orders, right? And that's them calling care navigation to get like the right MRI, et cetera, right? Go through green imaging or whatever you need to get those orders. And then it's taken to care navigation. And then from there, they'll go to Sean's team, schedule everything. And so there's no way to take advantage of it.
So that we can continue with our schedule, we want to take a couple of questions if we have any from the audience. Anybody?
Oh, come on, it was that straightforward.
Yeah. You're going to question Sean's NPS score.
Yeah.
You guys have a really innovative program that you've put together, and if anyone hasn't read the history of LNF and how the things you developed, it's really fascinating. What do you think has been, this is from a dollar amount perspective is a lot, but what do you think has been the most successful of all the different kind of cutting edge things you've put in place to manage your plans?
Well, so there are several, but I think the one thing that I would hit on, there's a lot of really great clinical partners that we work with. They drive significant amounts of, from a savings perspective, surgery, obviously, imaging, the gamut. But I would say, my opinion, the most critical part from a plan operations perspective in getting all of this work done, the single most important piece of that is care navigation, right? Because again, utilization is really what matters in these programs. There's a lot of great clinical people involved. They can save us a lot of money. They can provide really high quality care. But again, if nobody uses it, it doesn't mean anything. It's all just, a wasted effort. And so that care navigation piece really becomes the catalyst to what these clinical providers can bring to the table for our plan.
And you could say, I'll just put an HR person there for care navigation. It's really hard if you have audits, reports, et cetera, right? I used to be that person. I was care navigation before care navigation.
And it was at 10%.
That's right.
No, it was higher.
Where were you on that one, Andres?
Yeah, sorry. But through a care navigation company, they have everything you hold for your employees as insurance. They just literally navigate for them.
So you would say your workload decreased with the implementation?
Yeah, right. For sure.
Is care navigation optional, or are they good?
It's optional, but we tell them if it's best if they go through it, right? Because that's where the zero cost benefits.
If they're
right?
going to access the zero cost solutions,
they need to go through
care.
there. And they'll, if he doesn't go through it and I do, we both went for, I don't know, gastrointestinal stuff, right? He's going to get a $2,000 bill and I'm not.
Yep.
I have a quick question. So if someone was interested in pursuing this through Texas Medical Management, what would kind of next steps be? And then I looked at your website and I didn't see any pricing for Dallas yet. It's coming soon. Is that still coming soon or?
Yeah, just so everybody knows, I'm sixth generation Houstonian, so Dallas is special. It has been a slog to get into Dallas. And I thought we were done like 6 weeks ago, and anesthesia pulled the rug underneath us. We got it done 3 weeks ago, and then there were some implant issues. So we don't post things until we are like rock solid. We stand behind it 100%. I've got ortho. Javier said this morning, our surgical nurse, it's this week. And so that's between today and tomorrow. So I'm real hopeful. But yes, it'll be there, and when it's there, it's good to go.
You're starting with orthopedics.
Do you, because we got to wrap up here, but do you have another option? In other words, is there a wraparound PPO if folks don't want this?
Yeah, so we do have a PPO.
Yeah.
As well, and then we structure all of our direct contracts outside of that PPO.
Yeah,
So
and that's the point I wanted to make. Again, another example like the 10th today, that you can have a PPO and take steps towards change, and that's what we're trying to drive here at HBCH. And then quickly, more to Sean, are the consultants going around just spreading the gospel for you?
I'd like to think they're doing so quietly because I don't hear about it, but I think it's between them and their maker.
Well, I ask these things. Are you hearing this from your consultants and your health plans
Right.
to this particular point in time? And that pressure has to come from the employer side of the table.
100%.
In response to this young lady's question back here about what are next steps, we do direct contracts with self-funded employers. If the self-funded employer says, hey, look, I need you to work with my TPA, and TPA says, I think it'd be better that we have the contract, that's fine too. And then the care navigation that they put in place recently, that is like the best care navigation I've ever worked with in my life by times 100, is patient choice. And they'll say, we'll do the contract. Ultimately, I think the smartest employer health plans are going to own those contracts. Because as we've talked about on several of these talks, when the fiduciary starts coming up as an issue and lawsuits start coming, as an employer health plan, employer-sponsored health plan, having self-funded plan is great. Having direct contracts that you actually have high utilization means that you're actually doing something about containing the cost. And so I don't know about safe harbors and everything. That's usually kind of a legal thing that happens. But I think you're moving in that direction. You're doing it. You're walking the talk. Then I think, obviously, that's going to be better off than if you're fully funded, waiting for the government to come find you.
And another org that I've recognized that I wanted to have here for intended purposes. So again, thank you all so much
You're welcome.
Thank you.
for coming.
Appreciate y'all.
Thanks for having us.
Our next session, I call it, remember George Bush, 1,000 points of light? I call it 2,000 points of light. That's how many point solutions there are out there, right? And how do you manage those? How do you integrate them? How do you directly contract for them and get them into your plan? So we're going to, again, another employer case study. This is Baylor College of Medicine working as the employer side with Hello Heart, a point health solution. So we're all good here.
Thank you guys for staying, and I'm also on the board here for HBCH, and so I wanted to encourage everybody to join us for the cocktail reception later, because it's very hot and it's a lot of bad traffic. So just hang out with us for a couple of hours and have some drinks and music and some light bites. So
Yeah.
I wanted to let Monica introduce herself first.
Hi, Monica Williams. Thank you all so much for staying with us this late. And I do agree with Jen. 5 o'clock traffic is going to be murder in the medical center. So you may want to walk over with us over to the little HH. But Monica Williams, I am the Executive Director of Benefits at Baylor College of Medicine. I first started my career in city government with the city of Houston. Moved away from there, decided I was gonna, hey, let's go try the for-profit world. Well, personal experienced the Enron debacle. And that's where I landed at Baylor College of Medicine. I have been here now for 17 years and I enjoy what I do. This is my niche, I found it, and we're ready to rock and roll.
My name's Jen Roberts. I'm with Hello Heart. I lead our employer health strategy team, and I have been part of the Houston Business Coalition on Health since forever. Chris said forever. So I look like I'm reverse aging probably is what's going on. But I will say that every time we come and do these events, it's almost like a class reunion. You know, we see people and they're going through different changes with their jobs and still continue to come back. If they went from the consulting side to the employer side to the vendor side, but all still coming back together again. So that's really great. And I think George ran away, but George was actually just talking about this from LNF, and he was saying how there's so many different solutions that you have out there, and sometimes you can't get anybody to participate in them. And this is, you know, a problem I think probably everyone in this room is having right here. How do you choose which ones? How do you ensure they're effective, and how do you make sure that you don't have 1%, 2%, 3% engagement in that program? If you're paying for a program, you want to make sure that your investment is protected and you're de-risked by getting the engagement. So this is a profile of Baylor, and I'll turn it over.
Yep. Baylor College of Medicine, right now we have a little over 13,000 employees, which is quite a lot to manage, because we house faculty who see patients, we house faculty who teach, we have staff, we have residents, we have research postdocs, clinical postdocs, and also learners, which are our students. So we have a very diverse population. We are always looking for innovative, different types of programs that we can offer to our employees that'll be beneficial to them, as well as be beneficial to us as being the employer and having to pay the claims. So we do look for a lot of different products out there, because we also have a group that's abroad, and we have a global health group that's abroad in different countries dealing with our HIV, the malaria, those types of things. We have those types of research centers out in like Malawi, Afghanistan. We have them, they're all over. And so we want to make sure that we encompass all of those employees when we are looking for products that we want to bring into Baylor, which is the reason we kind of looked at Hello Heart initially.
I think a lot of kind of missteps sometimes consultants make, and since I used to be a consultant, I'm going to own up to that, is that, you know, you look at a group and you're like, this is education, or this is healthcare, and in fact, you really do have this diversified workforce, and not only is it diversified by job type or salary band, but also by gender, ethnicity. I don't know if you wanted to speak on that a little bit. You have a very diversified group at Baylor.
Oh yes. We are represented, I believe, by close to 200 countries are at Baylor College of Medicine. So it takes a lot to understand where they're coming from when they're looking to us for their benefits. Because 9 times out of 10, they're coming from a country where there's state benefits. There's a state covered plan. Everyone has that same plan. When they come to Baylor, they have choices. So you're speaking to them and their eyes are glazed over because they have no idea what it is you're speaking of. And like George said, when you put things in the bathroom, on the back door of the bathroom, you put it on the mirrors in the bathroom, they're in the elevators because you want to educate, you want them to know what their benefits are, what we offer. If you have questions, you come to us and ask us about those questions.
So one of your top risks were cardiovascular disease, and it was one of the top risks in cost, but the most prevalent.
Yes.
So thinking about that, is how did that lead you down the decision to put in a heart health solution?
Right. Well, during one of our annual reviews or our mid-year reviews, we found we had 3 categories that was not adherent at all to the regimens that were provided by their doctors. One was hypertension, diabetes, and hyperlipidemia. They were just out of the roof. There was nothing showing where these patients were actually following the doctor's orders. And so we're like, okay, well, let's step back. Let's look at this in a different light. Maybe there is an issue with purchasing the medication. Maybe the medication is too high. Maybe the cost is too high. Maybe their salaries are not at the point where they can take care of that take that medication. So like Omar at Harris Health, we also implemented in January of 2022 a $0 cost share for those 3 non-adherent categories, drug categories. So we do offer that to our employees, and we have seen a raise, not where we want it yet, but we have seen that there is a raise in those adherents. So we have found that there has been a slight increase. We're working to get it more. Maybe we need to educate more, which has been the theme that I've heard throughout this throughout today, that education is the key. And so maybe we just need to educate more, but we have seen a slight increase with those $0 cost shares. And so we thought topping those increases with implementing Hello Heart would maybe boost us a little bit more with that higher level of engagement.
And that's what we're talking about today, is really integrating. So I think point solutions can get a bad name or a bad rep, and in general, Hello Heart's a digital therapeutic, but it is something separate and aside. So if you really want to drive that engagement, which is going to lead to the clinical outcomes, which will lead to those cost savings, you're going to have to integrate it in your plan, with other vendors that you have, with your communication and marketing throughout the year, and you guys have done an amazing job of that. So I'll just recap. You said hypertension, hyperlipidemia, cardiovascular disease, most expensive, most prevalent, most deadly, in particular, especially for women and women of color. This is definitely something that Baylor is important to Baylor, I would say.
Oh yes, very important to Baylor. We, as I said, we house patients. We are working on our hospital. We are looking at the cardiovascular numbers that are coming from our actual physicians at Baylor to see exactly what is it that we are not doing, what can we do from a benefits perspective to help you help them. And that was the reason we thought maybe Hello Heart might be a good option for us to introduce to our population, and it has been.
So what are we talking about? I'll just really quick, I'll be very fast about this. So this is Hello Heart. It's a cardiovascular program, a digital therapeutic to improve heart health, and it's using behavioral science and AI-driven technology for digital coaching. That coaches in lifestyle change, exercise, nutrition, reducing stress, things like that, which are going to improve all of your cardiovascular kind of risk factors right there. And then we've put an additional emphasis besides blood pressure and cholesterol on a new area, which is really these heart flags. So if you're having an arrhythmia, if you're having a hypertensive crisis, if you're having a regular pulse, what do those things mean? Alert the member and then drive them to, like the AAA we've talked about, the right type of care at the right time at the right price. This additional emphasis we've recently launched on women's heart health is that the additional risk to women that we just mentioned, and kind of building that out a little bit more in the future. So one way to build this in the ecosystem is really within the app itself. So you can see here, does this look like anybody's benefit plan, like the different things that you offer? It can get a little hairy. There's a lot of stuff. And how many weight management programs do you have? 3 weight management programs right now. And sometimes you get those freebies from the carriers, or it's coupled with something else. And, how do you know which one you go to, and how do you know which one to communicate? So one of the benefits with Hello Heart, so besides integrating with the medical plan, in some cases with the PBM, is integrating with those other vendors. So you can see this example right here for weight management. So members at Baylor, if they're tracking their weight within the app and their blood pressure, and notice that neither of those are going in the right direction, they're both kind of heading in the upward trajectory, they'll get messaging saying, hey, did you know you have Weight Watchers at work available to you through your Vitality program? Correct. And so now it's an easier way for the members to navigate to those places.
Correct. And when they receive those types of notifications, 9 times out of 10, they do typically reach out to us and say, hey, I got this from Hello Heart, from the Hello Heart app. What do we offer? And that's just because they don't know. They don't remember. We've talked about it 50,000 times, but they just don't remember. And so then at that point, we can tell them, hey, why don't you go out to this website? Weight Watchers is there, and it's free. You can join Weight Watchers, and Baylor will pay for it as long as you remain engaged. So we can provide them with that information. We can offer them other weight management programs that we may have. So it's just all about that education. And with Hello Heart's app filtering them to us and offering them, hey, you need to talk to Baylor, you need to go to Baylor. That gives them that opportunity to reach out to us, and we can educate them on more than just what it is that they're asking us for.
I think that's another element of the ecosystem. So Baylor, you're unique like other healthcare systems, and to be fair, some of the healthcare systems got a little bit of a punch on the chin today. But I think Baylor survived that one,
Yeah, I think so.
which was nice. But because of that, you are interested also in somewhat domestic utilization, right? So if you are having your members going out in the community, they need care, you're actually offering them different things like on-site clinics or near-site clinics. So you want to kind of keep them in your system because it's a lower cost, higher quality provider. You guys know that. That's what you're providing to your customers as well. So there's some integrations, I think, going on with your clinics.
Yes, and so we do have an on-site clinic because our building is actually right across the street here at 6624 Fenton is where I'm housed. And so we actually have an on-site clinic there in that building on the 20th floor. And so employees are free to go there. It's free for them if they're on one of our premium, either a PPO plan or our EPO plan, it's free to them. If they're on our high deductible plan, there's a flat dollar fee to go into that clinic. But it's free health care. And we have utilized and leveraged, like Harris Health had mentioned, we leveraged our award-winning, I might add, wellness program to filter this information down by using our wellness champions and giving them the tools that they need to filter this through their departments and so that their employees they can help us educate. And we leverage our well-being program in all facets. It's a well-rounded, it's not just specifically looking at health, it's looking at spiritual health, it's looking at financial health. We want to well-round that person and give them the tools that they're needed. And so our first on-site clinic was open in 2022 over in our building, and we just recently opened a second clinic out in Sugar Land. So it's the same options there, and employees can utilize that as well for anyone that may be in the outlying areas outside of the Texas Medical Center.
Which is almost everybody.
Which is almost everybody, yeah. We don't have a lot of employees that live in the Texas Medical Center. We're all on the outskirts.
So that's thinking of the strategy where if people are just well enough to come to work, or it's kind of a physical or different things, it's convenient when it's close to work. But the highest concentration of your members is in actually Sugar Land. So if you want the members to come, that's why you open the care center.
That's why we opened the care center in Sugar Land.
And Monica's being really honest about the award-winning wellness because they won the Surgeon General C. Everett Cooper Award, which is extremely difficult to win and a very challenging application, a lot of step competition. Can you say a little bit more about a few of all the things that you do for wellness?
Oh gosh, I need Jesse. Jesse is our well-being director, and he eats, breathes, and sleeps well-being. And we offer so much through our wellness program. And we have a wellness portal that is powered by Vitality, and that's who we utilize for employees to enter in their activities. Like, we give them points for everything. You can eat and get points.
Eat healthy, I think.
Yeah, well, eat healthy. And like Jesse says, if we see you walking in the hallway with your McDonald's, we're not gonna just, hey, get that out of your hand. But we offer points for everything, and we have to do that because our employees abroad, and I tell our employees in Houston, like, y'all want us to earn so many points, and I'm like, we have people in Malawi. They are reaching those points. You can't tell me you can't make them here in Houston. And so we created that atmosphere so that we can all work together. We have virtual walking challenges that are through that wellness activities that you earn points for. You get a premium reduction if you've earned all of your points for this year. For next year, you'll get a premium reduction on your medical plan. And that's for whether you're employee plus children, employee plus family. It doesn't matter the coverage level, there is a reduction there. And we have found through surveys through the wellness plan that monetary incentives are really not what employees are looking for. That's not what they wanted from us. They wanted other types of incentives. So through our Vitality portal, we have given them all of these types of incentives that they can turn their points into books and purchase those incentives they have asked us about through that portal.
We were talking about that kind of as we were getting ready for this, and I thought that was really brave to kind of survey the employees and then take that in, because we think the easy route is give them $1,000 to do this, give them premium holidays, give them money. Give money and people will do things, and they will till you reach that dollar amount and then they're out. And so what is actually the intrinsic motivation to get people to change and lifestyle change? And that's really what the Hello Heart app works on, is how do individuals help find within themselves to make change. And we wanted to share a little piece here and bring this out, because I think for the employers here, how many of you guys have health coaches? Right, and so there's and I used to be health coach, Bianca in the audience, we were health coaches together at Harris Health, and you think live is the best type of coaching. Like if I'm talking to you one-on-one, then this is gonna be the best type of coaching. And if not, maybe we do video, maybe we do telephone. But what do you do after you leave that visit with that coach, with your provider? Then you have to do that kind of on your own, and that's really what the app focuses on. But let's not forget, we can still have these integration pieces with the other elements that you've put in your benefits plan. So you can get your live guidance from your coaches, have the 100% digital coaching, refer back and forth, and then reinforce the messaging, as well as being able to share clinician reports that's showing what are these metrics looking like, what's my weight, my activity, what's my blood pressure, what are my cholesterol reports, did I have any symptoms? And then you're empowering the provider, be it a coach, be it an on-site disease management nurse, case manager, or even their individual PCP, to have more information to make changes to their treatment plans.
It's just to piggyback on Jen. I use my husband as a guinea pig for lots of things. And he was a guinea pig for the Hello Heart before we implemented it, because I wanted to see how it worked before I brought it over to our employees. And being able to download and send his blood pressure readings from his last visit to the next visit, which is typically 3 months away, that was heavenly, because he could see the ups and downs, and the provider was able to know whether or not, hey, is this medication working for him? Do we need to change his medication? So he was able to get all of that information just from looking at the readings and the pulse rates and all the information that the app provided.
So here's kind of the big piece here. Here's some marketing materials, and the number one way to actually recruit people at Baylor and across our book of business is postcards. It still is postcards. And I think part of it is like maybe the medical director for the family's not at the workplace. And so communicating, it's a low cost, effective way. If you get a postcard, you don't have to open anything. You're like, oh, I'm gonna look at it right there, and you're gonna have automatic seeing. And you can see the co-branding with Vitality as well. So continuing that cross referral and reinforce and re-engage. So we have some really fantastic outcomes. If you want to walk through them in the short time that you guys have been there.
Stand up so I can see.
Go for it.
Okay, so like I said, we implemented Hello Heart in April of this year. And by first quarter, we had 806 employees that had actually been enrolled, engaged, and had received their blood pressure machine. And to date, we have over 1,100 that have enrolled. And that is amazing for Baylor for 6 months. I mean, that's just amazing numbers for us.
So that's 20% of your eligible population enrolled in less than a year.
Yes.
So think about that when you're looking at other vendors. Like, those are standards that you should be aiming for.
Yes. And then we also notice in our heart risk folks, and that might be people that maybe they do have high blood pressure, but they're taking medication, and the medication is keeping that controlled. They had a 1%, I can't remember my statistics, Jen. They had at least a 72% of them had at least a 1-point reduction in their blood pressure. That's 72% of those people that have been engaged for that first quarter was at 72%.
And you're starting to see reductions as early as 2 weeks.
Reduction within 2 to 3 weeks. If they are properly first getting those $0 cost share medications and taking them in accordance with what their provider is regimen has been provided for them. Our engagement, we have about 11 average meaningful visits during that period. I'm gonna let Jen kind of explain what that 11 average meaningful visits means.
So generally, you've got people coming once a week to the app, to the monitor. You've got super users. You have some people who use less, but on average to that high level of engagement, especially this long out for those members and continuing to engage and enroll people every day. To me, the biggest one that stands out is this reduction here of 17 points. So if we don't have like clinical people in the room right now, if you're at around a 130, 135 on your blood pressure, you're out of control for your blood pressure for that top number. You start dropping this significant amount, you're actually now heading toward in control. You're a different person on your medical plan than you were before that went into place. And the expectations that translates into savings.
Savings, yes.
So we'll be looking at those shortly.
We'll be looking at those in a little bit.
And I think that's just kind of a reminder that when you're evaluating vendors to make sure that you have an engaging program that people will actually join, sign, and continue to engage over time. And then it's delivering clinical and financial results. And then you know that's a program that's going to stay for the long term.
And they also get wellness points for that, for this as well.
Exactly.
Engagement, engagement, engagement. That's what we need.
You have time for a question or two, anybody?
You mentioned you have people from a lot of different countries. Other than the healthcare system being different, what's the biggest challenge you have in working with different backgrounds?
The biggest challenge, and I used to make a joke about it, one of our biggest challenges is, you know, with other countries, there's traditions there. And you have to know those traditions a little bit so that you know how to approach that person. You need to know how that person, who that person likes to engage with. Because in some countries, there is no handshaking between a man and between a man and a woman. There's no engagement, there's no talking. And so you have to set your system up to the point that you know that. So when that person approaches you, you know who you can have, oh, hey, Alex, can you talk to Dr. So-and-so? Or, and I am a person, I'm from Louisiana. And so I am, we are like touchy, huggy, how you doing, and those types of things. And so I have to put my hands behind my back most of the time so that hi, Dr. So-and-so, how can I help you? So I think that is one of the biggest things. And also, like I said, they have state insurance, a lot of them that are coming to us. And so everyone has the same coverage. There's nothing they have to think about. So lots of times we have to take extra time to visit with them and discuss exactly what our medical plan options are and help them choose which one is the best route for them to take for them and their families.
Let me ask this question, then we have to close it out. But it's my understanding that this is into the plan, but you are directly contracting with Hello Heart, right?
Correct.
Yeah, and it can be billed as a medical claim or a pharmacy claim, which is really important because it's a legitimate claim, preventive blood pressure, and it makes it really easy for groups to purchase, especially like public entities where it can be really challenging procurement process.
My point in that, again, another opportunity for direct contracting in an existing PPO plan. I hope that message has come through a few times.
It sounds familiar.
Today.
I know, it's very familiar.
So anyway, I really appreciate this. Obviously, the digital part is becoming more and more a part of healthcare delivery, virtual care, digital care. There's a lot of opportunities. An opportunity to reduce costs. National survey, I don't know where we go in this country, but if you look at a recent Gallup poll that showed the change, national surveys, obviously Gallup, of folks in the last 15 years that think we need a one-payer system and that the government should be part of that, that is increased like 30 percentage points over the last 10 years. My point is we have an opportunity to change this, and maybe that's what we need. Maybe we need to be like all these other countries. And that's where we may be heading if we don't take an opportunity of what's going on here with a lot of different providers.
Right.
So again, I thank you for both being a part of this.
Thank
Monica,
you.
Jen, thank you so
appreciate
much.
it.
Thank you.
Jen has some liquor.
Next panel, we're really hitting the home turf here, home stretch, if you will. So you've heard us talk about primary care ad nauseum today. And there's a lot of different ways that we can offer primary care. We can do it virtually. We can do it through the current health systems. We can do it through groups like Next Level Medical. There's a lot of different options. What is becoming more popular is offering primary care through grocery chains. And why not look at the biggest one in the state of Texas, HEB. So I've known Abby Aberman for several years, who is now Director of Benefits for HEB, and Monica Garza, who works on the HEB Wellness and Primary Care. I don't know if you know this, but they opened up a clinic recently in spring, at least one, and there's plans to open more. But we just thought it would be important to understand this option for employers. So Monica and Abby,
Thank you.
there you go.
Thank you.
Hey, everybody. Thank you so much for having us today. It probably does seem a little weird, to Chris's point, that HEB is standing up here talking about healthcare services. But and as Texans, residents of Houston, I'm sure you guys think you know HEB like the back of your hand. Everybody has their own HEB that they go to. But I wonder if you guys know that HEB has 5 different store formats. Did anybody know that? Convenience stores, Joe V's, which is a sort of a large store where you can go in and buy bulk items, Mi Tienda, which caters to the Hispanic population here in Texas, Central Market, and convenience stores. Did I say that? And regular HB, regular HB. Yeah, so a lot of HEB is a very unique, diverse employer, not only from the type of employees that we employ, but also all of the different businesses that we run. So manufacturing, warehousing, transportation, and now healthcare services. So I thought today I would try and share a story a little bit with you so you guys could fully understand the reason why we got into this space and how we're doing it. So it started back in 2011. That's the very first time that HEB opened an employee health clinic. We called it our Partner Health Center. For those of you who don't know, we call our employees partners, and of which we have about 140,000 partners these days. That was another fun fact I wanted to share with y'all. So in 2011, we hired a vendor to come out and start our very first Partner Health clinic. It was kind of an urgent care focus. We put it right next to some of our manufacturing and warehouse sites because we thought that would be convenient for them to go before, after work, during work, if they were sick and needed that urgent care setting. What we found was that was not necessarily targeting our employees or providing our employees, our partners, with the right kind of service based on what we were seeing in our utilization data, the data that we look at from our healthcare vendors every day. It wasn't necessarily moving the needle. So in 2016, we changed vendors, and with that, we were able to provide more of a primary care focus. And we brought in new services, or offered new services that we hadn't offered before, like physical therapy. At one point, I think we even had an exercise physiologist, health coaching, things like that. And it didn't take long. We were so involved in that model and involved with how those providers were providing care and what they were providing to our partners that we kind of came up with a dream and a hope. We're still not getting quite what we need out of this vendor and quite what we need out of these services. And so we took a chance and we said, we're going to form our own 501c3 and we're going to open and operationalize our clinics. And so in 2019, that's exactly what we did. The idea was born out of a benefits department. So all of us benefits folks rallied together, tried to identify how we could best maximize these services for our partners and deliver upon them where it's partners treating, managing partners' healthcare. And that's exactly what we did, which really, thankfully, we did it just in the nick of time, because in 2020 when COVID hit, we were able to move very quickly, and we transitioned to testing, vaccinating when we could, and really navigating about almost 90,000 partners who had COVID over the course of the 2-ish, 3-ish, however long pandemic that we're calling it. So that was a really wonderful, great investment. We also learned a lot during that time on how to effectively and efficiently deliver care. We were able to even open new clinics during COVID. One, our very first that opened during COVID, was attached to the store. So that was our first time to do that. And then now we've sort of gotten into this phase where we are continuing to expand on our services and also continuing to move into new markets. We originally were only in San Antonio, and as Chris mentioned today, we're in Houston. We're also in the Austin market, and we're continuing to grow the number of clinics that we have, and we're looking hopefully to move into the Gulf Coast and other regions on the border very soon. So as far as the benefit plan design is concerned, it's very simple. Partners who are enrolled in our medical plan and any of their dependents over the age of 12 can go to the clinic and receive free care. That's everything from a biometric screening or an annual physical to counseling to registered dietitian visits. We also have an integrated care model where once you're a member of the clinic, your care is overseen by a physician and a team of other individuals like dietitians, a clinical pharmacist, and other folks who can help to navigate you through the healthcare system. We are referring our members to HEB preferred providers. We have our own sort of algorithm and way that we identify physicians in each of the communities where we have membership, and we're able to refer our partners to those physicians. And actually starting next year in 2024, that's something that we're going to be offering to all of our health plan members, no matter if there's an HB Wellness primary care in their market or not. So we're really excited. It's going to be a reduced copay. So that's one of the ways that we're trying to expand, even when our partners don't have a brick and mortar facility to walk into. So a couple points on outcomes. We have studied this backwards and forwards. We are a privately held company, so I'm not going to share a lot of the specific numbers on this, but trust me when I say, data is in the backbone of HEB, and that we have looked at this very intently. In fact, the first few years of when we operationalized our clinics, they didn't get paid. Our clinic team did not get paid unless they recognized savings and they met membership metrics and goals. So we have been watching this and studying it. We feel like we have figured it out, and we are to a place where I can say that we do save money. The partners that go and members that go to the HB Wellness primary care cost less on an annual basis than our other members. This is recognized through that integrated care approach that I said. When they are better managed and we can kind of control that utilization, we see fewer ER visits, we see fewer inpatient visits. And that's where we see those costs come to fruition. So it's been a really great model. So circling back, I wonder if this will work.
Yeah, we're not sure if it'll work or not. If not, we can move to the next slide.
Oh, we had a video. We'll send that out later. It's a really great video. But
Is it a link on the website?
It's a link with, in the PowerPoint? Yes.
Yes, you can find it on the website now,
yeah. The logos to every one of the attendees, because each of these had some great information, and if they just click on it, they can learn a lot about all these organizations. So
Okay.
we'll do that.
Yeah, so I guess the point with the video, though, is not only that we have recognized a lot of savings, we've seen a lot of success with our clinic model, but our partners really, really appreciate it. It's almost like eye-opening. They have never been treated that way when they walk into a physician's office, and now all of a sudden they have a physician who they can call 24/7. Their physician knows if they, God forbid, land in the hospital overnight, and there's a hospitalist in the hospital treating them just like as an extension of their care team out of their primary care clinic. So circling back to the question, why the heck is HEB in healthcare? And really it comes down to a statement that our president of HEB, Craig Boyan, said a long, long time ago, but he feels very strongly that we need to treat Texans like family. We are responsible for the healthcare of Texans because we feed Texans. We are sort of inbred into this DNA of Texas. And so we have taken that to heart, and we feel like it's the right thing to do because people matter. That's our mantra at HEB, and so do Texans. So we are with that, I think I'm going to hand it over to Monica because we've done it well for our partners. We've tested and tried it. And now we're offering it to other businesses because we believe in it so strongly. So I'm going to let Monica take it from here.
So Abby mentioned that we've had a partner health clinic for quite a while. And I think the kind of transition and the point that I want to make and why it could actually be beneficial to you is for almost 8 years, we did not call our clinics anything related to HEB. We actually had a completely different name. And the reason why we did that is we wanted our partners to feel really safe when they came into our clinics and not like Big Brother employer was really monitoring them, which a lot of you know if you're in this space. They don't want you to know these things because they don't want you to make employment decisions. They don't want you to know why they're missing work, all of these things. So we had to build the brand first with our own partner population. And when you have almost 100,000 people in your medical plan, you have some information, you have data, you have a lot of things that you can track. And so it wasn't until the last 1.5 to 2 years that we actually rebranded to HEB Wellness Primary Care. And that is because the company now, from the leadership down, felt confident enough in the product that we were offering not only to our own partners, but now that we can bring to market. And going back to the question that Abby's asked a couple of times, like why healthcare? And she has shared that. Because we actually have a huge investment in people in the state of Texas in our own partner population. And really managing the plan the way that Abby does is extremely significant. I'm going to share with you in a moment what we've seen in some numbers or values related to what we're seeing on the medical plan side. But what I will say is you also have to remember, she already manages a very, very strong plan very tightly. We're not spending money where we don't need to spend money. We're saving where we can so that we can spend where we need to. So when you see these values, it's on a plan that's already highly, highly managed in a very, very strong way. We cut out as much fat as possible so we can take care of our folks. But what we've really done in the extension of the services that we're offering our partners is that we've really connected a lot of the key pieces that we know are super critical to employers. And the reason why I can speak to this as well is prior to being in this role where I'm selling this out to consumers is that I also worked on the benefits team as well. So like Abby, I've sat in your shoes as well, and I understand what some of those expenses are and where you're really seeing the most critical need. And so when we say primary care, people think, okay, people can come in and just see their doctor, urgent care, everyday kind of needs, and that it really is the place where they can go to get generalized care. And that's absolutely the case. But what we've really done is we've extended that, and we've incorporated a piece that really is our value prop, not only to our partners, but also to our external customer, and that is incorporating nutrition services. We have over 50 registered dietitians throughout the state of Texas. And so they can work very closely with our providers, offering our patients, our partners, an extension of care that you can't really find in any other retailer, inclusive of those who are our competitors. You can't find this at Walmart. You can't find this in some of these other brands who are out there doing this. Our RDs are truly retail registered dietitians, or retail dietitians, in that they know our stores really well. They work with our product and merchant teams. They're able to really take a diagnosis from the provider in the clinic and translate that to true action in the store. So somebody comes in, Abby has a partner that comes in to see us. They've just been diagnosed with diabetes. They haven't been managing it. You tell them to eat healthy. What does that mean? Most people don't know. They get a flyer, they walk out the door. What that provider can do, whether it's a nurse practitioner, a board certified DO or MD, or one of our physical therapists who's also providing care, or a mental health specialist, wherever it is that they're providing care, can then refer them over to get this extension of care, all inclusive at no charge. And so the integration of that into our model has been extremely critical and a huge part of where we're seeing a lot of the savings on the plan overall, because it's this integrative approach, and food plays such a huge component to that process. We also offer mental health services, so that really helps to treat so many of the issues and opportunities that we have with our employee populations right now, inclusive of some eating disorders, or people having difficulty with children who aren't, eating well, or so many of the things that have definitely come up through the pandemic. And so we're able to incorporate this. And I want to emphasize that in all of these areas of services that we have board certified professionals. We have registered dietitians, we have DOs, MDs, we have licensed professional counselors that we've also incorporated. And then, as I mentioned, we also offer physical therapy. Abby mentioned a little bit about the diversity of our population. So you're talking about a corporate environment, right? That's a small group of us. And then our workforce that during the pandemic was a critical workforce. Folks who were actually stocking shelves, bagging groceries, working at a cashier desk, or transporting product, a driver, or working in our warehouse and transportation. Many of you may have similar types of employee populations, and they're not seeking care as well as they should. So we have to be really thoughtful in all those areas, because those are the types of things that are costing the plan a significant amount of money. And we know that also translates to other employers in the community. And so we really, our vision for care for our partners is simple. We want to make sure that they have the best experience, that the care is integrated, as I just shared with you. We want to make sure that we have the best quality outcomes, and we want to make sure that we have the best value. For our partner population, they pay nothing to utilize the clinics. They can come in free of charge. Abby is expanding that program so that if you utilize places that we direct you to, you actually can pay less than you would if you don't. So all of those things are super critical. And I share all this with you because as an employer, you can also get these services as well. We are actually selling our excess capacity in our clinics out to other employers in the community. So you don't have to raise your own capital, build your own clinic, figure out how to hire doctors in case anybody wanted to know. It's not easy. It's super complicated. Providers ensure that they're credentialed, insured, and all the other things, right? HEB is taking the responsibility of that because we have built this product for our own population, and now we're extending that out. And just real quickly, I'll share with you, because I know we probably don't have a ton of time and we want to do questions, but the way that we're doing it for our partners that now translate out to our customers and community is really in these three buckets. It's all the services that we offer over on the left-hand side. Primary care, dietitians, as I said, a great team of clinical providers that are also connecting food. We are working with a lot of digital connections where a provider can actually recommend, right, along with one of our dietitians, foods and resources that would be helpful so that a patient doesn't have to think, what does this mean? How do I take action on this diagnosis that I just received? We can help connect the dots with that and literally fill up a basket. So, it's altruistic in us doing this for our own partner population, but we do sell grocery, so I'm gonna be transparent. Obviously, we want you to buy your product from us, so it comes full circle. But if you're shopping with us anyways, which we know you are, here in Houston market, it's about a 42% market share. In San Antonio, over a 70% market share. Your employees are shopping with us. So connect the other pieces to help them do that more healthfully. And I think that's super critical. And then we're also developing a lot of brands. We've done a lot of research around what are folks really looking for. And many people are shopping now or looking for diets or lifestyles that really meet their needs. And so with our partners in mind and ensuring that they understand how to shop, where they need to go, products they can buy, we've developed a whole ecosystem that really allows them to have a lot of resources right at their fingertips. And again, Abby mentioned all these services and how it's connected with our Provider Alliance, so I won't do that. But I do want to share this with you because as I mentioned, Abby manages her plan extremely well, trims out a lot of that fat and the services and things that she doesn't want to spend money on, so she can really invest in taking care of our partners in a really great way. And so this is what we have been able to see from some of the savings and the value for predominantly our partner population. We do have some other employers who already buy our services, but the bulk of our population comes currently from our partners and those that are utilizing our clinics throughout the state. And as you can see, there's some comparison here between the non-utilizer and the utilizer. And it's pretty significant. We're just defining some of the places that we know can be high cost for employers. other folks that were up here were identifying those same areas, and that is length of stay in the hospital. We do have a group of hospitalists that tracks our hospital stay for our partners and any other patients that we have, and we see a 12% reduction in the time that they're staying in the hospital, 36% reduction in the 90-day readmission rate, 7.6% improvement for those that are more adherent to medication related to diabetes, which we all know is a significant problem. And then overall, on that really, really well-managed plan, an additional 14% of savings. So you can do some calculations as well if you know what the national average is for spending on an individual person. Take an additional, you can lower that pretty significantly for how we manage our plan, and then cut off another 14%. So the percentage is actually higher, but this is what we're able to show as far as that savings. And so we have clinics that have now expanded throughout the state. We really focus on opening clinics where our population and our partners are more highly concentrated because they're our priority. And we have been in San Antonio for a long time, but we just actually opened, Chris, 4 new clinics in Houston. So now we have 5 in various areas of the city. We have 4 locations in San Antonio, 2 in Austin, with another one opening in about a month in the Hancock Center in Central. And then we will be going to Corpus Christi and the border very, very quickly after. So we are really trying to get to where all of our partners are. I know that most of you are here from the Houston area, so we have locations geographically throughout the city, because obviously Houston's big and your folks are probably not going to want to travel very far. But what we are able to really do, and what we've been able to do over the last 3 years, is to really take everything that we learned in managing our own clinics and have the ability to expand that and extend that out for other employers to be able to utilize. And we have seen significant benefit to our own population, most specifically during the pandemic. Abby and I took calls personally from partners.
We tracked everyone. Yeah, it was a very challenging time.
It was a very, very challenging time, and we were very grateful to have been on this journey already and didn't even know at that time what it would evolve to. We had dreams, we had hopes of being able to take care of our partners in this way, and now we're super proud of it, enough that we've put our name on the brand. In a very big way, because our brand has a lot of equity and a lot of trust. And so it is something that we can extend to you, but it is something that we have done very passionately for our own partner population.
And I will just say that this is one of our best benefits vendors. So, I mean, what else?
Yes, HEB is our biggest client. We are now a wholly owned subsidiary. So, and they're not easy to manage. They're a tough.
Anyone else who's ever
they're a
managed
tough
HEB
team.
will vouch for that.
That's right.
for
Yeah,
sure.
they're a tough team to manage, but we appreciate the relationship. And it is something that if you're interested in, our information is up here. We'd be happy to talk to you about how you can, have our clinics for your own population.
Have a few questions here. Here we
Sure.
go.
I think, Abby, you're right. The reputation of how HEB cares for its partners precedes itself, and success of some of these initiatives. You had mentioned kind of the specialty care as an expansion plan in 2024. I'm curious, how do you take it from the primary care on-site, and then for those partners or employers, how do you transition from that primary care to potentially specialty care or chronic condition management? What's your strategy there?
So do you mean specifically if another employer utilizes our services? So one of the things that I didn't mention, but it's super critical, is that we do not take insurance for our primary care. Our partners obviously can utilize our clinics at no charge, but if you're an employer who buys in, a customer, someone who comes up off the street, we're completely a cash pay entity. So we would work with the employer, and we have several different payment models that you could pay us for services. And then if we had to refer out after all the services we provided, if you still needed specialty care, then we would work with you to understand your plans and ensure that we were referring people to in-network providers so that they can have that continuity of care. Our integrated care team will still work with them to ensure that we're managing overall the care, but we'll make sure they get to the right folks in those other areas.
So again, it's directly contracted. If this is not through the plan, it's separate. It's
That's
a direct
correct.
contract.
Yes, an employer direct contracts through us.
But to more specifically, I think, answer your question, the specialist network, it's not a network. It's a list of providers that we have validated using our data and analytics team as quality, reasonable cost providers. And we have found that just by referring to those specialists, that saves our plan money in and of itself. And so the clinic is already doing that for us in the markets where they are. And the expansion next year is so that we're going to have a list like that in every single one of our markets. So we're looking for potential savings using that list as well, outside of the clinic.
I think that's probably where you came up with the 36% readmit rate, if I'm understanding correctly. You had a slide up there that showed
Yes.
a 90-day 36% reduction at readmit. So they were admitted, they were not readmitted. I assume that's
Correct.
because you're
Our teams were managing them, our
Care
navigators, our
navigation.
hospitalists,
Yep.
they were very engaged in the care of the patient. So then they weren't readmitted because we knew what was happening with them.
Yeah.
We made sure that they were adhering to their treatment plans when they got out.
Are your partners using these physicians as their primary care physicians?
Yes.
That is their primary
That's the
care
only way they
physician.
can do it. That's the only way you can do it. You can come one time for an urgent case, but after that, you're not going to be able to come back unless you establish care.
Again, the
They're
primary
not
care
required
model.
to. Our partners are not made to utilize
Right.
our clinics. It is an option, but it's a very cost-efficient option for them as well because they pay nothing to see us for all the services, but they do have to designate us as their primary care.
Yeah, you don't have
It's
to
the only way
sell-
you can manage the care properly.
You don't have to sell me on
Yeah.
primary care. That's the
Okay,
future in all its different modalities. That's
Yeah.
where we're heading. We for so long just bypassed the primary care and went direct to specialist, and that's why we have the situation we do.
Or to the
And then-
ER, or to urgent care, or wherever else, right? That's
Well,
right.
yeah.
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 So I get it. Anybody else? 4, 3, 2.
Literally, 1
1.
second.
Wow. You talk about good times.
Thank you.
I'm going to start by saying I know the real healthcare geeks in the room, right? I mean, those of you who've made it through the whole day, I really appreciate it. I'm Ken Yonda. I am a recovering health insurance executive, having worked for 40 years for big health insurance companies, but also been involved in a lot of policy stuff and as well as teaching. And so right now I have 2 jobs. One, I am the founding and managing principal of Wild Blue Health Solutions, Wild Blue, so you remember how to pronounce Yonda correctly. Wild Blue Yonda, not Wild Blue Janda or Jonda, right? So Wild Blue Yonda, but also Wild Blue in terms of we can do different things in healthcare than we think we can. And that kind of taking a risk, doing something differently is what I'm working with a number of folks on. And so I'm working with the Houston Business Coalition on health of this. I also am a faculty at the University of Houston College of Medicine and do population health. And so I was looking at statistics as people were showing about these things, and I'm like, oh, let's see the study about that. And did we do randomized controlled studies and all that kind of fun stuff too? So anyway, that's a little bit about me. Just quick, introduce yourselves too.
I'm Steve Saborin. I'm a health actuary. I've been at a lot of the big consulting firms, and I'm helping do some of the actuarial analysis around the SMART network.
And I'm Sue Prohaska. I'm the former benefits manager at Rice University and was a consultant with Mercer for years, and am passionate about we've got to make healthcare more affordable for our employees so that they get the care they need for themselves and their families. So that's what makes me tick.
So we're going to, oh, they didn't start the clock for us? So
that means we get to go forever.
If I'm talking, you better have a clock, right? So anyway, so what we've been talking about, and as Chris has mentioned, and some of you have heard about it before, because we've been thinking about this for a year or more now, about what we refer to as a smart network. And we now have actually a name for what this is. And what we're thinking about creating and working toward creating is what we're now calling a population health services organization, where we can take all of these point solutions that employers are thinking about and the various things, and how do we bring them together in integrated kind of ways that make sense for employers. And so, but we want to do this not in a for-profit model where some private equity company or venture capitalists to get rich off of this, but instead for employers, by employers, and that's how we want to develop it. So since I had never heard of a population health services organization before, probably most of you have not either. So what we think this is it's going to be a new legal entity that will be created, but will be connected to the Houston Business Coalition on Health, but managed by and for employers. So think of it kind of like a co-op. In fact, it may legally become a co-op as we go forward, but it's employers that are banding together to do a lot of these solutions collectively, offering integrated services, because it's, those of you who've done this, you know it's really hard. Okay, how do I add this new advanced primary care group into my existing PPO plan? Or if I want to do this kind of referral management things, it's complicated to do that. So we want to try to integrate these services in a way that's really help employers, all the way to the point where you could actually take all of the services that we think that we're going to pull together under the PHSO into a comprehensive program that you could like replace some of the companies I used to work for. So, but a couple of key elements of this, we think it's advanced primary care. As Chris said, it's folks like Next Level and HEB and Kelsey-Seybold, those kind of things, a directly contracted provider network. Because we know for individual employers to go out there and contract individually is really hard to do. And so we think we can do that ourselves. And we actually, as someone mentioned, I can't remember, we've heard so many people today, say you can actually go out and if you provide the right value proposition to hospitals and health systems and folks in Houston, you can do that. You can actually get better deals than I used to get when I worked for Aetna or Humana or even Community Health Choice. Well, I'm not sure we can get as good a deal as Community Health Choice because we had the advantage of having a Medicaid contract. So, but spend management capabilities in terms of what are the TPAs that really want to integrate these kinds of things into it, or PBMs or specialty referrals, as well as stop-loss carriers, those kinds of things. So it's really to how can we actually improve the health of your employees while also helping them have a better experience of care, a more integrated experience of care, and reducing costs for you, the healthcare triple aim. So this is kind of like how you would think about it. So if HBCH is the sponsor, we'll have this new entity. We don't have a name for it. Somebody have a name over drinks, come up with a name for it. But that entity would then, so that for the employer that doesn't have to contract with a gazillion different people here, you can contract with and have sort of pre-negotiated, preset, pre-curated deals for advanced primary care, for specialists, hospitals. Well, I'm not going to read you the whole slide. You get the idea. But it's the smart network, the support things that you need for a smart network, as well as the other sort of administrative capabilities. We think that the actual PHSO will basically be in the business of being a contract management firm for other these vendors out there. So that's kind of what it looks like. So some people will ask, well, what is not the PHSO? So it's an entity that's connected to HBCH. There's legal issues. I talked to the lawyers again yesterday about this in terms of, is it a downstream subsidiary? Is it an affiliate? We'll figure that out, right? But what it's not is a profit-oriented to make somebody else money. There's enough middlemen out there already, okay, right now. What this is something that will be of value to employers with the services being provided to them and no us keeping any money, right? So it'll be controlled and directed by employers, for employers. It's not going to be controlled by HBCH. We will have we envision a separate board of directors, a separate group of people to manage this that want to participate. It's a service organization where we house these things. It's not a provider organization where my HEB friends go. We're not going to try to hire doctors and nurses, right? We're going to find other people that are doing that. It's a contracting vehicle. We're not going to be a licensed HMO or a licensed insurance company, but a contracting vehicle for these things. And we're going to be flexible. Because all of the employers that are HBCH members and others are, you're in different places, you have different kind of relationships. We can't do this as a one-size-fits-all. So that's what we're planning on doing. We really think that there's the real capability of doing this and partnering with other people that you heard from today to really do something that's really meaningful and easier for employers to get involved with. I'm going to turn it over to Steve now to talk about his sort of actuarial conservative view of what the potential savings is here.
So we gathered information from another third-party actuarial firm that had data on Houston, and they gave us what they, across the full spectrum of services, what the costs and utilization are for all these different services currently, and what their benchmark said are possible in this marketplace for a very well-managed health plan. And so we developed assumptions only moving from where people are today to that well-managed. 15% to 45% is the range that we were using. And then we also looked at a RAND study that HBCH had done of the member data, of the HBCH member data for around the hospitals, around the utilization and the unit costs for the hospitals here in Houston. And then from the conversations that Ken has been having with the different healthcare providers, and I guess Chris and Ken and the team, of what they thought was achievable in terms of network discount rates relative to Medicare, we then came up with an assumption for where we thought they would get, what the modeling would be on a conservative versus a more aggressive approach. And we came up with the estimate that it's probably going to save somewhere between 15 and 25%. And that includes probably a 15 to 20% increase in like primary care through this direct primary care arrangements where you're actually investing more in the primary care. So that we're thinking that's probably a reasonable range for what this could accomplish with the components that they're building into this.
That's from an actuary, just for the record. So
and by the way, the one thing that I will say is I think beyond just the value of what this health plan can provide, I think since it's going to be run by employers, and you all, as we've heard today and at each one of these meetings, you all have a lot of great innovations. And imagine if you all get around the table and you guys are collaborating around new innovations here in the marketplace. I think there's probably even a greater opportunity to do even more great things here in the marketplace. And really, this is going to be the opportunity that you have to directly interface with and influence the healthcare providers in this marketplace as well.
Yep.
All right. So for employers by employers, we need employers to make this happen. Where we are in the process now is that we are recruiting employers who are interested in this concept to be early adopters of the program. And this is way too short for you to get the whole scoop on what's going on, but I hope we've wetted your whistle and that you may be interested in hearing more. Ken and I would be more than happy to have a phone call with you. Usually they're about an hour and 15 minutes to go through all of the information that you would want to know about what this might look like for you, and we can talk more about what it means to be a founding member, what opportunities that gives you, things like helping us make decisions about what kind of organization is this going to be. Who will our providers be? We'll be doing RFPs to find providers. Who will we select? We, and that's the employers. So contact me or Chris or any of us that you contact. We'll get to the right place for us to set up a phone call, a Zoom call. If you want, we'll come in person. That's up to you. But we'd love to talk with you more.
There's a couple of other people behind the scenes that are working with us on this. Josh Berlin, who some of you may have met from other conferences and stuff, his firm, Rule of Three, has really been great to help us with strategic kind of how we should think about this. Wild Blue Health Solutions at this point is actually 7 of us. It's a relatively small firm, but we have a number of other people that have provider contracting experience, that have worked for health plans, that have done RFPs, that know how to do project management to actually get this done. We'll help get this off the ground until we actually are in a position to hire staff to to make it happen. And of course, we have Steve and his folks that will help us with the actuarial stuff
And
along
I
the
also
way.
want to say Ted and Dan have been
Oh,
very
yes,
integral
yes,
in
yes.
being that
Absolutely.
employer voice through this. They're in
Absolutely
every
true.
single meeting
And-
and really helped you ground in what we should be thinking about from an employer perspective, which I think has really been valuable.
And of course, Sue's experience too, just both being on the employer side as well as on the consulting side is all. So I think we have a team to pull it off. And so now we're at the point.
Go to that slide, the team slide, or?
Oh, well, I sort of skipped over it. Yeah, but.
So that's the core team. We've actually have about a half a dozen employers who have signed letters of intent. We want to get this off the ground in 2025. Again, we don't have contracts with anyone, but we've spoken with a lot of the folks that you've heard today. One of the things that I was encouraged or discouraged, depending on how you look at it, but it takes time to get this. It's not something that happens in a year. And we've been talking about this. We first started with thinking about this through a National Alliance meeting dealing with episodes of care. Think bundled payments. And it's evolved over the last several years to this point. And one of the questions, and didn't raise it, I'm going to raise it, how does this get off the ground? Let's just say that it requires finances, so it's going to require some investment. And I know folks don't like to hear it, but the investment that would be required from the employers is minimal. And I say it's a rounding error in most of your health plans. And the reason it is because we have folks who believe in us. These are philanthropic organizations around the country who said, this is a great idea. We will help you get this off the ground and provide the funding. But what they don't want to do is they're not going to just throw the money at it when they hear the employers complain a lot, but they haven't seen them take those bold steps to make things happen. You heard today from a whole bunch of bold employers who are taking those steps, and we think we can pull this off in Houston. I just wanted to be able to close with this. It wasn't necessarily a setup, but I saw a little space on the agenda, and I said, well, let me see if we can get a couple words in about it. Anybody have any thoughts about this at this particular time? Sound good to some? Yeah? Yeah?
Up there, Chris.
Here he goes.
So about a year ago, I went to a conference, Health Rosetta. Most of you here will probably know about it. And I walked away from the meeting kind of like, wow, there's a lot of people in America that really want to change healthcare. But what's lacking is how. So we walked away from the meeting, and within the space of about 5 months, we met with TPAs, met with PBMs, met with reinsurers, and put a plan design together, started rolling it out. We have a bunch of DPC clinics, and next thing you know, we're getting rated super low from reinsurers. It's become really easy for brokers to sell what we do. Employers love it, and we're basically 3x our membership numbers in the space of about 6 months. So what you guys are doing is awesome. Obviously, we're doing it on a smaller scale. You're going on a bigger scale, but it's definitely worth it. The amount of money people save is insane, and employers will go nuts if it all comes together. So good luck with it.
For those of you that don't know about Dave Chase and his team at Health Rosetta, it's worth the read. What's the primary book? I should know it off the top of my head, but again, as he mentioned, this is being done by those employers that really are impacted, which are smaller employers who don't have the resources to blow. As I say, and I won't name the names, but Malcolm Gladwell, oh God, He goes through, I'm trying to name.
Outliers?
Not like the one before that.
Tipping point?
Tipping point. And on the tipping point, you went from the early adopters to the laggards. And we have some very large .coms as members. I'll say right up front, they're going to be the laggards because they don't need to, they don't have to, but yet they do if they really knew their population and the impact that it's having, even on these large companies with, you look at the folks making $75,000 or less who have medical debt, it's almost everyone. So we think this is a real opportunity.
The one thing that I'll add to that is a comment earlier that you're getting a lot of 90-point plus net promoter scores, and healthcare is generally 20 to 30%. You're paying thousands and thousands of dollars for unsatisfied employees. I remember a quote from the CEO of General Mills when they were saying we got to increase our budget $1 billion. He said, well, could we piss our employees off for any less money? And I think this is an opportunity to say, well, could we actually provide something that'll be truly perceived as a benefit by our employees? Because a low NPS says people don't like what they're getting.
And for employers, by employers, all employers are really about the people. And so this is about the people. This is about the city of Houston. This is about providing high-quality health care at a reasonable cost. What a great idea.
Yeah. So we thank you for sharing that with us. So I asked, as we close up here and walk on over to the Hilton, I wanted our board chair, Ted, who described this as an intimate setting this morning, it's more intimate now, to kind of recapsulize kind of what we heard there. And I wanted also Francois Brant, who I've got to know, and now I'm jealous that he lives in the Dominican Republic half the time, half the year. But Ted is our board chair, again, benefits director, compensation, all that for the Friedkin Group. Francois comes from the employer space. He was an innovator before innovation was cool, back with GE back in the day. Formed a lot of tools that are now still used by health plans. It's just a real thinkers, written, published on this. It's one of those people you want to know in healthcare. I'll just leave it there, and no pressure, but I would like to hear you two wrap this up for us.
I'll let you.
No. You're the chair. You get the.
Am I the chair? Wow. You know, my goal. I'll tell you what. My goal in these situations is to do as little talking as possible, because everybody's had a chance to listen, right? So I'm just going to jump in with audience questions, but. You seem like the kind of guy who's got a lot of interesting things to say, which is why I thought I would let you start.
Well, look, a few things. One, this morning, the session that opened up with Representative Frank and others, and I know, Chris, you mentioned you're going to go around the state with Chris Deacon and try to rally the troops. One thought that popped to my mind, because you mentioned benefit consultants and brokers, and over the past several weeks, my colleagues and I have had an opportunity to meet with a lot of benefit consultants and brokers from what I'd say not the three big houses, but also the three big houses. And I've been really impressed with the way in which they're taking all of this very seriously. And when I say all of this, transparency, the need for employers to own their own data. And I was thinking, that one potential way for Representative Frank to use a little bit of his bully pulpit is, why not a checklist? That all of the brokers and benefit, he could call broker and benefit consultant houses and ask them to do a pledge on transparency. Just like the vendors here, Capital RX and others have pledged for transparency, why not have them pledge to have a checklist for all of the RFIs and RFPs for all carriers or plans and TPAs, that they pledge to fully adhere to the tenets of the legislation. Because it is about the employers asking, but it's really also about the benefit consultants and brokers embedding that in all of their RFPs and RFIs. I'd say the other big takeaway to me was the NPS competition. So congratulations on all of those who've been able to get really high NPS scores. I think it does show that you can deliver in this country really good care, very affordably, and with great satisfaction to the people who get that care. And it's kind of tragic that the current carriers have been unable to do anything even close to that. But it does show that it can be done. And it can be done at scale. I mean, HEB is doing it at scale. Capital RX is doing it at scale. I mean, a lot of these companies are doing this really at scale. But it is a question of how do you assemble all of these components into an offering that employers can easy button. Because that's the key, right? It's how do you get to the easy button solution that gives me all of these things, not in a fragmented way, but in a way that becomes really integrated. And so it's great that the Business Coalition on Health is going through this effort of trying to aggregate these solutions, starting with contracting, because that becomes really the number one most effective tool, and then spreading it as much as possible. So, the company that I represent, we have pledged to use the Smart Network and offer it to the employers who sign up with XO Health, and we have employers in different parts of the country who have employees in Texas, in different parts of Texas. And so we're looking forward to giving those employers and their plan members access to the Smart Network and everything that comes with it, because it works, right? It's affordable care, good quality, with high NPS scores, and it shouldn't be that difficult to give to all Americans.
Awesome. It's good.
Right?
Amazing stuff. Yeah. Well, I'm going to go for some audience.
And I didn't even use any four-letter words.
Oh, well, no. Yeah, no, I didn't count one. Yeah. So you guys, you're the ones who are either dedicated or you weren't sure if you could get a table at the bar before the happy hour started. So, so I asked at the beginning if everybody would make a note of a takeaway. And, usually with conferences, I go, yeah, I got a couple of good nuggets here. And I went through the agenda, and I was able to write down something from everybody's talk. Just
same.
Huge stuff, right? So, well, if you can read my writing, Chris, you're doing better than most people. So let's start. Give me a takeaway from the state of Maine. Anything you got, sir? I'm gonna pick on Hannaford's to start with. Yeah, he's here.
I think the takeaway today is really enlightening. I think we talked about, are we at this tipping point of where? The takeaway is, are we at this tipping point? When are we going to say, as purchasers, enough is enough? And what I heard today is, I think that's really starting to percolate. That everybody was talking about the current status quo is not working. We really need to think about doing this differently. And I find that after battling in the trenches for 30 years, that's encouraging to hear that. Now we just have to do something.
It's interesting you say that, because your presentation with Karen was like an example of building momentum and critical mass to do something on a statewide basis. And Maine is not a small place to get things done. So hats off to both of you. And it gives me sort of like, how can you create that kind of momentum in a state like Texas?
And that example with a lot of the others also showed that you can create the results without having restrictions.
Yeah.
And I think that came out again and again and again in all the presentations, which is the restrictive way in which some employers in the past or some plans have presented options to plan members just doesn't work. But all of these are great examples of how you can effectively move markets by smart incentives and good communication, as opposed to creating kind of a restrictive choice that people just don't like.
Yeah, I want to put Andrea on the spot here. You knew I was going to do that, right? So I know Andrea, and she and Ted and I both serve on the board of directors of the Texas Business Group on Health. Andrea is with the city of Plano, and again, not flush in money what city is these days. So just your take. You asked a lot of great questions today.
So I came to this conference last year because I thought that the topic seemed really interesting, and it was a really great session. I left invigorated, so I wanted to come back. And this year, there was less information on the content, but I felt so pleased with where we're headed in our strategy. And it's nice. It kind of feels like we were kind of on this island heading down this path, and it was nice to see that other people are doing these things and have done them successfully, because a lot of our counterparts are like, what's our one solution for everything? There's not one. So I really took something away from every session too, and thank you guys for being innovative and sharing your examples with us.
Anybody in the
Anybody
back
else
seats?
before I pick on somebody?
No, I'm not. Yeah, there we go. Yeah.
Yeah. So I think what really resonated with me, and I don't know if it was specifically called out, but what the theme I received was culturally sensitive, community driven, and locally delivered. And I think those three things from everyone I've talked to that on an individual level as well as here presenting really are focused on that. And I think especially for healthcare, especially in Texas, right? There's so many different cultures and the diversity that the employers really are up against a challenge to represent when at a national level you can't get access and you're really blocked. And we talk about the digital health ecosystem and all of these solutions, but they're meaningless unless they're connected at the local level as well.
I like the way it was described by L&F. To make a lot of this happen, you need contracting, and we heard all about the direct contracting. You need the navigation, so what organizations like HEB are doing. I mean, they navigate somebody to Karam Health who's going to be working in the Houston market, that navigation, I think, is critical. And then the incentives. Incentives make a difference. And when we were having our actuarial analysis done, it's under the assumption that these savings, as you heard, no co-pays, no co-insurance. Those make a difference. How those savings are shared, will be determined by the employer. And if the employer says, no, I'm going to keep them all and pay my CEO more, well, then it's probably not going to work very well. But then they probably wouldn't be part of this anyway. So as an example, but those incentives make a difference. I'm going to just pick because I've had a couple of good conversations.
Well, and that was also, by the way, a recurring theme across everyone, which is the removal of the barriers to access better care. So the HEB clinics free for all of their partners. The ability at L&F to go and get the surgeries that people need at zero copay, at zero cost. I mean, that was like a recurring theme. And it doesn't have to be punitive. Right? It just doesn't have to be punitive, and so expensive today with deductibles and co-insurance that when you do have an opportunity to, and the third part was not only just no barriers from a financial standpoint, but call Tracy. Yeah. I mean, that to me was key.
Let me tell you what I thought was one of the coolest things with you guys over here at First Stop Health. We're going to give it to everybody. You don't have to be in the plan. It's not part of the plan. Because we're always worried about, well, what do you do with our high deductible people and how are they going to benefit? I thought that was like a stroke of genius. That was pretty amazing. Yeah.
One thing, and you don't have to say anything if you don't want to, but I've had a couple of good conversations with my friend Daniel.
Oh, Daniel's great.
Who's on the consultant side, and I'd be interested just how is what you're hearing today, how do you think that will be perceived? Because the employers are really dependent on their consultants, and if they can't buy into it, it's a real uphill battle. So I'd just be curious, and you don't have to, but if you'd want to share a word. Not to put you on the spot, but.
I think the need for transparency, which was talked about, is crucial. And then I think what relates to all the things we talked about today, the need to use data effectively to be able to measure and prioritize, because you can't do everything at once. So where can we impact the fewest people and the largest number of dollars and go from there? Can help you align those priorities as an organization. And then contracting. So the ability to be really transparent with your vendor contracts and tactical, and where's the money hidden, where's your money going. All of those things are just crucial. And, you know, I'm not going to tell you where I work, so it's not a commercial. But if you're a broker, if your consultant's not doing that, they should be.
They should be.
All right.
There's a friend of mine, Lauren Vella. I don't know how many know Lauren, but Lauren, she's on her own right now, but she was with the formerly the Purchaser Business Group on Health. No, actually now so they represent a lot of large employers, the Home Depots of the world, Walmart, so on and so forth, Boeing, et cetera. And she did a podcast on one of my favorite podcasts. It's called Relentless Health Value. I just think it's one of the best, if not the best, out there. And she said it was why the inertia on employer change in healthcare. And, you know, a list of 5. Everybody has a short list, right? And I just thought all of it was so true. Number one, on the employer side, gosh, why are they going to be responsible for fixing healthcare? You know, why does it fall on them? Yeah. They didn't create it, but yet they own it. A lot of these companies, they own small healthcare companies if you look at how much they spend. So number one, it's tough. You know, why do I have to spend that much time? Ted doesn't just only deal with healthcare. He has 20 other things that he has to be responsible for, and this is just one. The second one is there's very little in-house expertise. The largest company, I used to work with Shell, you know, and it wasn't a large team working on benefits design. So they didn't have a lot of in-house expertise, so what do? Number 2 on our list was over-reliance on consultants. And there's a lot of misaligned incentives in this business. I'll just leave it at that. But I like her way to fix that. He says, find a consultant that has your best interests at heart. I like your idea. I wrote it down about the transparency checklist. I think that's good. Number 3, no good deed goes unpunished. You know, it's easier to just do the same old, well, a 3% increase this year, every one of my peers are doing that. Where's that gotten us over the last 30 years? Impact on your business, impact on employees, impact on their families. So it's tough to take some risk, but you heard about a lot of employers taking risk. Number 4, there's no magic bullet. There's no silver bullet you can say this is going to fix it. It's an accumulation of a lot of different things, and you know that's what we're trying to do with the smart network, taking the best of the best and putting them into something that can be flexible, but really have the same intent at heart. That's number 4. And number 5, I mean, it's maybe the truest. As humans, we don't like change. Not that we're lazy. We're just, you know, it's easier to keep up with the status quo. So I thought it was a good list, and as we went through this today, I was just motivated by those who were able to take that risk and try different things. Some of them work, some of them don't work. I'm sure every one of our companies, everything doesn't work, but we think it's that important.
There seemed to be another theme running around.
What was that?
Direct contracting.
Oh, direct contracting, yes, yeah.
I'm glad you brought that up. There's a group I want to hear from, because I kind of made a list of the most this and the most that. And so the most unexpected information I got was from the lactation network. It was like, what an incredibly important area, so impactful, and I hadn't thought of it. Well, I'm, just a stupid old guy, right? But I want to know what takeaways did you guys have? Because I'm sure your perspective is really different from mine.
I did not. So whoever wants to talk, I'll just drop it and somebody can pick it up.
I think being at so many conferences over the last year and a half, 2 years, the formatting of this conference where you're giving employers a chance to learn from their peers instead of just having a vendor up in front of the room pontificating about how great they are. It's wonderful to learn about new innovative tools, but to hear how they've been implemented, to hear what outcomes have been delivered on behalf of that vendor, and hearing it from a peer as opposed to the vendor itself. I think that's a really cool thing that I've not seen done at any other conference in the last 2 years. So hats off to you for having it structured that way. And thanks again for having us.
You're welcome. My board actually told me we got to have more employer voices here. So I thank my board for that. And this will be the theme going forward. I think I'm trying to think, how can we, it's a long day. So I get that. We've got some thinking to do. Maybe we do 2 half-day conferences or something because it's a long day. And we have happy hours after both of them. So we'll figure that out. But anybody else have a final comment? Otherwise, I know I'm standing between.
Chris, have we heard from anybody on
No,
this side of the
no,
room?
no.
Come on, you guys got to pull your weight here. Let's get a takeaway from this side of the room, the left brain side of the room.
I just wanted to double down on the last comment about how beautifully curated this all seemed. Each one of the sessions back to back, and I feel like it was just a perfect example of, at the very end, how we can all come together and work together to a greater solution. And I feel like something would have been missing if that wasn't there. So I'm very impressed by that and excited about it as well.
I'm going to pick on my new friend from Pfizer, from visiting from Nashville. So.
Okay, well, there was something that stood out to me earlier today, and that was a comment about network providers and the idea of communicating to your employees that you pay more because we pay more. And it's not necessarily, a punishment or trying to narrow choices for that employee. So as we're thinking about all of these novel ways of new healthcare models to do things more cost effectively and still have not only equal quality but better quality than in the past, what type of communication strategies are we using to help the employees understand the decisions that you're making?
I like that. No on the go. I thought that was a good, catchy thing there.
Steve.
Thank you, Steve.
My big takeaway is that the timer really helped. Except it seems to be broken now because we're now after 5:25.
So that's good. I got to tell you, when Steve was sitting up there, he's our actuary. And, Mr. Fact, this is it. And then I look at the 2 things that he has hanging from his badge. Seriously? And then Joker. I just kind of.
Let me tell you why I picked those out.
Okay.
I did that to balance my last name, which is so boring.
All right. Well, I think with that, then let's, if anybody doesn't know how to get there, it's the Hilton. If you didn't stay there, it's just get out of the building here, turn left, and you're at the hotel. And then it's on the 8th floor. It's an open area. I know it's in the shade. 9th? Oh, sorry. Well, that'd be fun. There you go. So ninth floor. It's shaded. I know that, so it won't be near as bad. It's a little breezy. I can't remember if they have the vapor fans or not, but we'll see. Well, that's what you do in August, right? So we'll see you all over there. Thank you all so much for your attention today.
the Dominican Republic.